I would like to invite Dr. Mahesh Kumar sir on the stage to give mementos to our chairperson. Uh, Dr. Ajay Kumar sir, Assistant Professor, PMCH. Thank you, sir. Dr. Shiv Akshit, intensivist from Ranchi. Thank you, sir, for moderating this session. Thank you, Mahesh Kumar sir, for coming on the dais. We'll quickly move on to the next session. Next lecture is an online lecture. Dr. Silora Sahu is going to speak on anesthesiologist's approach to awake craniotomy. We all know how practical it mementos to our chairperson. Yeah, so it's an online lecture and we'll just connect Dr. Silora online and we'll go ahead. Dr. Ajay Kumar sir, Assistant Professor, PMCH. Thank you, sir. Dr. Shiv Akshit, intensivist from Ranchi. Thank you, sir, for moderating this session. Thank you, Mahesh Kumar sir, for coming on the dais. We'll quickly move on to the next session. Next lecture, Dr. Silora Sahu is going to speak on anesthesiologist's approach to awake craniotomy. We all know how practical it mementos to our chairperson. Yeah, so it's an online lecture and
yeah, good morning. I hope I am audible right now.
Dr. Silora, can you hear us? Are you
yeah,
online?
I can hear you, but I can also hear some lecture which is going on somewhere else.
Ma'am, can you click on share screen if you can come online?
Yeah, sure. Wait, I'm just going to share my presentation right now. Is it visible?
It's visible, ma'am.
Okay.
I'll quickly invite our chairpersons for this session. Dr. Kunal Singh, Associate Professor, AIMS Patna. So please come on the dais. Dr. Sukesh Kumar, Assistant Professor, PMCH. With our chairperson's kind permission, may I request Dr. Silora Sahu to begin the session?
I hope my presentation is visible right now.
Your presentation is visible, ma'am.
Okay. A very good morning to our esteemed delegates, ladies and gentlemen. At the outset, I would like to thank the organizers for this topic, which has always fascinated a lot of people. In fact, performing an awake craniotomy solo used to be one of the criteria to test our training in our neuroanesthesia residency days. So it is always very close to our heart. Now, very recently, the social media was abuzz with a video of a person who was playing a piano while playing a guitar while the neurosurgeons were operating on him. And this has fascinated a lot of people. But in fact, awake craniotomy is not something which is very new. In fact, in ancient times also, trephination was done not only in the European or Western world, but also in India. But it was Sir Victor Horsley who performed the first modern awake craniotomies for epilepsy surgery back in 1886. But the main limelight of awake craniotomy came after Penfield, who developed a new surgical approach known as the Montreal procedure, where he removed the skull cap to expose brain tissue and probe different areas of the brain while the patient was awake and interacted with him. Later on, the concept of neural analgesia came, focusing on ameliorating the stress and pain produced during surgery. So, awake craniotomy started evolving this way and is now considered the gold standard procedure for tumor resection in eloquent areas of the brain. Now, the concept or the main basis of awake craniotomy is founded on the concept of eloquent areas of the brain. These are those parts of the brain which are associated with sensory, motor, speech, visual, and other important functions. So the main idea is to resect as much of the tumor tissue as possible, making all attempts to preserve cortical function. And as they say always in neurosurgery, an awake patient is the best neurological monitor. Although awake craniotomy has been traditionally used for over a century for epilepsy surgery, the most common surgical indication for awake craniotomy is resection of tumor adjacent to the eloquent areas of the brain. It is also used for stereotactic surgery and deep brain stimulation surgery for Parkinsonism disease and other central movement disorders. The other indications include interventional pain procedures such as pallidotomy and thalamotomy. Awake craniotomy has been instrumental in intraoperative cortical mapping for lesions close to the eloquent areas of the brain. The most common surgical indication for awake and for localization of epileptic foci during intraoperative electrocorticogram or ECOG, as we say that. Now, what is brain mapping? It was originally used for epileptic surgery and is now utilized for tumor resection. And over the last 2 decades, it has gained more popularity. It basically helps in identifying the regions of language representation and motor cortex or the eloquent areas of the brain. And thus, it helps to distinguish between the eloquent cortex and the tumor tissue, which in turn facilitates accessing the tumor from the safest transcortical route as well as aggressive tumor resection while preserving functional tissue. Now, most important benefit of awake craniotomy is that it allows the neurosurgeon to maximize tumor resection while preserving the neurological function. The patients undergoing craniotomy have fewer neurological deficits and a reduced need of postoperative ICU monitoring and a short hospital stay as compared to the patients who have undergone general anesthesia. Those undergoing awake craniotomy under sedation do not need general anesthesia and avoid the risk inherent to GA, like intubation and mechanical ventilation. And in fact, post-op pain, nausea, and vomiting is also reduced in awake craniotomy. As with all surgical procedures or with anesthesia techniques, there are certain contraindications for awake craniotomy as well. Basically, a well-motivated, mature patient who can tolerate lying still for several hours and is cooperative during testing are the best candidates for awake craniotomy. So any patient who is not able to do that is a contraindication for awake craniotomy. Besides that, anticipated difficult intubation is an anesthetic contraindication. And the other relative contraindications include high vascular lesions with significant dural involvement, which might lead to intraoperative blood loss and hemodynamic disturbances, or significant blood loss, that is. Low occipital lobe lesions, which are difficult to access, and the positioning is also difficult. So it makes a patient uncomfortable during the procedure. Plus, the risk of venous air embolism is more in these kind of lesions. And patients with obesity and obstructive sleep apnea, because this in turn leads to respiratory depression or obstruction, leading to hypercarbia and hypoxia, and may need conversion to general anesthesia. And not to mention the medical conditions, which may be preventing the patient to lie down for several hours. Now, coming to the role of anesthesiologists. Besides maintaining the hemodynamic parameters in the perioperative period, we also focus on analgesia, local anesthesia, and sedation. And this begins with the preoperative phase. The most important, or the point of paramount importance in performing a successful awake craniotomy is patient selection. Because a well-motivated, psychologically motivated patient who understands everything and is willing to respond to commands and cooperate during the surgery is the most important factor. So patient selection is very important. And it is very important to establish rapport with the patient. For this, there might be requirement of multiple visits to establish communication and to win the confidence of the patient. Besides, we have to explain the procedure to the patient and reassure him or her about the entire procedure and the safety required. So it is basically a team approach between the anesthesiologist, neurosurgeon, and neurophysician who combinedly take care of this aspect. Patients are instructed about the testing process. For example, if the patient is undergoing awake craniotomy in the motor or sensory cortex area, then we might need to neurologically monitor clinically also in the intraoperative period. So we will be showing a few flashcards or other photos for visual and cortical functions, as well as asking the patient to perform simple motor activities. So explaining them beforehand helps in the intraoperative period while we expect the patient to cooperate with us. The patient is also made aware of the fact that he or she may experience transient deficits during the testing. There might be pain during local anesthetic injection. There could be loud noises in the operation theater, like while the burhole is performed, and the alarms can be distressing to the patient. And there can be episodes of nausea and vomiting, for which we'll take preventive action. Now, coming to the considerations during awake craniotomy. The preoperative considerations include an examination of the upper airways for any prediction of difficult intubation or obstructive apnea risk. Patients who are on epilepsy, they have to be, the history has to be taken regarding the type and frequency of seizures, the pharmacotherapy that they are receiving, and the preoperative serum dose of anti-epileptic agents. Patients on nausea, vomiting, the patients who are having nausea, vomiting, the intensity has to be seen, because if it is very severe, then they are not good candidates for awake craniotomy, plus the medications that the patients are receiving. Then there is estimation of the intracranial pressure, the type of lesion, the radiological and clinical signs, the hemorrhage risk that the patient might have because of the localization of the tumor or any antiplatelet therapy that the patient might be on, so we need a medical history. And the most important factor, which I have discussed earlier, is the level of anxiety and cooperation of the patient, the amount of pain that we expect the patient to tolerate, and if there are any neurological deficits. So based on these considerations, the anesthetic goals include maintaining patient cooperation by optimal analgesia, adequate sedation and anxiolysis during the different stages of awake craniotomy, giving a comfortable position to the patient. So many a times when the patient is done under awake craniotomy and is fully awake during the entire procedure, we ask the patient that whether it is a comfortable position or not, and adjust accordingly. All the while maintaining safe airway and adequate ventilation, hemodynamic stability, normal intracranial pressure as much as feasible. And if the patient is undergoing awake craniotomy for epilepsy surgery, then we have to see that we do not use anesthetic agents that might result in interference in the electrophysiological recordings. And of course, prevention of nausea, vomiting, and seizures. The intraoperative monitoring includes the standard ASA monitors that we use in all the patients. And besides this, monitoring depth of anesthesia by EEG related parameters, and neuromonitoring, which includes assessment of vision, speech, power, and memory. The anesthesia techniques mainly are grouped into three categories. One is the monitored anesthesia tray. The second is the asleep, awake, asleep, or a variant of which of it is asleep, awake, and then the fully awake technique. Now, before moving on to the individual anesthesia techniques, let me highlight the points at which the patient is going to experience most pain. So it might, if the patient is undergoing GA, then laryngoscopy is obviously one of the intense stimuli. But if the patient is under awake craniotomy without general anesthesia, then the surgical points at which there might be much pain is pin insertion, scalp incision, periosteum elevation, burhole, and dural incision. Beyond this, the patient does not experience pain due to any procedure because the internal structures of the brain are not sensitive to pain. So coming to the technique of asleep, awake, asleep. In this technique, the patient is mostly under general anesthesia, and in the intermediate period in between in the surgery, the patient is awakened for neurological assessment or mapping. So patient gets general anesthesia before and after mapping and assessment with involvement of an airway device at the start and end of the procedure. There are three phases in this. The first is general anesthesia and controlled ventilation. The second phase is when the anesthetics are discontinued, spontaneous ventilation is allowed, and the patient is made awake for functional and electrophysiological testing. And the third is we will revert back to general anesthesia in the similar fashion as described in the first phase. The sleep awake variant of this technique involves only the first and second phase. Once the patient is awake, then we do not give general anesthesia to the patient again. To secure the airway, both endotracheal intubation and supraglottic airway devices have been used in awake craniotomy in this technique. But generally, it is found that the tolerance to the device is better with supraglottic airway devices, because in the endotracheal tube may lead to puffing and bucking during extubation, and it is very difficult to reinstall the endotracheal tube if we go for a sleep awake asleep technique. And since the patient has to be awakened in the intraoperative period for assessment, neurological assessment and neurophysiological monitoring, the choice of anesthetic agents should be such that they are very short acting. So we have to take care of that. Now coming to monitored anesthesia care. In this technique, the anesthetist administers sedatives, analgesics and hypnotics, addresses any clinical problems that may arise, and provides the patient with psychological support during therapeutic and diagnostic procedures. The analgesia is taken care with scalp block as well as local anesthetic infiltration of skin periosteal layer of cranium and the dura mater as the surgeon conducts the surgery. Now coming to the fully awake technique. In this, we avoid the use of sedatives and use opioids very sparingly. And it is very important to have proper counseling and psycho support, because patient cooperation is of paramount importance. The patient is positioned as best as and is most comfortable to the patient, and the pain of pin fixation and craniotomy is ameliorated by using scalp blocks and local infiltration. Scalp blocks forms an important part in these two techniques. Although initially asleep awake asleep was more prevalent, nowadays it has shifted towards a more favorable fully awake technique. So scalp block becomes very important, and this is a procedure in which the nerves, there are 7 nerves which supply the scalp, they are blocked in scalp block. So these nerves include the supraorbital, supratrochlear nerve, the zygomatico-temporal nerve, the auriculotemporal, lesser occipital, greater occipital, and greater auricular nerve. So what we do is we give an infiltration of 1 or 2 ml at the supratrochlear, at the supraorbital foramen, this notch, and this is the point where you give the injection to block the supraorbital and supratrochlear nerves. At the temple, as you can see in the second picture, the depression at the temple, that is the site for infiltration to block the zygomatico-temporal nerve. And for auriculotemporal nerve, we just go 1 finger breadth ahead in front of the tragus or anterior to the tragus and give the block over the zygomatic arch. We have to take care that the infiltration of drug is given over the zygomatic arch, because if we give it under the zygomatic arch, there are more chances of facial nerve injury. And then the posterior part of lesser occipital and greater occipital nerves, these are blocked by giving drug infiltration at the mastoid prominence and then infiltrating almost like a field block up to the occipital protuberance. We have to take care during the procedure that the total local anesthetic that the patient is receiving does not exceed the dose that is permitted for that patient, because the surgeon is also going to infiltrate the surgical site. Both only bupivacaine can be used, or we have found better results with lignocaine and bupivacaine in a combination. Now, in this picture, you can see that the patient is on skull pins. So pin insertion is a very intense stimulus. And usually what we do is that just before the pin is being inserted, we give local infiltration of 1 ml or half ml, very small amount at the sites, exact sites where the pin will be inserted. So that takes care of the pin insertion pain that the patient has. We have to be very careful during maintaining the sedation, because if the patient is over sedated, the patient might become uncooperative and there might be respiratory depression. And if the patient is under sedated, it can lead to unstable hemodynamics and the patient may become agitated and uncomfortable. The intraoperative hemodynamic parameters are controlled as best as possible to reduce bleeding, to have a lax brain, get a better hemostasis, and prevent any intracranial hemorrhage. Meta-analysis and systematic review then recently revealed that although sleep awake, sleep and MAC techniques were feasible and safe, there was limited data regarding the fully awake techniques and larger RCTs were required. But over the next few years, awake craniotomy or the fully awake technique has gained more prominence now. Besides the neurophysiological monitoring that we use intraoperatively for like visual evoked potentials for the occipital lobe, we also use very commonly these flashcards. These are very simple flashcards which we get in kids' toys section, and we show these flashcards to the patient before the surgery, and during the surgery, we ask them to identify what they see. So that gives us an estimate about the visual as well as the cortical functions. And in this video, as you can see, awake craniotomy is being performed. The surgeon is operating on the brain here, and the patient will be awake on the other side. See, the flashcards are there, having simple.
हाथ फड़ो,
The patient is being asked to
छोड़ो,
important
छोड़ो बोलना पड़ रहा है। जीभ बाहर निकालो, जीभ बाहर निकालना, अंदर कर लो, बस बस, शाबाश, हाँ पैर चला दो, पैर चलाओ, पैर की उंगलियाँ, सीधी करो, हाँ, बस शाबाश, बस।
Although we focus on the site of the surgery, like if the right side area is being operated upon, then the left side motor functions we assess. But bilateral usually we do so that we can compare if there is any deficit or any change in the motor parameters. As with all techniques, there are certain complications which are associated with this technique. It might be anesthesia related, like airway obstruction, desaturation, hypoxia, and which require conversion to GA. Or they can be hemodynamic disturbances, nausea, vomiting, and shivering, local anesthetic toxicity, pain, poor coordination because of the neurological factors, or agitation and restlessness. Or the complications might be surgery related, like focal or generalized seizures, aphasia, bleeding, neurological deficit, brain swelling, various air embolism, or electrolyte imbalances. The most dreaded complication during awake craniotomy is intraoperative seizures. It has an incidence of around 2 to 20% in awake craniotomy. These seizures are most commonly during stimulation of the brain mapping. Many intraoperative seizures are either focal or brief and short limited, and they resolve spontaneously, whereas some are generalized. And this is what is going to cause a problem. Patients with history of seizure, who are patients who are younger in age, and if the lesion is in the frontal lobe, are more susceptible to have intraoperative seizures. So in these patients, we have to be more careful about the perioperative anti-epileptic drug management. And in case any seizure activity is noted, then we might have to give IV drugs like propofol, midazolam, or cold saline. The first step is to install cold saline or ice cold saline at the site of surgery. And if it does not respond to that, then we give the medications. The airway complications include hypercarbia and respiratory as a effect of respiratory depression, and there might be desaturation. Now, these are catastrophic in the sense that they may lead to a significant tense brain or raised in intracranial pressure and brain bulge. So how can we prevent that is by proper selection of the patient and using airway adjuncts in the patients in which we think they are necessary. Now coming to the post-operative part, after the surgery, the patient is usually transferred to a high dependency unit or ICU. Pain management can be achieved by multimodal analgesia techniques, utilizing regional anesthesia techniques, paracetamol, small doses of opioids intravenously, and including patient-controlled analgesia. Post-analgesic requirements and the incidence of nausea, vomiting are lower in awake craniotomy than craniotomy under general anesthesia. But the assessment of neurological status and the monitoring has to be done like any other craniotomy. And of course, continuing the anti-epileptic drug in the post-operative period also. So basically, to summarize, the procedure that we follow is that the pre-operative part consists of pre-anesthetic checkup, establishing rapport with the patient, communication, reassurance, and pre-medication. Once the patient comes into the operating room, the patient is all the standard monitors are attached, and the special monitors which are required. We have to establish the IV access and monitoring with invasive monitoring that is required, and we sedate the patient, giving analgesia, local anesthesia, and position the patient as best as possible. During the intraoperative period, we have to take care of the oxygenation, hemodynamic stability, the laxity of the brain, to continue with the monitoring which is required intraoperatively, and be prepared for early awakening. And so for that, we use short-acting anesthetic agents. We have to be ready for the complications that are anticipated in the particular patient and prevent complications as much as possible, and be alert in managing the complications if they arise. And there should be provision to readily convert to general anesthesia immediately as required. And the post-operative care includes the care as is expected from any neurosurgical patients, including monitoring, analgesia, and positioning. So the take-home messages are that proper selection of patient is of paramount importance in performing a successful awake craniotomy, and a good rapport with the patient is very important in this aspect. Adequate analgesia is important so that the patient does not have any stress during the perioperative period. The correct method of examination of the areas involved has to be done, and an alert anesthesia or anesthesiologist is important, who is aware of the complications that can arise in the intraoperative period and is ready to manage them. A good post-operative analgesia and follow-up of patients till discharge completes the entire procedure in a successful manner. Thank you.
Thank you, ma'am, for deliberating such a beautiful lecture on awake craniotomy and an aesthetic concern. You have really given an insight about what are the advantages, disadvantages, and what are the latest coming into this awake craniotomy. And if we could take, as we are running short of time, we could take only 1 or 2 questions if anybody wants to ask from the audience. So if you may allow, madam, may I ask, I have one query that the modalities like intraoperative MRI is coming up. So can it replace the awake craniotomy? And what is your opinion about the use of dexmedetomidine in awake craniotomies?
Yes, sure. I'll first address the second question that you asked, because that is more relevant and more commonly practiced, which we are practicing right now. We might not be having access to awake craniotomy for tumor resection right now, but dexmedetomidine is invariably a very good drug, and it has significantly changed the perioperative management during awake craniotomy, because it does not lead to any respiratory depression. The patient is fully arousable, and and it reduces the requirement of other anesthetic agents significantly. The only drawback is that it may lead to hypotension and bradycardia, and bradycardia is an important feature to be monitored in neurosurgical practice. But if we avoid the loading dose of dexmedetomidine and instead start with the maintenance dose only, then the results are very much better as compared to if we give the loading dose, because the side effects are not pronounced with the maintenance dose only. So what we usually do is that when we receive the patient in the operating theater and attach the monitors, we start the dexmed infusion and then go on to give the scalp block. By the time you have started to give the scalp block, the patient is already on dexmed infusion and sedated quite satisfactorily. So dexmed is perhaps is very revolutionizing, I must say, for awake craniotomy procedures. And regarding the intraoperative MRI, yes, that may reduce the requirement of awake craniotomy, but it cannot abolish the entire requirement of awake craniotomy, because MRI as such is a very bulky structure. If you have seen the intraoperative MRI apparatus, it is very huge and not easily accessible to a lot of centers also for intraoperative mapping, as you may say. So in that respect, brain mapping or awake craniotomy still continues to be a better choice.
Thank you so much. Thank you, ma'am. And now I hand over to Dr. Weber for further.
Thank you, Dr. Silora, for this wonderful session.
Thank you so much.
While we regret that you're not here with us physically, we would like to courier you probably your memento. But thanking you from the deepest part of our hearts and deepest gratitude to you for this wonderful presentation. I would now request Dr. Hemant Kumar Jha, Professor, Nalanda Medical College Hospital, and Treasurer ISA Patna branch. Sir, kindly come on the dais and present mementos to our chairperson. Dr. Kunal Singh, our chairperson from AIMS Patna, associate professor. Sir, please. Dr. Sukesh from PMCH, assistant professor. Thank you, sir. Thank you, sir. Now we move to the next session. Next, we have fluid therapy in ICU by Dr. Shivakshat. I'll kindly request sir to come on the dais. I would also like to invite the chairperson for this session, Dr. P.K. Gyani sir from Betia. So please come on the stage. Dr. Mahesh Prasad from Bhagalpur. Sir, may I request your presence on the dais? Let me take this opportunity to introduce our speaker. Dr. Shivakshat is a consultant critical care medicine. He's presently working in Paris Hospital, Ranchi, and he has completed his DM critical care medicine from AIMS, New Delhi. His core area of interest, as is already evident, is critical care, and he'll be talking on fluid therapy in ICU. Sir, over to you.
So very good morning to all the gathered delegates, and with the permission of the chairpersons, I'd like to start this session. The topic of this session, as you're aware, is fluid therapy in ICU. Now, fluid therapy is perhaps the most ubiquitous intervention in clinical practice. The history of this dates back to the year 1832, when a pioneering Scottish physician first used intravenous saline for replenishing the intravascular volume in patients with cholera, and found some very useful results. Subsequently, in the year 1852, fluids was reclassified into colloids and crystalloids by a British chemist, Thomas Graham, who is also known as father of colloid chemistry. But in spite of such a long-standing history of use of this intervention, surprisingly, there is very little consensus regarding optimal fluid therapy for various clinical disorders. What we do know is that fluid therapy is like a double-edged sword. While appropriate fluid therapy is not only useful but in life-saving in certain situations, but if used inappropriately, they can cause a wide variety of adverse effects affecting almost all the systems of our body, chiefly the respiratory system, renal system, and GI system. To avoid this, what we need is to treat fluids like drugs, and to practice fluid stewardship analogous to antibiotics stewardship with respect to the type of fluid used, the volume which needs to be infused, the duration of fluids, as well as appropriate de-recruitment when the hemodynamic goals have been met. Coming to the type of fluids which is available in clinical practice, fluids can be classified into crystalloids and colloids. Colloids are large molecular weight compounds which are dispersed in a insoluble medium. They can be either natural colloids like albumin, or synthetic colloids like hydroxyethyl starch. Now, most commonly used colloids are isotonic or hyperoncotic albumin, or various hydroxyethyl starches. Other colloids mainly of historical importance would be gelatins and dextrains. Now, these colloids are has various risk benefit profiles. Now, coming to first albumin, which is the most important determinant of oncotic property of human plasma, contributing to about 80% of tonicity of human plasma. It is basically a single polypeptide chain, a monodispersible colloid of molecular weight of around 66.5 kilodalton. It is synthesized in liver and is subsequently secreted in vascular compartment and exchanged between intra and extravascular compartment with help of a transporter called alpondine. Besides being a main determinant of tonicity, it also has diverse functions like binding agents to various endogenous chemicals and drugs. It is a important plasma buffer. It has antioxidant properties, and it is a useful as a in metabolism of lipids and eicosanoids. And as you will be well aware, albumin is costlier than other resuscitation fluid. The reason being is that it needs to be prepared from multiple plasma donors and rendered to be free from transmissible diseases, including prion diseases, by first alcoholic precipitation and pasteurization for at least 10 hours. So if we have to justify the use of albumin as a resuscitation fluid, we need to have convincing evidence that this is actually beneficial vis-a-vis the other intravenous fluids. Surprisingly, there is no such convincing data. In fact, the earlier meta-analysis done in the later half of the last centuries, especially a Cochrane review, showed that albumin use was associated with increase in mortality. Although this study had many methodological flaws, to answer this question, into year 2004, a SAFE study, a study was conducted by SAFE study group, which made a head-to-head comparison between albumin and normal saline for resuscitation in critically ill patients. And although this study found that albumin is safe, but they were not able to demonstrate any mortality benefit with use of 4% albumin. And in fact, in a subgroup analysis, they found that use of 4% albumin in patients with severe traumatic head injury was associated with increase in mortality. And in patient with sepsis, the use of 4% albumin did show some trends towards improving mortality, but this did not attain statistical significance, probably because of underpowered nature of the study. To resolve this issue, another study was conducted later by Albios group, which again showed compared 20% albumin with crystalloids. And again, in this study also, there was no mortality benefit, although there was some hemodynamic benefit, which was statistically significant, but it did not have any significant clinical benefit. So the consensus regarding albumin today is that it can be used as second-line resuscitation fluid after the patient has received adequate amounts of crystalloids in patients with sepsis, as well as in polytrauma patients who do not have severe head injuries. But it has to be used only after adequate amount of crystalloids have been given. The other specific indications where albumin needs to be given would be probably patient undergoing high volume paracentesis to prevent occurrence of paracentesis induced circulatory disturbance, and in patients of hepatorenal syndrome in conjunction with vasopressors like terlipressin. Now, coming to the next commonly used colloid, hydroxyethyl starch. Now, it is basically, it can be iso-oncotic or hyper-oncotic. And it is basically classified into first, second, and third generation on basis of their molecular weight or molar substitution. Molar substitution is the number of carbon atoms of the glucose monomer where the hydroxyl group has been replaced by hydroxyethyl group. Because of this replacement, the earlier colloids tended to remain in the vascular compartment for a longer period of time, but with this apparent benefit came the trade-off that these tended to accumulate in the reticuloendothelial cells, kidney, skin, and other tissues, leading to some unacceptable adverse effects. And these compounds had also had higher C2 by C6 ratio. So they tended to cause coagulopathy, acute kidney injury by osmotic nephrosis, and they had higher incidence of anaphylactoid reaction and pruritus. So to obviate these adverse effects, next generation of colloids of hydroxyethyl starch were developed, which had lower molecular weights or molar substitutions. But again, when head-to-head comparisons were made with a normal saline in resuscitation fluids, even these were not found to be effective in a study by chest study group. They were found to be as efficacious as saline as far as 90-day mortality was concerned, but patient resuscitated with hydroxyethyl starch needed more incidence of renal replacement therapy. Now, when in patients with sepsis, when the famous Scandinavian study group conducted the landmark success trial, the disadvantages were even more stark. Not only the patients resuscitated with colloids required more episodes of renal replacement therapy, but in this case, there was significantly more mortality, around 20% more mortality in hydroxyethyl starch group. Now, these studies, as well as the subsequent another meta-analysis by Qureshi et al., have amply demonstrated that hydroxyethyl starch is not a good choice as a resuscitation fluid when in a critically ill patients. Almost all the regulatory authorities like US FDA and or European medication regulation authorities have proscribed the use of hydroxyethyl starch in critically ill patients, and also the other guidelines like surviving sepsis guidelines, they have all cautioned against the use of hydroxyethyl starches, so they are basically out now. Other colloids are mainly of academic discussion. There is not much data regarding their safety and side effect profile. Dextrains, are, as you will be knowing, is available in two formulations. The Macrodex is the Dextrain 70 is mostly used as resuscitation fluids, and the Dextrain 40 is mainly used to improve the rheological properties of microcirculation. Sometimes it is used in vascular surgeries, but as a resuscitation fluid, it is has become obsolete now, especially because of its tendency to cause acute kidney injury. Similarly, gelatins, hemaxil, gelfusin, they are still used in some places, but again, there's not much backed by objective evidence in the literature. Now coming to crystalloids, they are undoubtedly the first line resuscitation fluids, and the commonly used crystalloids would be normal saline, ringer lactate, other balanced salt solutions like sterofundin or plasma light, and the dextrose containing fluid. Now, dextrose containing fluids are ineffective plasma expanders because of their tendency to go inside intracellular compartments. So if you give actually 1 liter of for example, 5% dextrose, only about 80 ml would remain in the intravascular compartment. So not much used as a volume expander. Among other crystalloids, normal saline has some disadvantages, theoretical disadvantages, because of its unphysiologically high chloride content and absence of other cations in comparison to human plasma and other crystalloid. So theoretical risk is associated with use of especially high volume of normal saline in resuscitation. These would include hyperchloremic metabolic acidosis leading to other complications like hyperkalemia. It can also cause acute injury, acute kidney injury because of decreasing the renal cortical blood flow by causing vasoconstriction of renal arteries. And it is also there are some animal studies which shows that they cause increase in inflammatory cytokines like IL-6 levels. Whether these theoretical risks translate into some clinical disadvantages is not known. Now, most studies which have been against normal salines are mainly very small sample size studies or observational studies. The one by Yunus et al. That is notable, which had a significant number of patients, around 105, and it was a before and after studies which did show that there was a decrease in AKI when normal saline was replaced with balanced crystalloids. This was tried to be investigated in 3 large studies. The first to be conducted was the split trial, which was conducted in New Zealand. This did not show any advantage of balanced crystalloids over normal saline, but this study had the disadvantage that it mainly included the post-op patient of elective surgeries who were less sicker. The median Apache score was around 14, so they were not really representative of critically ill patients. Also, other largest studies like the 2 sister studies, salted study conducted in non-critically ill patients and smart study conducted in critically ill patients, did show that use of normal saline caused a greater incidence of adverse kidney events at 30 days. So although the data is not very robust against normal saline, and it is still acceptable resuscitation fluids, what we can conclude is crystalloids are undoubtedly the first line resuscitation fluids. Both normal saline and balanced salt solutions are acceptable, probably with certain advantages with balanced salt solutions. Albumin may be used in specific indications if we keep the relevant caveats in mind. And but hydroxyethyl starches and other colloids, synthetic colloids, are definitely out as far as resuscitation is concerned. Now, coming to volume of fluids used in resuscitation, it was already covered yesterday in the session regarding hemodynamic monitoring. What I would like to emphasize that fluid therapy is like a double-edged knife. Both inadequate volume depletion and volume overload is associated with significant problems causing morbidity and even mortality in patients. So we need to have other tools for assessing the volume status and fluid responsiveness. Many statics and dynamic parameters are available to us. They have their own advantages and disadvantages. One needs to be aware both of the advantages of specific parameters as well as the clinical condition and phase of illness before choosing an appropriate parameters and formulating a fluid strategy. Also, you need to be aware of the phase of illness. For example, in early phase, the resuscitation fluid phase, early adequate fluid management should be given to prevent some symptoms and signs associated with hypoperfusion. Later, it has to be changed into late conservative fluid management guided by dynamic indices to prevent development of polycompartment syndrome and global increased permeability syndrome, and then finally switched over probably around 72 hours after the initial insult to deresuscitation phase to both simultaneously prevent the disadvantages of fluid overload as well as excessive fluid removal. What we can say definitely is that most commonly used parameters for fluid responsiveness, the CVP, is basically not much useful. In a study conducted, the correlation coefficient between CVP and the improvement in cardiac index was very poor. So probably CVP should not be used, and the dynamic indices should be used. A pragmatic plan would be to look for obvious signs of fluid loss or blood loss in a patient with signs of hypoperfusion, and if they are present, we can directly go for volume expansion. In absence of such obvious signs, we should first look for dynamic parameters of fluid responsiveness according to the clinical condition of the patient and available resources, and then subsequently in deciding whether and the volume of fluids that needs to be given. Thank you.
Dr. Siu has given a very nice presentation over fluid management in ICU patients. Now the session is open for discussion or any questions from audience. No question. ये कॉन्वेंशनल नहीं है कि हम चेयर करें और हम क्वेश्चन पूछे डॉक्टर सिंह से, लेकिन हमारे सारे जितने कलीग्स हैं उनके बिहाफ पे मैं कुछ बातें पूछना चाहता हूँ।
जी सर।
अब कोलोइड के बारे में बताया कि इट शुड बी अवॉइडेड। क्रिस्टलोइड के बारे में कोई माने वैसा कोई लाइन नहीं मिला जिसको हम एडवोकेट कर सके। एक पेशेंट है डायबिटिक कीटोएसिडोसिस का, जिसका पीएच है 6.7 और 6.8, और नॉर्मल सलाइन देने के लिए एडवोकेट हम लोग करते हैं। नॉर्मल सलाइन का भी पीएच होता है 6 के अराउंड,
तो और कम होता है सर, और कम होता है 4.5 के अराउंड होता है।
तो इज इट rational to administer normal saline patients in patients with diabetic ketoacidosis?
सर अभी जितना जो अभी और जो स्टडीज आ रहा है वो बेसिकली इज मोर इन फेवर ऑफ बैलेंस सॉल्यूशंस इन प्रेफरेंस टू नॉर्मल सलाइन। नॉर्मल सलाइन का जो इंट्रिंसिक पीएच होता है उसके साथ जो उसके साथ जो और प्रॉब्लम एसोसिएटेड होता है कि जो स्ट्रॉन्ग आयन डिफरेंस होता है उसका 0 होता है। तो अगर हम लार्ज वॉल्यूम ये देंगे तो जो स्टुअर्ट्स अप्रोच से देखेंगे तो वो प्लाज्मा का भी स्ट्रॉन्ग आयन डिफरेंस कम करेगा और वो और ज्यादा एसिडोसिस कराएगा। तो जो रिस्क जो ये था जो हम लोग एक करते थे स्पेशली रिंगर लैक्टेट से कि वो लैक्टेट का लेवल्स बढ़ाता है, बट अगर लिवर फंक्शन इवन पार्शियली प्रेजेंट है तो लैक्टेट का लेवल बढ़ता नहीं है। और बहुत सारा भी स्टडी हुआ है जिसमें जो बैलेंस सॉल्ट सॉल्यूशन को कंपेयर किया गया नॉर्मल सलाइन से डीके में, और देखा गया है कि वो सुपीरियर है इन कंपैरिजन टू, ऑल्दो अगर उसमें भी मोर्टेलिटी बेनिफिट उसमें भी नहीं मिला, लेकिन जो बायोकेमिकल पैरामीटर्स है वो बेटर रहता है इन बैलेंस सॉल्ट सॉल्यूशन इन कंपैरिजन टू नॉर्मल सलाइन। स्पेशली सरप्राइजिंगली अगर सलाइन का यूज से ये देखा गया कि हाइपरकैलेमिया और ज्यादा हो जाता है, उसमें बिल्कुल पोटेशियम नहीं होता, बट बिकॉज एसिडोसिस के कारण वो इंट्रासेलुलर जो पोटेशियम होता है उसको मोबिलाइज करके एक्स्ट्रावास्कुलर सेलुलर कंपार्टमेंट में ले आता है, तो उसके कारण पोटेशियम लेवल और बढ़ जाता है। तो जितना भी जो प्रॉब्लम हम सस्पेक्ट कर रहे थे रिंगर लैक्टेट के साथ वो जनरली होता नहीं है। सो वी कैन आई थिंक वी शुड प्रेफर बैलेंस सॉल्ट सॉल्यूशन इन पेशेंट्स विद डीके इन प्रेफरेंस टू सेलिंग।
Second question, this is very practical questions for intensivist. कितना से ज्यादा हम पैरासिंथेसिस करेंगे तो एल्ब्यूमिन देंगे?
सर उसका भी ये है मतलब अब जैसे नॉर्मली हम ये करते हैं कि अराउंड 8 लीटर से ज्यादा कर जो गाइडलाइन कहता है उसके बाद उसको ये करने के लिए कहता है, बट जो प्रैक्टिकली होता है अगर हम इवन 4 लीटर दे रहे हैं से निकाल रहे हैं तो देयर इज नो हार्म इन गिविंग एल्ब्यूमिन। और दूसरी चीज ये है कि जनरली अगर जिनके पास ये रहता है जो 10 एसाइटिस होता है जिसमें पैरासिटिस करते हैं, दे आर एट रिस्क ऑफ एसबीपी। तो इन दोज पेशेंट्स एज सच एल्ब्यूमिन देना के से मोर्टेलिटी बेनिफिट है ही। सो अगर आप 4 लीटर से ज्यादा निकाल रहे हैं तो देयर इज वी शुड एक्चुअली गिव एल्ब्यूमिन। उससे दो फायदे होंगे, अगर एसबीपी है तो उस तो डेफिनेटली मोर्टेलिटी बेनिफिट है, और एल्ब्यूमिन अगर हम दे रहे हैं तो उसमें जो सर्कुलेटरी डिस्टर्बेंसेस जो होते हैं वो नहीं होंगे। बट एक और इसमें ये है कि हमने इसमें कभी इसका कंपैरिजन क्रिस्टलोइड वर्सेस एल्ब्यूमिन को कोई अच्छा स्टडी में हुआ नहीं है। हो सकता है कि अगर हम एडिक्वेट वॉल्यूम में क्रिस्टलोइड दे हाई वॉल्यूम पैरासिटिस में वो भी इक्वली इफेक्टिव हो, बट अभी का कंसेंसस ये है कि एल्ब्यूमिन देना चाहिए।
तीसरा कि यदि पेशेंट का 2.6 ग्राम % उसका एल्ब्यूमिन का लेवल है सीरम में, और इफ ही इज लूजिंग 5 ग्राम ऑफ एल्ब्यूमिन पर डे थ्रू यूरिन इन 24 आवर्स, हाउ मच एल्ब्यूमिन शुड बी गिवन टू द पेशेंट्स?
सर ये एक्चुअली इसको कैलकुलेट करना होगा, बट बेसिकली वो जो ये होता है जो आप कह रहे हैं कि रीनल लॉस नेफ्रोपैथी, उसमें अगर आप कॉज को ट्रीट अगर नहीं कर पा रहे हैं तो आप कितना भी एल्ब्यूमिन दे दीजिए, क्योंकि जो आप एक्सोजेनसली जो एल्ब्यूमिन आप देते हैं उसको आपका हाफ लाइफ अराउंड 2 to 3 डेज होता है। नेचुरल एल्ब्यूमिन का 20 डेज होता है, इसका 2 to 3 डेज होता है। तो आप उसको आप कितना भी एल्ब्यूमिन दे दीजिए, यू विल नॉट बी एबल टू कॉज एनी बायोकेमिकल इंप्रूवमेंट। सो इन एनी protein losing diseases, the main focus should be on the treatment of the underlying cause rather than treating albumin with the low protein levels with albumin. खासकर सेप्सिस में तो ये कहा गया है कि the low albumin is actually a marker of severity of disease, उसमें आपको एल्ब्यूमिन देने से कोई फायदा नहीं होता है। सो किसी भी लो एल्ब्यूमिन स्टेट में the focus should be on giving the treating the cause rather than giving albumin.
Okay, thank you डॉक्टर साहब। तो टेक होम मैसेज हुआ कि हम लोग यदि 3 टाइम्स से ज्यादा एलएफटी का जो एंजाइम्स है एलिवेटेड नहीं हो, हम लोग दे सकते हैं, और 4 लीटर से यदि पैरासिम्पथेसिस ज्यादा कर रहे हैं तो एल्ब्यूमिन देना है, और नॉर्मल सलाइन के बदले प्रेफरेबली रिंगर लैक्टेट शुड बी यूज्ड इन ऑल दोज पेशेंट्स। थैंक यू डॉक्टर।
Thank you, Shivakshit sir, for this wonderful topic. And thank you to the chairpersons. I would now like to request our chairpersons to give Dr. Shivakshit a memento. Sir, please. I would request Dr. Rakesh Singh to please come on the stage to give our chairpersons memento. Dr. P.K. Gyani sir, thank you. Dr. Mahesh Prasad sir. Thank you, sir. We'll now move to the next session. We have Dr. Rakesh Singh from Katihar, who will be speaking on role of NIV in COVID. Oh, sorry, I'm sorry. It's an online online presentation next. Dr. Abhishek Chatterjee joins us from Jamshedpur. He'll be speaking on peri-operative cardiac emergencies. I'll request Dr. H.K. Jha sir to come on the stage to moderate this session. I'd also like to request Dr. Krishna Kumar sir from Muzaffarpur to come on the stage. Sir, please. I'll just briefly introduce our next speaker. Dr. Abhishek Chatterjee is a consultant anesthesiologist at Tata Main Hospital, Jamshedpur. He has multiple presentations in national, zonal, and state level. He's also joined National Secretary of ISACON East Zone in 2017. His core area of interest is obstetric and regional anesthesia. Dr. Chatterjee, can you hear us?
Good morning. Am I audible? Good morning, chairpersons, seniors, and my dear friends. I am thankful to the scientific committee of ISACON East Zone for giving me an opportunity.
Dr. Chatterjee, can you please share your screen?
Dr. Chatterjee? Hello?
Hello, am I audible?
Yes, sir, we can hear you.
Are my slides visible?
Dr. Chatterjee, do you hear me?
Yes, I can hear you. Are my slides visible?
Yes.
Your slides
Go
are
on.
not visible, sir.
Go on, please. No, slides are not visible. Slides are not visible.
Are the slides visible now?
It's
Yes.
visible now, sir.
Yes. Now it is coming.
Okay, so with the permission of the chairpersons, can I begin my talk?
Yes. Please start.
So, good morning, respected chairpersons, seniors, and my dear friends. So at the outset, I must express my gratitude, and I am extremely thankful to the scientific committee of ISACON East Zone for giving me the opportunity to speak on this important topic. Perioperative cardiac emergencies present a real challenge to all anesthesiologists, and if not managed properly, it can lead to disastrous outcome. It has been defined in the Cleveland Clinic as the life-threatening disorders which are recognized immediately to avoid delay in treatment and to minimize morbidity and mortality. The cardiac complications constitute the most common cause of postoperative morbidity and mortality, strongly affecting the length and cost of hospitalization. Now coming to incidences, if the age of patients are more than 45 years and if they are posted for non-cardiac surgery, then cardiac complications can occur in up to 5% of patients. In Asian countries, the incidences of all perioperative cardiac arrest are in the range of 3 to 40 per 10,000 cases. And if we see the 30-day mortality for non-cardiac surgery, the incidence is around 2%, whereas in patients at high cardiac risk, the incidences are more than 5%. The incidence of post-op arrhythmia after cardiothoracic surgery ranges from 30 to 40%, and it ranges from 4 to 20% for non-cardiac surgeries. 70% of the patients undergoing general anesthesia may develop intraoperative arrhythmias. There are numerous conditions which come under perioperative cardiac emergencies. So I am going to deal each of the conditions. The first and commonly encountered condition is the hypertension. It is a strong risk factor for coronary artery disease. The 7th report of the Joint National Committee defined hypertensive crisis as blood pressure of more than 180 by 110. This hypertensive crisis encompasses both hypertensive emergencies and hypertensive urgencies. Hypertensive emergency is the condition where there is severe increase in blood pressure complicated by evidence of progressive organ dysfunction. Whereas in hypertensive urgency, the severe increase in blood pressure is without organ dysfunction. So suppose if a patient comes to us in the preoperative period with a blood pressure of more than 180 by 110, what shall we do? Shall we postpone the surgery or shall we go ahead with the surgery? The decision to cancel elective surgery for preoperative hypertension is controversial, and it varies from practitioners' experience and judgment. Wax and colleagues performed a retrospective analysis to investigate the incidence of preoperative hypertension, case cancellations, and association with post-op outcomes. However, the small percentage of cases that were cancelled because of presentation of severe hypertension did not result in normalization of blood pressure when the procedure was rescheduled. Most anesthesia practitioners delay the surgery for patients with diastolic blood pressure of more than 110 because these patients are thought to be at increased risk of perioperative arrhythmias, MI, infarction, or stroke. However, a randomized trial by Wexler and colleagues was unable to show a benefit to delaying the surgery. The goal for hypertensive patients is to maintain a stable, smooth intraoperative course. Beta blockers and calcium channel blockers should be continued on the day of surgery because tachycardia, hypertension, angina, and MI can occur when beta blockers and calcium channel blockers are abruptly discontinued. It is optimal to hold the angiotensin converting enzyme inhibitors and angiotensin receptor blockers for 24 to 48 hours preoperatively because of their association with increased intraoperative hypotension. The causes of hypertension could be related to surgery, it could be related to anesthetic agents, could be related to medications. And this table on the right hand side is showing the intravenous antihypertensives for efficient and rapid control of intraoperative hypertension. It is ideal to maintain blood pressure within 20% of the patient's baseline mean pressure. Hypertensive patients tend to have an exaggerated response to laryngoscopy and intubation. Hence, a fine balance of anesthetic agents, narcotics, and beta blockers help us to blunt this sympathetic response. Hypertensive patients are also hypovolemic. Chronic vasoconstriction results in volume contraction and a greater susceptibility to hypotension from the vasodilating and cardiac depressant effects of anesthetic agents. Hypotension should be immediately treated by decreasing the volatile agents, IV fluid administration, or vasopressors. Emergence from anesthesia can also be correlated with hypertensive responses and is a time to titrate more narcotic and intravenous antihypertensive medications to continue a smooth course to the recovery area. Now coming to the next condition, that is myocardial infarction and ischemia. The most recent universal definition of MI is based on the increase or decrease in levels of cardiac biomarkers in the setting of myocardial ischemia. There are two separate mechanisms that can lead to perioperative MI or PMI. The type 1 PMI is also known as acute coronary syndrome, and it occurs when plaque undergoes spontaneous rupture or erosion, leading to coronary thrombosis, ischemia, or infarction. Type 2 PMI is largely because of prolonged myocardial oxygen supply demand imbalance. And the most common cause that could lead to type 2 PMI is tachycardia. Now, all the practitioners are encouraged to identify patients' cardiac risk in the preoperative period. There are various scoring systems available. However, the most commonly used criteria is the Lee's Revised Cardiac Risk Index, or RCRI index, which has got 6 parameters: the history of ischemic heart disease, high risk type of surgery, history of congestive heart failure, history of cerebrovascular disease, pre-op treatment with insulin, and pre-op serum creatinine of more than 2. Beta blockers should be administered to patients with one or more factors that are known to be associated with a higher perioperative cardiac risk. Although perioperative beta blockers have been proved to decrease the risk of MI, this benefit is accompanied by increased risk of stroke, hypotension, and bradycardia in the post-op period. Patients already on beta blockers should be maintained on them throughout the perioperative period for optimal outcomes. HMG-CoA reductase inhibitors should also be continued in the perioperative period because abrupt withdrawal of these drugs may cause destabilization of atheromatous plaque. Current recommendations support the dual antiplatelet therapy for at least 4 weeks after bare metal stent placement and for at least 1 year after drug-eluting stent placement. Elective surgery during this period is strongly discouraged. Coming to the management of MI, we have to increase the FiO2 to 100%. Heart rate should be controlled with beta blockers. It is imperative to maintain a fine balance between myocardial oxygen supply and demand. All causes of tachycardia, hypertension, anemia, and severe pain should be treated aggressively. Troponin is the gold standard in the diagnosis of acute coronary syndrome. After surgery, because of the influence of anesthesia and analgesic agents, symptoms of MI can be atypical or absent. Any patient with suggestive symptoms of MI should have a 12 bleed ECG and a serial troponin measurements. Next condition is acute heart failure. In the perioperative period, acute heart failure can result from a variety of conditions, and treatment may therefore vary considerably depending on its mechanism. Incidence of major cardiac complications after non-cardiac surgery is around 2 to 3.5%, whereas it is more than 20% in cases of cardiac surgeries. Heart failure is a complex clinical syndrome that results from various structural or functional impairment of ventricular filling or ejection of blood. Acute heart failure presents frequently as pulmonary edema or left, right, or biventricular congestive cardiac failure, and sometimes as cardiogenic shock. In the perioperative period, patients may be faced with numerous triggers of acute heart failure, which includes hypertension, tachyarrhythmia, anemia, hypercoagulability, inappropriate IV fluid management, severe pain, surgical stress, MI, etc. For years, the diagnosis of acute heart failure was based on clinical signs and was confirmed by echocardiography. Recently, the use of plasma biomarkers has shown great diagnostic value. In a recent systematic review and meta-analysis in non-cardiac surgery patients, increased postoperative BNP and NT-proBNP are independently associated with increased risk of mortality, myocardial infarction, and cardiac failure at 30 days and more than 180 days after surgery. Coming to management of acute heart failure, the concept of the golden hour for acute heart failure management is essential, and drugs administration must be started within minutes of diagnosis. We should initiate resuscitation measures like maximize the oxygenation ventilation, control of post-op pain, tachycardia, and correction of acid base, as well as electrolyte imbalances. There are 3 main components of management: optimizing the preload, the afterload, and to take care of the contractility. We have to optimize the preload. we have to judge between volume load versus diuresis based on the volume status of patient. Regarding afterload, if it is high, we should consider dilatation with nitroglycerin or sodium nitroprusside. And if the afterload is low, we have to consider augmentation with norepinephrine. Contractility should be maintained by utilizing the inotrope agents. And in situations in which the use of pharmacological therapy alone is insufficient, or the requirement of vasopressors are quite high, then we should opt for mechanical support as an appropriate option. Currently, 3 methods are employed: the intra-aortic balloon pump, the cardiovascular implantable devices, and percutaneous cardiopulmonary bypass system. We may face with a problem that a pregnant patient comes to us in acute heart failure, especially in patients with peripartum cardiomyopathy. The management algorithm remains the same. We have to optimize the preload, the oxygenation, we have to add inotropes and or vasopressors, and we should go for urgent delivery of the fetus by immediate cesarean section. Nowadays, bromocriptine is being increasingly used in patients with peripartum cardiomyopathy. The next condition is perioperative arrhythmia. These are common complications of surgery, particularly in the elderly population. The incidence after cardiothoracic surgery ranges from 30 to 40%, whereas the incidence is around 4 to 20% in non-cardiac surgeries. Atrial fibrillation is the most common type of sustained supraventricular tachycardia. Common factors that may contribute to perioperative arrhythmias include increased sympathetic activation, blood loss, fluid shifts, beta blocker withdrawal, hypo as well as hyperglycemia, and electrolyte imbalance. This table shows the common arrhythmias that we encountered during the perioperative period. Paroxysmal supraventricular tachycardia. If patient is hemodynamically unstable, we should go for synchronized cardioversion. And in cases where patients are hemodynamically stable, first we should attempt vagal maneuvers. If failed, then we should go for adenosine, calcium channel blockers, or beta blockers. Similarly, atrial flutter also requires cardioversion if a patient is hemodynamically unstable. And in stable patients, patients should be anticoagulated, and pharmacological treatment includes amiodarone, diltiazem, or verapamil. In atrial fibrillation, for hemodynamically stable patients, our primary target should be rate control, and it can be achieved by using amiodarone initially by bolus followed by infusion dose. Other alternates are propafenone, ibutylide, sotalol, beta blockers, and calcium channel blockers. For pulseless ventricular tachycardia, we have to follow the ACLS algorithm. For hemodynamically unstable patients, we need synchronized cardioversion, and for stable patients with pulse, we have to go for amiodarone. For ventricular fibrillation, again, we have to follow the AHA ACLS guideline. We should defibrillate the patient with 200 joules, chest compression, ventilation at a ratio of 30:2 for 2 minutes following shock. Epinephrine should be given every 3 to 5 minutes. For all these 5 critical arrhythmias, we must look for a causative agent. The most common cause for development of perioperative arrhythmias are the 5 H's and 5 T's, like hypovolemia, hypoxia, acidosis, hypo or hyperkalemia, hypothermia, tension pneumothorax, tamponade, toxins, and coronary or pulmonary thrombosis. And once it is identified, it has to be treated aggressively. Perioperative cardiac arrest is a rare but potentially catastrophic event, and the risk ranges from 4.3 to 34.6 per 10,000 procedures. Periopca is related to secondary causes, but many of them are anesthesia caused or anesthesia related, such as hypoxia due to failed airway and ventilation management, loss of the airway during transfer, residual neuromuscular block, or severe hemodynamic derangement caused by negative inotropes and vasodilator effects of general anesthesia drugs, severe bradycardia after subarachnoid block, immune mediated such as anaphylaxis, or non-immune mediated drugs adverse effects like local anesthetic systemic toxicity. In adult patients with periopca, ventricular fibrillation or pulseless VT should be defibrillated within 3 minutes after onset. The use of AEDs can be useful for improving survival. It is not recommended to defibrillate patients of VF or pulseless VT if the episode is lasting for more than 3 minutes without prior chest compression. Epinephrine administration after the third shock can be beneficial. In patients with periopka, it may be reasonable to administer epinephrine 1 mg, and it should be administered every 3 to 5 minutes. In adult patients with periopka, it is recommended to administer amiodarone or lidocaine for the treatment of VF or pulses VT. Magnesium is not indicated for treatment of these conditions, and it might be reasonable to administer amiodarone or lidocaine after the third shock. A ventilation rate of 10 breaths per minute during CPR may be reasonable. In adult patients with periopka due to pulmonary embolism or suspected pulmonary embolism, early consideration of thrombolysis and CPR duration of at least 60 to 90 minutes with or without the use of a mechanical chest compression device may be reasonable. I have mentioned all the class of recommendations and level of evidence along with each statement. In patients with periop cardiac arrest, it may be reasonable to maintain an EtCO2 of more than 10. It may be reasonable to target the hemodynamic goals to optimize tissue perfusion as indicated by an adequate urine output and normal to decreasing plasma lactate values. Coming to anaphylaxis, although anaphylaxis is immune mediated, but it can lead to severe cardiovascular emergency in the perioperative period. Perioperative anaphylaxis is a life-threatening immediate hypersensitivity reaction that is usually IgE mediated. Perioperative IgE mediated anaphylaxis is mainly related to agents given by intravenous route. It usually occurs after induction of anesthesia with neuromuscular blocking agents and antibiotics being the main causal agents. The National Audit Project 6 of UK showed that the drugs most commonly involved are antibiotics followed by neuromuscular blocking agents. Coamoxiclav and teicoplanin together accounted for more than 90% of the antibiotics identified. However, unlike the UK data, the latest French study showed that neuromuscular blocking agents were the most common drugs followed by antibiotics. The common clinical presentations may include from mild cutaneous features to tachycardia, and it may ultimately lead to cardiovascular collapse. Coming to management of anaphylaxis, the management usually has got two components, general measures and therapeutic measures. General measures include withdrawal of the culprit drug, temporary discontinuation or lightening of the depth of anesthesia, and use of Trendelenburg position or leg raising maneuvers depending on the clinical setting. Regarding the therapeutic measures, the cornerstone of management is IV adrenaline. There is agreement among the Scandinavian, French, Australian, and Spanish guideline to recommend an IV bolus of adrenaline 100 to 200 microgram, and it should be repeated every 1 to 2 minutes according to the response. The other crucial part of management is liberal IV fluid administration, and it has been found that dose of around 20 to 30 ml per kg may be needed. In the setting of persistent bronchospasm, short-acting beta-2 selective agonists like terbutaline or salbutamol can be used via a nebulizer or, if available, with a metered dose inhaler connected to the inspiratory limb of the ventilator circuit. Glucocorticoids, especially methylprednisolone at a dose of 1 to 2 mg per kg, remain a key component of management as their potent anti-inflammatory effects decrease the airway inflammation. Now coming to cardiac tamponade. Cardiac tamponade is a condition where there is accumulation of blood in the pericardial sac, which results in external pressure that compresses the atria as well as ventricles. Cardiac preload, cardiac output, as well as blood pressure are all strongly affected. Stroke volume becomes fixed and cardiac output becomes dependent on heart rate. The clinical manifestation are tachycardia, dyspnea, pulses paradoxus, Beckstrad, or pulseless electrical activity. Immediate treatment is required to remove the fluid from the pericardial sac. Management is designed to maintain the stroke volume until the pericardial sac is open. Patients with tamponade are at risk of severe hypotension and cardiac arrest with anesthesia induction. pericardial drainage can be accomplished with local anesthetic infiltration. As an alternative, initial drainage can be accomplished with local anesthetic infiltration, and after the hemodynamics have improved, general anesthesia can be induced. If general anesthesia is decided, those anesthetics that minimally depress the cardiac function and limit vasodilatation, like ketamine, etomidate, etc., they should be used. Positive pressure ventilation can increase vascular resistance and decrease the right ventricular outflow. And if general anesthesia is necessary, we should avoid large tidal volumes, and high peak airway pressure minimizes the impact of ventilation on hemodynamics. And we should try to opt for spontaneous respiration over positive pressure ventilation. Next condition is tension pneumothorax. It occurs when air accumulates within the pleural cavity. When this pressure becomes very high, the mediastinum shifts to the opposite hemithorax and causes compression on the contralateral lung and blood vessels. These are the common causes of tension pneumothorax in the perioperative period. The clinical manifestations are hypotension, hypoxia, tachycardia, decreased breath sounds, and increased airway pressure. Immediate treatment is crucial. A fiber optic bronchoscopy may initially be completed to rule out endobronchial intubation. The chest can be decompressed with insertion of 16 gauge or 18 gauge catheter into second to third interspace anteriorly or fourth to fifth interspace laterally. A rush of air is heard when decompression occurs. With advances in cardiology and cardiothoracic surgery, several newer implantable cardiac devices have become common in the surgical populations. The commonly used implantable devices are permanent pacemaker, artificial implantable cardioverter defibrillator, cardiac resynchronization therapy with or without defibrillator. Although these are being increasingly used, there is possibility of malfunction of these devices, which may result in catastrophic outcome. In the event of an arrhythmia or bradycardia, before attempting defibrillation, the magnet, if applied, should be removed to permit reactivation of anti-tachyarrhythmia function. All sources of electromechanical interference should be discontinued to allow proper interpretation of rhythm and appropriate therapy. Failure of the rhythm to revert after removal of the magnet will require either defibrillation or cardioversion, depending on the rhythm. During the occurrence of such an event, bedside ECG recording with paper is helpful to determine the ventricular rate as well as ventricular rhythm. There may be possibility that the recorded ventricular rate is lower than the set rate on the AICD. And in such condition, we must reprogram the device in the perioperative period. Application of transcutaneous pacing or defibrillator pads is essential, along with a standby external defibrillator with pacing capabilities. Continuous ECG, pulse oximetry monitoring, and additionally an arterial line, if indicated, are essential. Nowadays, we are getting more and more patients with acute prosthetic valve, and we may face with acute prosthetic valve thrombosis in the perioperative period. Diagnosis of acute prosthetic valve thrombosis should be suspected in patients with suspected thrombosis, and it should be evaluated with either transthoracic or transesophageal echocardiography, fluoroscopy, and or multi-detector CT. And for patients with thrombosed left-sided mechanical prosthetic heart valve who present with symptoms of valve obstruction, urgent initial treatment with either slow infusion, low-dose fibrinolytic therapy, or emergency surgery is recommended. Thank you. Thanks for patient hearing.
Explained the perioperative cardiac emergencies commonly observed and how to manage it. So nicely explained. Now the session is open for questions and queries, if any, please.
Cardiac emergency, very competent subject. Any questions, please?
Sir, I hope all my slides were visible because there was an initial technical glitch.
In the beginning, actually, your lecture and the slides were not matching, but later on, it was okay.
Okay, right, sir.
Thank you, Dr. Abhishek Chatterjee. One question, sir.
Yes, sir.
Sir, you have told that some muscle relaxant causes anaphylaxis. Can you tell me which muscle relaxant especially causes anaphylaxis? Yeah, all muscle relaxant can cause anaphylaxis.
Sir, the National Audit Project of UK, which showed that the muscle relaxants were responsible for anaphylaxis, they enumerated that it is mostly the histamine releasing muscle relaxants like the atracurium and to certain extent cisatracurium.
Okay, sir. Second question is, if patient is on a stent, drug-eluting or bare metal, what precautions should be taken during non-cardiac surgery?
Sir, first they have recommended that patients on bare metal stent, the antiplatelet therapy should be continued for at least 1 month, and for drug-eluting stent, they should be continued for at least 1 year. And they have also recommended that during this period, all elective surgeries should be discouraged. And if at all we should go for surgery, if surgery is needed, especially in emergency condition, then with all the precautions and with all possibilities of bleeding and anticipated profuse bleeding should be taken into account, and we should be prepare ourselves according to that. But for routine surgeries, it is strongly recommended that all routine surgeries should be discouraged for 4 weeks in bare metal stent and for 1 year in drug-eluting stents.
Okay, sir. But I want to know that if patient already have a stent, time has left more than 6 months, 10 months, then what precaution we should take during non-cardiac surgery? Is it any precautions, or we should continue anticoagulant what he has taking during course?
Sir, now they are recommending that clopidogrel can be stopped 5 to 7 days prior to surgery, and aspirin can be continued till the day of surgery, provided it is not a vascular surgery or where we are not anticipating major blood loss. In these conditions, aspirin can be continued till day of surgery, and preferably clopidogrel can be stopped for 5 to 7 days. And both the antiplatelets should be restarted in the post-operative period once the surgery is over, if the chances of rebleeding are less.
Okay, thank you.
Thank you, Dr. Chatterjee. Your memento will be sent by some Jamshedpur people. Thank you. Now I request Dr. Gurbakh Prasad to hand over the memento to our chairpersons. Our next speaker, Professor Rakesh Singh from Katihar. He is a very well-known teacher. We all know the ventilation, and the Dr. Professor Rakesh Singh will tell about non-invasive ventilation and COVID. The chairpersons are Dr. Kishore Junjunwala, Dr. Silora Sahu online, and Dr. Nagina Chaudhary. Dr. Kishore Junjunwala, intensivist, critical care. Dr. Nagina Chaudhary, HOD Madhepura. Sir, please. एक अनाउंसमेंट करना चाहते हैं, सोवेनियर आ गया है, रजिस्ट्रेशन काउंटर पर है, जिनको नहीं मिला हो कृपया वहां से कलेक्ट कर लें. धन्यवाद.
Respected chairpersons, my senior teachers and dear student. This is a postgraduate forum. So I would like to present this talk in very simplified way that will be easily understandable by all the PG students. So my topic is role of role of non-invasive ventilation in COVID. So COVID patients usually develop respiratory failure, and various modalities are used for the treatment, starting from oxygen through the flow meter to the non-invasive ventilation. But I would not cover the oxygen flow through mask or non-invasive ventilation. My topic will be confined purely to the non-invasive ventilation. So non-invasive ventilation is the mode of ventilation in which positive pressure is applied in the upper airway without use of any adjunct inside the oral cavity or into the trachea. So you will be putting interface over the face, and you will connect your breathing tube to the device. So this is the main difference between the invasive, where the tube is used or the tracheostomy tube is used, and the non-invasive ventilation where some interface is used over the face. There are so many interfaces available. There are nasal pillow. You can point at nasal pillow. Then there are nasal mask. Then there are oral mask. Then there is full face mask, and there is helmet. Among all these, it is recommended that the nasal mask is preferred. This is preferred because in this condition, your mouth remains open, and if you want to expectorate or remove your secretion from the mouth, that is easily possible. Much hype was about the helmet ventilation using helmet mask, but it is not easily available, and it has not shown any significant improvement over the nasal mask. So till now, it is preferable to use the nasal mask. So there is heterogeneous presentation of the COVID. Some peoples are affected in the mild fashion, some develop severe infection, approximately 15% patient who develop severe infection, and the 5% of them will require admission into the ICU. Patient who have comorbidity and who develop severe ARDS, the mortality is very high. Even with the use of the invasive ventilator, the mortality is in the range of 50 to 80% at the various hospitals. So there is heterogeneous presentation. Nobody would know how our body would react to the invasion by this virus. Some people develop very mild infection, but many develop shortness of breath, they develop ARDS, they require ICU admission, and death also. Okay, so this is the pathophysiology of ARDS, and in the case of corona, it is called the COVID associated adult respiratory distress syndrome. In this, there is damage to the alveolo-capillary membrane. So transudation occurs, there microthrombi creation inside the alveoli. Alveoli are damaged, and the pneumonic consolidations occurs. There are few types of the phenotypes in the cards. One phenotype is the L phenotype. L means severity is less. So L means low elastage. Low elastage means compliance is good. They are means just opposite of each other. So if the elastance is low, means compliance is good. Then there is low weight, because the pneumonia has not spread to far extent. It is confined to the pleural area. And so the amount of the recruitable tissue is also less, means because all of the alveoli are normally ventilated, so the recruitable tissue is less, so everything is less, and this is called the L phenotype. That is, your elastance is less, your weight of the lung is less, as well as the recruitable tissue is less. But if favorable treatment is not done, they can progress to the H type. H type is just opposite of the L type, in which the elastance is high, means the compliance is very less. Pneumonic consolidation has developed, so the lung weight is high, as well as the amount of the recruitable tissue is less. So this is like baby lung condition, where the alveoli which are normally ventilated is very less. And if it is not halted at this place, then they can develop into the phenotype F, where the fibrosis will develop, and these patients will require very long-term treatment even after the recovery from the COVID. So as per the Berlin definition of the ARDS, there are 3 stages of the severity: mild, moderate, and the severe, depending on the PaO2 FiO2 ratio. So if PaO2 FiO2 ratio is less than 300, this is mild. If it is less than 200, it is moderate. And if it is less than 100, it is severe. It has been found that NIV can be very, very effective in the mild to the moderate cases of the COVID-associated ARDS. So how does it help, and what are the different modes in the non-invasive ventilation? In non-invasive ventilation, there are basically 2 types of mode, and these are called the CPAP and the BiPAP. CPAP is continuous positive airway pressure, and it works during exhalation. So here you can see that the baseline is raised. Usually when you exhale, you come to the atmospheric pressure, but when the CPAP is applied, your baseline is raised, and this is the CPAP. This is like if you are moving in a car, taking your head out, and blow of air is coming from the other side. So you will feel a pressure of air inside you, and due to this effect, what will happen? It will increase your functional residual capacity. So if the patient has only hypoxemic respiratory failure, that is type 1 respiratory failure, where there is only PaO2 is less, in mild cases, only this will help. And this kind of the ventilator is available in many homes, and even those ventilators with only CPAP modality can be used for the mild cases. Other modality is the BiPAP, in which 2 pressure are there. One is EPAP, that is the expiratory positive airway pressure, and the other is IPAP. And the difference between these 2 is basically the pressure support. So if you increase the distance between these 2, your tidal volume will be augmented. So in type 2 respiratory failure, where there is hypoxia as well as hypercarbia, in those cases, if the patient has previous COPD or sleep apnea syndrome, this kind of the ventilator will be useful in them. So effect of PEEP, what is that? It increases the functional residual capacity, so decreases the shunt, and it increases the partial pressure of oxygen. It improves the compliance and it decreases the work of breathing. So this kind of ventilator will be useful for type 1 respiratory failure. The modes available are basically 3. First is the spontaneous, in which you are applying CPAP. You are just raising the baseline pressure up to what point they can exhale. Then there is a spontaneous timed, means there would be a backup rate in the ventilator. So if patients develop apnea, in that condition, the ventilator will give backup rate. In the spontaneous, there will be no backup rate. And there is assist control mode, which will work in the assist control, pressure control mode. So types of the mask, full face mask, which is used are basically 2 types. One is called non-vented type. It doesn't have opening, okay? And other is called the vented mask. So vented mask is used where in the standalone BiPAP machine, because there is just one breathing tube. So whatever gas patient is exhaling, you should give passage to that gas. So for giving passage to that gas, you must use vented mask with this standalone BiPAP machine. But in many invasive ventilator, the non-invasive mode is also incorporated. And in these machines, there are 2 breathing tubes. And so in these cases, you must use the non-vented type, because there is a passage for exhale gas. When you exhale, it comes out through some other passage. So the non-vented mask will be used. But in the time of COVID, there was one concern that when we use vented mask, there is the chances that the aerosol would come and the chances of infection to the healthcare worker will occur. So to mitigate these factors, what is recommended that even with standalone BiPAP, you must use non-vented mask. Okay. Thereafter, using non-vented mask, you will use a filter. And after filter, you will attach another extension that will, through which the gases will come out. So by using this method, we can decrease the chances of infection spread to the healthcare worker. So many a time, even in the standalone BiPAP, you can use non-vented mask with some modifications. So indications are the severe symptom, patient is dyspneic and the breath rate is 25 breaths per minute, or the signs of the gas exchange or disturbances, the PaCO2 is high and the PaO2 by FiO2 ratio is less than 200. These are the criteria where it should not be used if the patient develops respiratory arrest, if the dynamics is unstable, the level of consciousness is low, the inability to protect the respiratory tract, there is excessive bronchial secretion, there is signs of the impaired consciousness, and there is facial trauma, burn, or anatomic disorder, so that the face mask cannot be applied. When it should be stopped, when there is inability of the non-invasive ventilation to improve gas exchange. Basically the non-invasive ventilators have been criticized that it increases the mortality in the patients of the COVID. So we should not use it for extended period. If it is not giving result within 2 hours, then it is not going to help. So the clinical improvement should occur within 2 hours. And if it occurs, then you will continue the use of NIV, other you will terminate it. If there is inability of mask ventilation to ease dyspnea within 2 hours, if patient develop hemodynamic instability, or if there is failure to continue mask due to discomfort felt by the patient. So what is the advantage? Advantage is if you use NIV, the chances of the intubation will decrease by 50%. There is avoidance of the complication associated with the use of invasive ventilation, many a time weaning becomes difficult if the patient is kept on the invasive ventilation. There would be reduced stay in the hospital or ICU. There would be reduction of the treatment cost. There would be preservation of the protective reflexes. There would be the preservation of the patient ability to cuff his sputum, talk or swallow. There would be the reduced need of sedation and the muscle relaxant, and there would be the possibility of intermittent use. If you intubate a patient, then you will have to continuously put it on ventilator. But if he is using the non-invasive ventilation, he can use it intermittently also. So we have evidence from certain study that it is helpful. So this is a multiple center survey on the use in the clinical practice of the non-invasive ventilation as the first line intervention for the acute respiratory distress syndrome. Objective was to investigate the application of the NPPV as a first line intervention in the early ARDS. The result was that the non-invasive positive pressure ventilation improved gas exchange and avoided intubation in the 54% of the patient. There was avoidance of the intubation associated with ventilator associated pneumonia, in which intubation was not done, it was 2%, and in which it was done, it was 21%, and the mortality was also low. In which it was used, the mortality was 6%, and in those it was not used, mortality was quite high. And what is the indicator that it is working or it will not work? So if your simplified acute physiology score is more than 34, and if there is inability to improve the PaO2 FiO2 ratio within half hour, maximum up to 2 hours, then this is not going to work. There is another study, there is effectiveness of the non-invasive positive pressure ventilation in the treatment of the acute respiratory failure in the severe acute respiratory failure. The result was that the endotracheal intubation was avoided in the 70% patient in whom the length of stay in the ICU was shorter. It was 3.1 versus 21.3, which is significantly different. And the chest radiography score within 24 hours of non-positive pressure ventilation was 15.1 versus 22.5 compared to the intubated patient. Intubation avoidance was predicted by marked reduction in the respiratory rate with a flow of 3 liters per minute. 3 liter की कमी आ गई, and the supplementation of oxygen within 24 hours. And there was no infection in the 105 healthcare worker caring for this patient. This is very, very important. If you use non-invasive ventilation and you use all the protective measure along with it, then there is no increased risk of infection due to the use of non-invasive ventilation as compared to the invasive ventilation. So this is the lung safe study. This is an observational study, and the idea, the objective was to determine whether during NIV categorization of ARDS severity based on PaO2 FiO2 is useful or not. The result was that NIV failure occurred in 22% of the mild cases. It is 22 mild cases में 22% में failure हुआ, moderate में 42% और severe cases में 47% में there was a failure. Okay, hospital mortality in patients with NIV success and failure, because it will be successful in only 50% patient. So in which it was successful, the mortality was less, 16%, and in which it was not successful, it was 45%. And NIV use was independently associated with increased ICU, but not hospital. But this was a negative remark has come along with this. But the conclusion was NIV seems to be associated with higher ICU mortality in FiO2. Here you can see that mortality in the mild cases and the moderate cases is almost same. with the invasive and non-invasive ventilation. Only the mortality is higher in the case where the severity is very high. So this is the recommendation of the International Society. Many society are still not supporting use of NIV. You can see that the Australian and the Italian, they are not in support of it. Some are in support of it, and some are silent about it. What does our society say? That is the ICMR. It clearly says that the patient admitted in ICU can be treated with the NIV. So consider use of NIV, helmet or face mask interface, depending on the availability in patients with increasing oxygen requirement if the work of breathing is low. So this is the NIV application protocol. It will be useful if the PaO2 FiO2 ratio is less than 200. You will apply it for maximum of 2 hours. If it is showing chances, if it is showing improvement, if the respiratory rate is decreasing, oxygen requirement is decreasing, ABs is improving, then you will continue. If it doesn't work, you will shift over to the intubation. And also, your target should not be high. The target should be kept in 88 to 92%. You will give the oxygen flows so that our target of SpO2 is 82 to 92%, because it has been seen when we keep higher target, that is more than 96%, the mortality increases. So we should keep our target to 88 to 92%. So the take home message is ventilator are precious, so it should be used judiciously. NIV has its role in mild to moderate cards, and the NIV can help to properly use our resources to benefit mass and reduce mortality associated with COVID-19. Thank you very much.
Thank you, sir. Such a nice presentation by you. The only concern which we raised when, because of the lung safe trial was there, the 3 concern was there when we are using the NIV. First thing is that in case of failure, it delays the lung safe trial says that once you initiated the NIV in ARDS, what happens is delays the intubation, and that leads to the more mortality. Second, but the recent contradictory to that was published the recent article in Lancet or also ESN in a COVID patients. The intubation, post-intubation in cases of failure of NIV not increase the mortality. That was the observation in the COVID-19. Second concern was when we are worried about why the contraindication was that the aerosolization. But it was found that during the NIV, what happened, we use your mask, we are using the PPE kit. So basically aerosolization infection was less. In the Lancet, they published that inside the ICU and out of the ICU, inside the ICU, those who was working have a lesser COVID infection than the person who was working outside the ICU, and probably due to the more strict your precaution. And that we all observed during this pandemic. Everyone has faced. Those working inside the ICUs are less affected people. Third concern was the effectiveness. In case of effectiveness, it was found that why the failure of invasive ventilation in this pandemic was there, because we are concerned about the pandemic. Everywhere oxygen pressure was set very low. We are keeping the invasive mechanical ventilation. We are setting the FiO2 of 80%, and actually delivering the machine is only 21%. The failure is also due to the oxygen pressure, and there is a lack of oxygen pressure supply chain everywhere. We are trying to save more oxygen. We try to save the more and more patient. So this pandemic has given us an insight, even with the severe of ARDS is effective. We'll get the more data on that. Any question from the
Thank you so much for nice presentation, sir. My question to you, sir, is that is there any feeding guidelines while present on the NIV? Because there is big issue for all of us.
No. The advantage of the NIV is that the patient is fully conscious, okay, and NIV can be used intermittently. So at the time of the feeding should be given, and thereafter it can be applied.
But
Because
how much long we should hold an IV, sir? Because feeding is important part of, for the patient care.
Definitely.
So how long we should hold the feeding? When we have to put the next an IV time, there is any time limit, any guidelines for it?
I am not aware of exact guidance about it, but it can be, interruption should be of for the minimum period or the as per patient tolerate. We do not apply it for day over.
Okay,
Sir, you would like to
Actually, you are concerned about the feeding. You are more concerned about the aspiration, number one. And second, you are concerned about when you are interrupting your NIV, and during that time, patient become hypoxemic. So, the what happened in this pandemic, what the observation was there, patient was not able to tolerate. Once you remove the BiPAP, suddenly they started desaturating. So what the application? This was the concern basically. Okay, once you remove this BiPAP, they are suddenly you got the saturation 60% and patient was unable to take the food. So two answer was there. Initially for 24 hours, when you are ventilating with the NIV, for particularly in ARDS patient, you can use the RAS 2 feeding, number one. Second, if at all patient is tolerating, you can use the alternative way of giving the oxygen, like use the high flow. If you have the HFNC, give the high flow nasal cannula and give the feed, and you can give the feed, and you can get the better oxygenation. So it's very important. And regarding the your aspiration and vomiting and aspiration, there are very less, because anyway in NIV when we are using, we are giving the only maximum of 18, 16 or 18 or 20 of the IPAP, and our lower esophageal sphincter is worked on the 30 centimeter of pressure. Until unless we'll not cross that 30 centimeter, our LES will not open up. So there are very less risk of vomiting and aspiration, particularly are giving the feeding, but be cautious about two things. Abhi, recently no guideline. The reason is that no one can give that much of ARDS on a severe ARDS, because you are very much confused with the when you are using the severe ARDS. What happened in this pandemic? We are using NIV in the severe ARDS, and when you are removing, there is a problem. But entire guideline is not saying use in the severe ARDS. And what we used in this pandemic, even those are not dying patient, those are the very sick patient, dyspneic patient, we use the NIV. That's why we face the problem. And I can tell you, use the alternative way of oxygenation and give the feed.
if patient is conscious, then there is no chance of aspiration. This guideline is only for mild to moderate, where the PaO2 FiO2 ratio is at least more than 150. This guideline are not for less than that. If it is less than that, ideally you should use as Dr. Jhunjhunwala had said that the lower esophageal sphincter will not open at this pressure. There is no do not use high flow. Do not use high flow. High flow is going to cause damage. Okay, so you have to give the minimal flow to maintain the oxygenation in the 88 to 92%. Okay, and you will say that the sufficient tidal volume as per ARDS guideline is met. So you will also keep pressure minimum, so that the chances of aspiration will be less. If you use it judiciously, then the chances of aspiration is not a big.
Thank you, sir. Thank you very much.
Definitely risk of aerophagia is there, but you can individualize. Aerophagia is there. Patient can give, when you are there is esophageal leak. When you are using the BiPAP, here will go inside the stomach. So you can individualize the treatment. That's all. We are concluding such a nice session.
And other thing is that if you use nasal mask, actually nasal mask is preferred. We are not using nasal mask, we are using oronasal mask. Then the chances of this aerophagia and things will be there.
Now I request Professor Apurva Dayal to hand over the memento to our speaker and chairpersons. आईसीयू में फ्लूइड चला लिए, कार्डियक इमरजेंसी देखा, उसके बाद एनआईवी भी हो रहा है, ये भी खत्म हो गया, तब थोड़ा सा चेस्ट देख लिया जाए। तो उसके लिए हम चेस्ट रेडियोलॉजी के लिए बुला रहे हैं डॉक्टर राजीव प्रियदर्शी फ्रॉम एम्स पटना, और चेयरपर्सन हैं प्रोफेसर पीके सिंह गया, प्रोफेसर अजीत गुप्ता, सासाराम, प्रोफेसर अभिषेक बासुकी।
There is an important announcement. We have just concluded the TN Jha Award. Okay, we have just concluded the TN Jha Award. Certificates has been given to all the participants. Those who have not received, please collect your certificates from the 5th floor. We are going to start the next session. Young anesthesiologist certificate is with me. Please collect. The result will be announced during valedictory in the second half. So I request all the participants to please stay. If you are winner, we'll be very happy to have you at that moment. So I request everyone. We are going to start the young anesthesiologist and the private practitioner forum award in next 5 minutes in the 5th floor. Thank you.
Hello, very good morning to all of you. And now we are moving to a topic that is very much useful to the postgraduate students. And the speaker is no one else, Rajiv Pradeshi, very dynamic and good orator. Had been working with me at Indira Gandhi Institute of Medical Sciences for so many years. And he switched over to now All India Institute. And he is one of the backbones of the radiology department in AIIMS Patna. So just by his presentation, you will know what is his capability. Okay, Dr. Rajiv.
Thank you, Gupta sir, for this nice introduction. So this talk I have made especially for the postgraduate students, and I will try to keep it as simple as possible so that the students who are even in the first or second year can get it very easily. So first, the chest radiography as well as the CT scan both utilizes the X-ray, and the principle is overall the same. There is a X-ray tube, and from the tube, the X-ray passes through the patient body. It detects the different kind of the density, and then it goes to the detector, and then the film is made. Chest X-ray can identify only 5 types of the density. It can identify air, it can identify fat, water, and bone and metal. In contrast to that, you see there are only 5 types of the density. A radiograph can make you all understand that. In contrast to that, chest CT scan, there is a detector again, there is a tube, but there is rotation of the tube and detector assembly all around the patients. Therefore, there is slicing of the patient. So whatever we see, all the 3-dimensional structure we see, and we see as a slice. Actual acquisition in the CT scan is a slice. The difference from the X-ray is that all the data, all the information goes to the computer, and computer assigns a particular density for every structure, every tissue of the body. And here comes the concept of windowing. You must understand what is window. You must have had the lung window. You must have heard about the soft tissue window and the bone window. What it is exactly, I will tell you in a brief. So our eyes has limited capacity to differentiate different shades of gray and white. We cannot differentiate very subtle difference. Therefore, we try to put all the shades of the gray, which we can identify by the human eyes towards more bone density, more towards the higher density in the bone window. In the lung window, we put all the shades of gray towards the negative side so that we can identify even the subtle difference in the density. And the soft tissue, what you should know is that for the lung parenchymal examination, you should ask for the lung window. For the bone evaluation, you should ask for the bone window. And for the soft tissue evaluation or the mediastinum, you should ask for a soft tissue window. You should also know when CT contrast is given. Contrast, basically when we give contrast, it is a high density material, it mixes with the water, then it goes wherever the blood goes. So wherever the contrast will go, it will make that structure of the high density. So contrast is given only when you are suspecting some soft tissue abnormality, where you expect some enhancement or some kind of differentiation based on the enhancement property, and that tissue has some vascularity. Otherwise, just for the gross evaluation, contrast is not required. At the same time, you should also try to understand what is high resolution CT. Is it the same as non-contrast CT? No, it is not the same. Technically, there is big difference between the high resolution CT and non-contrast CT. In high resolution CT, the section is very thin, so the parenchyma is very, very clear. So it is indicated when you are suspecting any disease which is involving the lung parenchyma, not the mediastinum, not the soft tissue, not the chest wall. When you are sure that there is lesion in the lung parenchyma, screening chest radiograph has shown some opacity, and you want to make it clear, then high resolution CT is required, because algorithm is different. You can just see the example. This is the airways which is arising from. It is very, very clear in the HRCT. So HRCT is advised when you are suspecting some diffuse lung disease, parenchymal abnormality. You must have heard about the different type of the reconstruction, which is now possible with the advent of newer generation CT scanners like multi-slice CT scanners. So actually you should know that the acquisition is acquired in the axial plane. CT scan takes the sections of the body, and all the newer CT scan is taking the whole data of the patient's body. All the information goes to the computer, and now whatever the way you want to make, the computer will make. You want to make it sagittal, you want to make it coronal, you want to make it oblique, whatever you want to do, you can do with that that data. So this is the actual scan which is taken in the transverse sections. So there is very, very thin slice. Thousands of the transverse sections are taken by the computer. And now with that, you can make coronal, all the coronal, or you can make sagittal. This is the sagittal, this is the coronal, and at the same time, you can also make it oblique. Just by rotating it, you can make it oblique. Whatever the way you want to make it, you can make. That is the facility now available with the multi-slice CT scanner. At the same time, you can also do a volume rendering technique. You can make a volumetric imaging. You can do a different type of the shading and the surface shaded display, the volume rendering technique. There are several techniques now. I will not go in detail. Is available with the newer CT scanners now. So now I will discuss very briefly in what is anatomy, which is relevant for the interpretation of the chest X-ray in a short. You know, there is two lung, which is divided by the major fissure into the upper lobe and the lower lobe. What you have to remember that the upper lobe is anteriorly placed, whereas lower lobe is posteriorly placed. This is a very important concept that will help you to understand when you see the opacity in the chest radiograph, particularly the frontal radiograph. You cannot say confidently that whether it is located in the anterior part or the posterior part, because you don't have the third dimension, and there is considerable overlap between the upper lobe and the lower lobe. On the right side, there is horizontal fissures which divides the upper lobe into the two parts, which is a partial fissure. This is not complete fissure, into the upper lobe and right middle lobe. Again, this upper lobe is anterior, lower lobe is posterior structure, which is divided by this major fissure. And this fissure, you must, why I'm showing you to, because you will understand that when collapse occurs, these fissures become very prominent. Sometimes fluid can also get accumulated in the fissure that can mimic a soft tissue tumor or the mass. Fluid can get accumulated here. It can get accumulated even in the minor fissure. And whenever there is collapse, there is whole shifting of these fissures towards the collapse side. So therefore, this understanding is important for you. Understanding of how this pleura behaves is also important, because there is two pleura. You know that there is a parietal pleura which is closely adherent to the chest wall, whereas the visceral pleura is closely adherent to the lung parenchyma. There is no separation between the chest wall and the parietal pleura, and there is no separation between the visceral pleura and the lung parenchyma. And in between that, there is potential space in which everything accumulates. It could be air, it could be the pus, it could be the fluid, or whatever can accumulate. It could be the blood into that potential pleural space in between. So also the lung is quite collapsible when there is accumulation of the fluid or the air. Easily lung collapses, that you know well as you are anesthesiologist. Now let us look at the structure at the hyla, which imparts density in the radiograph. At the hilum, which is the root of the lung, there is pulmonary vein, there is pulmonary artery and the bronchus. But pulmonary vein, because it is lower down in position and it is overshadowed by the cardiac shadow, which is a soft tissue structure which has the same density as the blood, it is not going to make significant part in the formation of the pulmonary hilum. Similarly, the airways, the right and the left bronchus, because it is filled with the air, it is not going to impart significant density in the formation of the lung hilum. So what is more important in the lung hilum is the pulmonary artery. So major density is formed by this pulmonary artery, right and left pulmonary artery, that you should understand. Also, you should try to understand with this cadaveric image is that left pulmonary artery hooks the left bronchus superiorly, therefore the left hyla appears slightly higher than the right hyla. Also, you should try to understand with this cadaveric image that there is a concept of Silhouette sign in the radiology. It's a very, very important concept when you look at the radiograph. It says that why we see something, why the border of something is visible. It is visible because of the density difference. Here you should try to see that what makes the right heart border, because lung is in contact with the right heart, therefore the right border is visible. It is in contact with this superior vena cava, therefore we can see the outline of the superior vena cava, because there is density difference. Lung has a different density and the superior vena cava has a different density, therefore we can identify the interface. Right ventricle, on the other hand, is anteriorly placed. Here you can see the right ventricle. Therefore, it is not going to make any border of the lung. Left ventricle, because it is touching the left lung, it will make the left heart border. And this is the left atrium, which is receiving all the pulmonary vein. This is the pulmonary vein. It is posteriorly placed, so it is also not going to make any border. So again, I am repeating, right ventricle is not going to form any heart border. Left atrium is not going to make any heart border. Right atrium which will mainly form the right heart border, and left heart border will be formed by the left ventricle. Again, the aortic knuckle here is in contact with the air, it will be visible. Pulmonary artery is contact with the lung, it will be visible, but pulmonary veins will not be visible, mostly. Now I am going to discuss in brief about the sectional anatomy of the CT scan, which is much more important before understanding the chest radiograph. So I will start with the sectional anatomy of the CT scan and what are the structure that you can easily identify on the CT scan. Just you have to pay attention. When we take section of the body, the CT scan cuts the sections of the body at the different level. What you will see, that will depend on the level. So just understand, try to understand that when we will take a section over here, this place, we will see the brachiocephalic vein. At the same time, we will see all the branches of the aorta, but we will not see this aortic arch. We will not see this ascending aorta. We will not see the pulmonary artery. So sections at this level will show only the structure which is available at this level. Similarly, when we will take a section here, we will see the arch of aorta and we will see the superior vena cava. If we will take a section over here, we will see the pulmonary artery, we will see the branches, but we will not see all the branches, we will not see the arch of aorta, we will not see the heart. So this all depends upon the sections. Therefore, knowledge of the sectional anatomy for you is very important. You can draw a picture in the to make it, you practice it, then it's very easy to understand at least chest radiology. So this is the sections. You compare it with the cadaveric section. This is the section at the upper part of the chest. You see the 5 vessel view. This is the left subclavian artery, then left common carotid artery. This is brachiocephalic artery, and there is 2 veins. This is brachiocephalic vein, and this is the superior vena cava. This is just going to form this superior vena cava. So this is and this is esophagus. We can see a little bit of the air in the esophagus, and this is the trachea. This is the soft tissue window. Therefore, lung parenchyma is not visible. It doesn't mean, because this is windowing. This is the play of the windowing, because we have our target is to see the soft tissue. Therefore, this is not a proper window to see the lung. We will see later how the lung window appear. So this is the sections at the thoracic inlet. You should identify these 5 vessels. This is all the ribs. This is scapula. And this is soft tissue. Very simple. Lower down, you see the arch of aorta, you see the superior vena cava. Because it is lower, try to assume that you are looking the patients from the foot end, and the CT scan is taking sections. So now see, this is the arch of aorta, this is superior vena cava, and all the branches are above. Therefore, you don't see these branches. Now going down, you see the arch of aorta, and below that you see ascending aorta and descending aorta, but you don't see the arch of aorta because we are a section below that. So you see, this is the level at the aortopulmonary window. This is ascending aorta. This is descending aorta. This is again the trachea where it is going to divide. This is the level of the carina. Roughly, it corresponds to the T4 level. And this is all the vessels. We don't see lung parenchyma because of the lower density. And this is soft tissue window. And this is all ribs and scapula like the previous image we discussed. This is at the level of the left pulmonary artery. This is a typical configuration of the left pulmonary artery because it hooks. Left hilum is higher, it appears before the right pulmonary artery. In the next section, we are going to see the right pulmonary artery, and above that section, you will see the left pulmonary artery. Right pulmonary artery has a slightly lower sections, and then ascending aorta, descending aorta, and the lung parenchyma. Below that, we will see all the chambers of the heart. This is the right atrium, this is the right ventricle, and this is origin of the aorta, and this is the left atrium, which is receiving the supply from the pulmonary vein. This is descending aorta. Below that, you will see the left ventricle, which is identified by the side, by the thickened wall compared to the right ventricle. Now we will look at the lung parenchyma. This was about the soft tissue. This was about the mediastinum. Now we will look at the anatomy of the lung parenchyma. But before I go to describe how the lung parenchyma looks like, let us have a concept of the secondary pulmonary lobule, which is very important in the chest radiology. We must identify it. So all over the lung, always the artery goes along with the airways. So there is always a branch of bronchus bronchiole. It goes along the airways. And this forms the centrilobular core structure. Out of these 2 dots, one will be of the vessel, one will be of the bronchioles. And normally, because bronchiole contains air, they will not form any density. But imagine what will happen when it gets filled in the airway disease, in the bronchiectasis, in the tuberculosis. It will become visible. That I will show. And this is the interstitium, secondary pulmonary lobule, where there is pulmonary vein, there is lymphatics, and there is interstitium. Interstitium, which is the supporting network of the lung parenchyma, where the alveoli is arranged. It is otherwise all the alveoli will collapse if there is no interstitium. So this understanding, 2 or 3 things you should remember. Normally, the centrilobular core structure is formed only by the vessels. Airways does not make any density because it is filled with air. Veins runs in the secondary pulmonary lobule. Normally, it is not visible, but when there is pulmonary edema develops, this secondary lobule, interlobular septa, is going to be prominent. That we will see in some example. And lymphatics runs in the intralobular space as well as in the interlobar septa. This is the secondary pulmonary lobule where veins and the interstitium and the lymphatics goes. Now we will look at the lung parenchyma. Now, whatever the density you see here is of the vessels, all the dots. Nowhere you see airways, particularly in the peripheral third, visibility of the airways is abnormal. This is the airways that you see only in the proximal 2/3. You don't see any airways here. All the airways is visible. This dot is of the air. Just I will stop it here to make it. Now try to see, this is the airways. This is the bronchioles. It is visible up to here only. Beyond that, we don't see any airways. This is the fissures. Here it is very thin, hardly visible. This is again the major fissure. This is just seen as a line. It is not visible. But we will see how it becomes visible. So now I will discuss that what structure we have to evaluate in a chest radiograph. We have to we can start with the name of the patients, whether that position is right or left, that is you can identify by it is not visible here, by the air bubbles in the stomach. Then you can start with the central efficiency is formed by the trachea. It divides into the right main bronchus and the left main bronchus. You should try that whether it is central in position or not. Then you should see the cardiac silhouette. Here it is formed by the right atrium. Above that it is formed by the superior vena cava. On the left side, this border will be formed by the left ventricle. Above that there is small portion by the left arterial appendages. Then you will see this pulmonary artery shadow here. Then this is aortic knuckle, and you can see all the outlines of the descending aorta here. And then after this cardiac silhouette and the airways, you should try to see the pleura. Normally, pleura is not visible unless calcified. You can see the very sharp angle of the cardiophrenic angle. This is the costophrenic angle. Normally, it is very sharp. You know all that when there is fluid accumulation here, this gets blunted. Then you can see the diaphragm. Normally, the right diaphragm is higher than the left diaphragm by 1.5 centimeter. Then you have to see the hilum, which is mainly formed by the pulmonary artery. This is the shadow of the pulmonary artery, descending branch of the pulmonary artery. This is also pulmonary artery. Pulmonary veins sometimes appear when there is pulmonary venous hypertension. Then you can see in the cardiac failure, pulmonary veins appears and that forms the stag antler sign. Here it is not visible. You should try to identify all the bones. In the bones, clavicle is easy to identify. In the ribs, you are often asked in the examination that how will you identify the anterior rib and how will you identify the posterior ribs? You should remember that anterior rib is obliquely placed. This is the obliquely placed bony structure. This is anterior rib and this is posterior rib because it is horizontal. So after that, I think this is all a structure we have identified, which is possible to identify on the chest X-ray. And then I will tell you about the quality of the X-ray, how to assess the quality of X-ray after a few slides. And then I will also tell you how to say that whether it is PA or AP view later in the slides. So PA view, it all depends on how the X-ray goes. If it goes from the posterior to anterior, PA, you just put an arrow here, and easily you can identify what is the course of the X-ray. In the PA, there is proper positioning of the patient. A scapula is away because of this positioning. This positioning itself makes the scapula away from the lung field, and the heart shadow appears normal. So this is PA view. You should try to identify. In contrast to that, the AP view is often taken in the patient who is in the supine position. Therefore, the shifting of the scapula is not possible because we don't make the position in that position to take that X-ray. And often the heart appears larger than that. This is the common questions that examination often ask you. Okay, my time is up. Sir, can I have 5 to 10 minutes? Thank you, sir. Slides are not moving. So lateral decubitus is used when you want to detect very small amount of the fluid. Otherwise, it is rarely used now. So 2 or 3 things that you need to identify to check whether your quality of the X-ray is not. Patient must not have any kind of the rotation. You just check that whether that interspinous process are as the equal distance from the medial end of the clavicle. Then you have to see that whether the inspiratory efforts are proper or not. In a complete inspiratory effort, you should be able to see at least 10 posterior horizontal ribs and 5 to 6 anterior ribs. You should also assess that whether that exposure is adequate or not. That is again a technical factor. The easy way to understand that your intervertebral disc should just be visible. So these are the 3 things that you should know to say that quality of the X-ray is adequate. And after you look at the lung parenchyma, and if you find any opacity, you need to identify where it is located, because I told you, because of the overlapping factor, it is often not possible whether it is in the anterior lobe or the posterior lobe. So therefore, you can ask for the lateral chest X-ray. If it is located in the posterior part, it is in the lower lobe. If it is located in the anterior part, it is in the upper lobe. Otherwise, CT scan is a simple solution. If it is in the anterior, it is in the anterior lobe, and if it is in the posterior, it is in the posterior lobe. Now, when how a student has to read a chest X-ray, you should start with that. This is a chest X-ray of Mr. Show and Show. This is a PA or AP view of the X-ray obtained on this date. then you can start describing all the structure. That trachea is central in position. There is no deviation of the trachea. Cardiac seal heart is normal. And then pleura is normal. This costophrenic angle is sharp, and the diaphragm is normal. And then you can say that there is no bony abnormality, and overall this is a normal chest X-ray. This should be the way of reading in a examinations. So I think my time is up. So I had a lot to describe, but I am stopping here for the questions. If you have any questions, I will be happy to answer that.
For successful presentation, I really thank. And if any question comes from the audience or house, you may ask any question.
Any questions?
I think time is up.
Query? No query.
Okay.
Thank you, sir. Thank you. Thank you.
Now I request Dr. Shruti Kirti from Muzaffarpur, sir. Sir, please. And for chairpersons. Thank you, sir. Now our next topic is perioperative fluid therapy by Dr. Ravi Tiwari from Australia. He is online. And our chairpersons are Dr. D.K. Singh from Dhanwad, Dr. Ranjit Kumar from PMCH Patna, and Dr. Asutosh Kumar from Katihar. Dr. Ravi, you are online, please.
Yes, can you see me?
Thank you, sir. Thank you very much. Now I take permission from our chairpersons to continue the session. Sir, Dr. Tiwari.
Yes.
Please continue.
Okay. Just a second. What happened here? You can't see my slide, isn't it?
No.
Just a second.
Yes.
Sir, your
Okay,
slide.
okay.
Please share, sir.
Just a second.
Yes, it is visible, sir.
I think,
President, I'll be leaving. Thank you very much. No, hot no. It is
From
not
your
at all
side,
possible.
sir. Your video is visible.
31st March is the last day.
Are not being shared.
can you see my slide now?
Yes, sir. Yes, sir. It is
Very
visible,
good.
sir.
Sorry?
Yes, sir.
Okay. Thank
Yes,
you
sir.
so much
Thank
for
you, sir.
Thank you so much for inviting me. And it's a very, very emotional thing because of my personal contact with Patna, where I spent and grew up. And as you can see, this is how I look like. in theater scrub, though getting older day by the day. So first I will tell you that what do I do? Because most of the people in India think that Australia is Sydney or Melbourne or Perth. So I'm far, far away from Sydney and Perth. So I will tell you where do I work and what do I do, my bulk of work. And then I will continue the talk. Is it okay? So I live 1,200 kilometers north of Sydney on the east coast and 2,000 kilometers from Melbourne and around 4,500 kilometers from Perth. So the red dot which you see on the slide, that is Brisbane, and it is 280 kilometers north of Brisbane. My place is called Hervey Bay. It's a regional area. I work in a regional hospital. Initially, I used to work in the public hospital until 2010. Then I dropped half time and I was doing private. And since 2018, I'm 100% in private. So it's a very, very pristine area. You know, a lot of holiday makers come here to this town of Hervey Bay. As you can see, this is the sunrise picture of from the sea. So Hervey Bay area comprises, you know, it comes in wide bay area. You can see three big dots, Bundaberg, Hervey Bay, and Maryborough. These are the major hospitals, and all these small dots are small centers. So the population of Hervey Bay, this is a little bit old data, is 55 to 60,000 of this town. And the population density is 561 per square kilometer. In the wide bay area, there are about around 300,000 people live here in the whole wide bay area, which is quite big, around 48,000 square kilometer, and population density, as you can see, is 5.6 if you include the whole area. So my town or city, you can say, is you know, a lot of elderly population are here. The median age is 48, and people of more than 65 years of age are 28.1%. So majority, we do a lot of bowel surgery from bowel cancer and a lot of orthopedic surgery. So these two are the bulk of practice here. But we do everything like general surgery and lots of daycare surgeries. So this is rural medical school from University of Queensland where students come. So in Australia, students go everywhere. Like even in Hervey Bay Hospital, we get 6 trainees, college trainees, and my hospital is approved for basic anesthesia training. And here in this building, the medical students come, not the anesthesia trainees. So this is one of the private hospital, which is St. Stephen's Hospital. So in most of the cities, you will see private and public hospital across the road. So just across the road is public hospital, which is government hospital. So this is St. Stephen's Hospital. The uniqueness of this hospital is that it is fully digital hospital. So no paper used, everything is on the computer. This is Hervey Bay Hospital, and you can see underneath is the helipad for patient retrieval. This is another center. You'll be very surprised. It has got only 8 beds, and every weekend it is closed. And we do about 4,000 to 5,000 daycare surgeries and around 250 to 300 joints every year. And you can see on the side orthopedics, ophthalmology, and gastroenterology written, but we have started doing general surgery cases as well. So this is my theater chair, and this is my workstation. Behind me sits the surgeon, and he works on his computer. This is the layout of theater, and this is the nursing station. So one computer for the nurses, one for the surgeon, and one for the anesthetist. This is the recovery bay. Okay, so I'm going to talk to you about perioperative IV fluid, and I will just stick to the basics. And I'm not going to quote any studies here. So you will see this kind of IV fluid order, you know, IV chart, which we use across Australia. You go to any hospital, public or private hospital where they are using paper system, you will see this kind of chart. So here I have written normal saline 1 liter, 3.3 glucose in 0.3% saline with KCl 40 millimole 1 liter, and Hartmann solution 1 liter, to go, all of this has to go at the rate of 125 mils per hour. So you can order anything. So this is how we order on the paper. Or Hartmann, which is very, very not a good idea to give 3 liters of Hartmann or 1 saline. This is a bit better than the next one. And this is the worst IV fluid prescription for 24 hours. Normal saline, normal saline, normal saline. You see all sorts of combination advised. So what we are going to do in this talk, the objective is to understand the intravenous fluid, consider the patient individually. That is the most important thing. Like when I was doing cesarean list and I have registrar with me, all the cesarean patients are young, between 20 to 30, 35 years of age. So all patients getting spinal. So my advice to my registrar was that consider every patient as an individual patient, nothing like 2 mils of 0.5% heavy Marcaine is going to work in this patient and it is going to work in that patient as well. And we should follow the prescription with evidence. I was listening to the talk of Mr. Shiva Akshat, and he couple of times he mentioned in his talk about theoretical risk. So the problem in our practice is that, whatever theoretical risk we say, that is also a potential clinical risk. So always consider this. So don't take theoretical risk in isolation. So if it is a theoretical risk, it can be a potential clinical risk. And evaluation of the patient naturally is very, very important. So why do we give IV fluid? Sorry for the typo error, fluid is written. So water and electrolyte hemostasis to maintain this and also to provide nutrition. So this was mentioned by Dr. Shiva Akshat that, we first started using intravenous fluid in early 19th century when the large population got stuck with cholera. And in late 19th century, we started using saline in surgical patients. But right from the start, as you can see, from 1911 onwards, we have found that there are some potential harms of also giving, if you are giving intravenous fluid without any consideration. So there are danger of excessive salt administration, water administration, sodium retention, etc. Because most of the patients in initial perioperative phase are under stress, and there is huge surge of catecholamines. So that doesn't help in sodium excretion at all. And what did we found? In 1997, they did a study in UK, and they found that in the first few days, there is almost 7 liters of retention of positive fluid and positive sodium load to the extent of 700 millimole in the first few days. In UK, in 1999, they did a study in USA, and they reviewed the death of 13 patients, and they reviewed the death of perioperative death, and they found that 13 patients died solely because of overload of fluid to the extent of 67 mils per kg per day. So if it is a 70 kg guy, you can imagine that 1.5 liter of positive fluid was getting accumulated every day. They reviewed and they found in USA in the same year, this was a study was done by an author called Arif, and he found that 8,315 patients die per year just from pulmonary edema in the absence of any other cause. And that was published in Chest. They did one survey in UK and found that in UK, first year, foundation level doctors are responsible for prescribing fluid in 90 to 100% of the patient. And in the same survey, they found that 50% of the foundation doctors, they didn't know what was the amount of sodium in a bag of sodium chloride. So in nutshell, fluid balance is frequently missed just by poor understanding and also by some negligent approach. So the problem is not new, but the magnitude of the problem is definitely new because we identified in early 1900. So how much sodium do we need? We don't need sodium more than 70 millimole in an hour. And we need 1.5 to 2.5 liters of fluid in a day. Kidney is an amazing organ, and I call it a very, very deceptive organ because we don't identify its problem, which is happening on a regular basis, until really the problem becomes very, very grave and severe. So kidney plays a major role in maintaining extracellular sodium osmolality of the plasma. The other system in our body is renin-angiotensin-aldosterone system. The peculiarity of this system is that it gets activated very, very quickly, but you cannot suppress it. And that is the whole problem, which leads to retention of sodium and water both. So response to excessive salt intake is very, very sluggish, because when this system is activated, it retains a lot of sodium. And when the sodium is retained, what do we need? We need to suppress it, and we cannot suppress it. And how much is the role of antidiuretic, natriuretic peptide or for diuresis is not known. The other problem of giving sodium chloride is chloride ion, because it's a very, very potent renal vasoconstrictor. And one of the chairperson in the previous talk asked a very, very pertinent question, that what fluid we should consider in treating a patient of diabetic ketoacidosis, because potentially we do more harm when we are resuscitating the patient with sodium chloride, because it is going to potentiate the acidosis. So I will come to that later, that what we should use. So as we know, this is the renin-angiotensin-aldosterone system. If you remember the mnemonic Akash, it works on Akash. So Akash is arteriole. Here you can see, can you see my cursor? And K is for kidney, which, renin comes from kidney, and when it is activated to the extent of angiotensin 2 acts on kidney, and it secretes aldosterone, which causes further sodium conservation. And then it also acts on the sympathetic system to release noradrenaline, and it also acts on hypothalamus to release antidiuretic hormone. So all of it potentially causes problem. So when we use fluid, we should always remember this picture, because where fluid is going to retain, it all depends upon its solute content. So say, for example, in the case of sodium chloride goes to the total extracellular fluid. So if you are giving 1 liter of sodium chloride, only 200 to 250 milliliter stays in the plasma or in the circulation. If we are using 5% dextrose, it gets distributed throughout the intracellular space as well as the extracellular space. So it hardly does any work, it does not help at all. And plus we are giving a lot of water to the patient, free water, and it gets into the interstitial tissue and it causes edema. So basically here we call 5% dextrose poison. And my way of saying normal saline is that we all should stop calling normal saline. We should all call abnormal saline, because normal saline is not a normal fluid at all. So this is just a chart, and I won't go into the detail. You all know that there's so much of, the sodium chloride, which we call actually abnormal saline, contains 154 millimole of sodium in a liter bag and 154 of chloride. And its osmolality is so high, 308 calculated osmolality, though the measured osmolality is that of plasma. I'm not going to touch upon starch fluid because starch is almost banned here. We cannot use starch. We don't have 5% albumin freely available for, this country is highly, highly restricted. For everything you have to take permission. So even for 4% albumin, we have to ask permission from blood bank, and we have to fill up a form and put a justification that why do I want 4% albumin. The freely available starch, or not, you should not call it a starch, but plasma volume expander here is gelofusine, which is a bit different from Hemaxil, which we were using. So gelofusine is quite safer because it is succinylated gelatin, though it does not stay in the circulation for more than 2 to 3 hours. So, but for a temporary phase, if you have to give some fluid without giving too much of free fluid, you can use it on a temporary basis, which is, I'm talking about 4% gelofusine. So except 5% dextrose, all IV solution contains sodium and chloride. Whether you talk about Hartmann, which we call in India ringer lactate, or we call plasma light, or any other solution. There is always controversy between crystalloid and colloid. And the other problem is that we always give an individual touch in doing the prescription for these fluids. We don't use albumin, especially in sepsis. It causes a lot of harm. And starch should always be avoided in acute kidney injury because it makes it worse very, very fast. So we now understand that, in the perioperative phase, because of the catecholamine surge and activation of RAAS, renin-angiotensin-aldosterone system, it is difficult to excrete water and sodium, most importantly. There is risk of hypernatremia and hyponatremia also if you are giving salt-free fluid. And we all should be aware about chloride effect. Potassium loss plays a very, very important role in sodium retention because, it works through the exchanger. Okay. So how we are going to monitor, how we are going to give it, the main dilemma is that, we always consider that, if the urine output is falling, that means patient has got fluid deficit. But is it really true? No, because no antidiuretic hormone is there playing, it can cause oliguria in presence of normal volemia, but by mistake, we consider that it is because of hypovolemia. We give more fluid and we causes more harm. There is more sodium retention and more free fluid retention and causes interstitial edema. So what should we do to monitor the patient? Of course, here we start from basic history is the most important. So history of fasting, history of nausea, vomiting. So we have to replace all that. We do need to look at the fluid balance chart. We do look at urine output, and I've just mentioned that just looking at urine output, it can mislead us. Blood pressure measurement is never going to solve our problem because blood pressure, even in normal volumic patient, blood pressure can be low because of the effect of antihypertensive, especially when you're using when we are considering an old patient. So if you ask me what to pick up to monitor the patient, I will pick up patient weight. And then these again are misleading, like skin turgle, dry mouth, sunken faces, capillary refill, very, very difficult. I will just put a little bit of more emphasis here on urine biochemistry, and serum biochemistry is important, where you can say why it is important, because it can give you urine biochemistry and its correlation with serum biochemistry can give you an idea that what sort of fluid you should give to the patient. So that way it is very, very helpful. So I'm going to tell you a few recommendations here, and those recommendations are based on British consensus guideline for IV fluid therapy in adult surgical patients. And here I'm going to use some recommendation and level of evidence. Unfortunately, we haven't got very high level of evidence for most of the practice which we do in day-to-day practice. So most of it is based on low level of evidence. But if we have got some high level of evidence, we should keep it on our head. So So one of the good level of evidence recommendation one is that to avoid hypochloremic acidosis, balanced salt solution should be used in place of ringers, such as ringers or Hartmann. And normal saline should be replaced with this solution, because as I said, normal saline is never normal saline, it is always abnormal saline. Free water are important for maintenance of homeostasis and should be used, but with a lot of caution, especially in elderly patients. It can cause iatrogenic hyponatremia, especially in which patients? Especially in patients with diabetic ketoacidosis. But in diabetes insipidus, you need to give a lot of free water because now patient lose very, very hypoosmolar urine. Patient should receive 50 to 100 millimole potassium a day and 40 to 60, you can say, millimole of potassium a day. The recommendation say 40 to 48. And oral route is always preferred than enteral, and enteral is always preferred than parenteral route, though it has got very low level of evidence. The problem is that, you know, all the fluid which we give, we will give at least 1 liter of fluid, and all of them, like balanced salt solution, has got more than 100 millimole of sodium. So what should we use? We should mix it, you know, we should alternate it with glucose containing solution with salt. And I put a lot of emphasis on this. Why? Because, you know, our liver has got only 200 to 300 grams of glycogen. And patient is fasted. You are not going to allow orally to the patient. If patient is going to have abnormal surgery, in orthopedic surgery, we allow patient oral straight way. So we should give some form of nutrition in the form of glucose. In patient without the disorder of gastric emptying and who are going to have elective surgery, they should be allowed oral fluid up to 2 hours before induction of anesthesia. Like tomorrow, I'm going to do my first case tomorrow is knee replacement, and we start theater at 8 o'clock. So what I have done, I have asked the patient to have a cup of tea or coffee, because most of them in this country love to have a cup of tea or coffee, black tea, and 1 bickies with it, 1 or 2 biscuits, because the biscuit is not solid, because the moment biscuit goes in, it becomes semi-solid. And if you are keeping patient fasted for a long time, it delays the gastric emptying, and there are more chances of nausea, vomiting, as opposed to if you feed the patient, gastric emptying and motility is preserved, and there is a lot less chance of nausea, vomiting. In the absence of disorder of gastric emptying or diabetes, preoperative administration of carbohydrate-rich beverages 2 to 3 hours before induction of anesthesia may improve patient well-being and facilitate recovery. And this is very, very important. And what do we do here? We give patient clear apple juice. So it gives nutrition as well as it gives water to the patient, and it puts, you know, the catecholamine surge. It has been studies. If you will read a lot of papers on early recovery after surgery, they don't keep patient fasted at all. Even for abdominal bowel surgery, they don't prepare the bowel, because now when we are doing bowel preparation by mechanical means, the patient goes into the deficit of 1 to 2 liters of fluid, at least an adult patient. Routine use of mechanical bowel preparation, I just said, is not beneficial, and it may complicate intra and post-operative management of fluid. Where mechanical bowel preparation is used, fluid and electrolyte deregument commonly occurs, and it should be adequately replaced with balanced solution. Excessive losses from gastric aspiration, vomiting should be treated appropriately with crystalloid solution. And here we go. In this kind of patient, it is good to administer abnormal saline, it is normal saline, and with potassium supplement, because in vomiting, especially, you know, like when we do pediatric surgery for hypertrophic stenosis of pylorus, they are very, very deficit in sodium, chloride, and potassium. So we have to give in those selective cases sodium chloride. And loss of fluid from diarrhea or ileostomy or small bowel fistula should be adequately replaced, because from those areas they lose a lot of potassium. In high-risk surgical patient, preoperative treatment with IV fluid and inotrope should be aimed. So early institution of inotrope is advisable rather than giving fluid and causing edema and positive fluid balance. And the whole goal is to maintain the cardiac output, to maintain oxygen delivery to the tissue. And this has got a very, very high level of evidence. Preoperative and pre and intraoperative hypovolemia should be diagnosed by flow-based measurement. And that is very, very strongly advisable these days. I'm sure you'd be aware about use of flow track, with Edward system. And it has got a very high level of evidence because, that gives a very good status of patient volume. And of course, hypovolemia predominantly due to blood should be treated either by balanced solution or colloid. As I said that, for short term to maintain it, we do use gelifizine here. Hypovolemia due to severe infection should be treated with either a suitable colloid or balanced salt solution. I'm a bit late. Administration of large volume of colloid without sufficient free water may precipitate hyperoncotic state. And there is always crystalloid is preferred over colloid, and it has got good level of evidence. So I won't go into the detail because most of the important thing we have covered. The only strong message is that don't give fluid just because, if you're doing it just for the sake of giving it, always consider patient individually and treat accordingly. So here I will end because this talk is endless, and I pay my tribute to my first guru in anesthetic, under whom I did my diploma in anesthesia at Patna Medical College in 1991-92. And I invite you people to ask me any question, please. Do you have any question? Hello?
Any question from the audience?
Audience must be very hungry just before lunch, and it is already late.
Thank you, sir, for your nice update regarding perioperative fluid therapy. Thanks again, sir. There is no question. Thank you, sir, again.
Okay, no problem.
It was nice.
Thank you, sir. Thank you,
presentation
Ravi
of
Tiwari, sir.
excessive use of sodium chloride.
Thank you, sir.
Just
Now I
remember,
call-
don't call normal saline. It is abnormal saline, and that is how you are going to stop its use.
After this presentation, we will call normal saline.
And one thing more, I forgot to mention about fluid replacement in diabetic ketoacidosis. The best solution in diabetic ketoacidosis is plasma light, because plasma light has got sodium gluconate and acetate, which gets converted into CO2 and water. And in that order, it consumes a lot of hydrogen ion, and its pH is 7.4. If you compare it with Ringer lactate or Hartmann, its pH is also around 4 to 6, around 6. So 7.4 pH with the presence of sodium acetate and sodium gluconate really helps a lot in maintaining, correcting acidosis. And it has also got the potassium and magnesium, which is very, very helpful in maintaining potassium homeostasis in diabetic ketoacidotic patient.
Thank you, sir.
Thank you, sir. Now I call Dr. Vinod Kumar Kashyap, sir, HOD PMCH Patna, to give mementos to our chairpersons. Respected DK Singh, sir. Dr. Ranjit Kumar, sir.
Thank you, sir. Thank you very much. Our next topic is how to write a thesis. For that, our speaker is Dr. Amit Rastogi, sir. I think Amit sir is online. Yeah. And now I call our chairpersons, Dr. Rakesh Kumar sir from Katihar and Dr. Rajdeep sir from AIMS Patna. Sir.
Start, sir.
My screen is visible.
You can start, sir.
My screen is visible.
Slide is visible, sir.
Lights are visible. Voice is clear.
Voice, there is some problem with the voice. It is, you move slightly away from the microphone, I think.
Is it better now?
Huh? Slightly better. Yes, sir. Yes, sir. It is okay now.
Okay.
You can start your presentation, sir, please.
Okay. Thank you, team ISACON East Zone and the team ISACON Bihar Jharkhand Anesthesiologist Association. The theme of the conference is anesthesiology beyond the pandemic, and this pandemic has taken a toll on everything. It has taken toll on in the terms of human life. It has taken toll of in the terms of academics, and so is the thesis. So thesis has been severely suffered in the last 2 years. The batch who have passed the thesis preparation has actually very much suffered. Submission has also suffered because of this pandemic. So I pray that this pandemic gradually weans off and we can start our thesis work of our students in a very proper way. So I will give in this 20-minute presentation, I will tell you how exactly a MPG student should write a thesis once his protocol and study is complete. So our main objective to giving thesis to a postgraduate student is to teach the basics of research, aiming at improvement of scientific temperament of postgraduate students. So basically what we meant in a postgraduate student, that basically by the help of thesis, he is able to go through the research and methodology, learning of research and methodology of the subject and of a particular topic. So that is basically aim of a thesis. Thesis is basically a proposition where an effort is being made to propose a new thing or concept by a guide and the student. And a hypothesis becomes thesis if the proposition is being delivered with a proof in the form of statistical data and analysis. So whenever we talk about thesis, there are few headings in which it has been written by a student. First is the title page, which includes the author's name, the institution, affiliations, his department, the date of submission, and the other relevant things. Along with that, there is table of contents, which includes what is the contents of the thesis, certification by the guide, declaration of the authorship, list of table and figures, acknowledgements, dedication, and abstract. So the first thing, whenever we read a thesis, whenever any reader goes through a paper or thesis, what he reads is the abstract. The structure of a thesis, the common questions every thesis must have: what, why, where, who, and how. So these 5 questions are very important, and they basically constitute the structure of thesis. Suppose, for an example, we want to study PDPH in post cesarean section parturient patients. So we have to study what is PDPH, what is the incidence of PDPH, why you want to study PDPH, why you want to do a study related to PDPH, where you want to do the study, who will be included in this study, and how will you do the study. So till the methodology, the structure of thesis is basically till the methodology. These things you already have been decided in your thesis protocol. So these 5 questions are basically forming the structure of the thesis. I'm Bradford in Hill in 1965 evolved the AMRAD structure of the thesis writing. It has 5 structures and has been universally followed in the medical fraternity: introduction, material and methods, results, analysis, and discussion. So most important thing of anything, whenever somebody picks up your thesis, whenever your guide or some teacher or examiner takes up your thesis, or any, for that matter, you make a paper of your thesis, the first and most important thing is the abstract. So abstract is very much important. Why? Because it is standalone. It is basically the bird's eye view of your of the project that you have done. Basically, it's a distillate which concisely describes the problem addressed, its possible solutions, and the results and conclusions. So usually abstract is the main, abstract is what you say, the distillate of your project, and it is self-contained. Abstract usually don't contain any references. And if you require any references, then details should be included in the text of abstract itself. So abstract is usually doesn't have any reference. And if it is imperative to put a reference in the abstract, the text is then and there provided in the abstract only. It shouldn't come in the references list. So that is very important. Abstract tells why the study was done. You have to answer 5 or 6 questions in your abstract. Why you have done the study, what was exactly done, how it was done, what was found, what was concluded, and why does it matters to the medical society. So you have to answer 6 basic things in the abstract. And the most important thing in the abstract is that you have to stick to maximum of 400 words. You have to complete your 400 words abstract within 400 words. It should be clear and concise and avoid unnecessary details. And abstract is best written when your thesis work is over. So abstract is basically a concise distillate of your project, and it has maximum you can write up to 400 words into it. Now with AMRAD classification by Bradford Hill, we have to go for the first part of the thesis, that is the introduction. This introduction basically describes why you took that subject for your project. Why this particular topic? You have to describe why you want to take this particular topic. Why have you taken this particular topic? Aims and objectives of your thesis. Important scientific problem that thesis either solves or addresses. So you have to tell about what exactly the scientific problem you are addressing up to, and why, what will be the sufficient interest to motivate readers. So introduction is basically the first introduction. Basically, you tells why you are taking up this project and what is actually the problem that you are going to address. So this is introduction should be smart enough to attract the readers, so that even after 4 or 5 reading the sentences, he is able to he decide that yes, I will go ahead with the topic. Relevant background information must be given in the introduction in the form of literature review, what has earlier been done and what is been still going on this particular topic. And you have to tell why further work is necessary, why your thesis on this particular topic is important in further way. You can provide all sufficient references and give citations of all the references in this particular heading. A good introduction is very important, and you must know your project, the body of your project, the complete body of your thesis in and out. So it is usually advisable that you write introduction once your dissertation work is project completed. So then only if you write introduction when your project is complete, it will be a complete introduction. And it is a very good idea for all the postgraduate students. If you want really good introduction, go to a person who is from other branch, go to your medicine colleagues or surgery colleagues, and ask them to read your introduction. And ask them whether it is sufficient enough, whether it is able to carry the information, because those who is from anesthesiology, they can easily understand the topic. But Your paper is for the mass, it is for the public, because your thesis and your paper, further paper, original article is for the mass. So it's better that some person who is not very much into your subject read this particular introduction, and then you can take feedback from him whether your introduction is smart enough to gives a glimpse of the topic that you are going to touch further. So now the next topic is the objectives. The objectives in which you have to summarize what is to be achieved by the study. Suppose you want to do a study on postdural puncture and neck, then you have to study what exactly. Suppose you want to develop a new drug or a new technique in reduction of the pain in PDPH. So you have to summarize what exactly you want to achieve with the help of this study. Clearly phase in operational terms, specifying exactly what you are going to do, where and for what purpose you are going to do, and use action verbs which are specific enough to be evaluated. Now, the most important thing of any thesis writing is the material and methods. It answers what and how of the study. The information that has been given in material method should be complete. Complete in the sense that if some other author wants to do, or any other projects want to do the same thing, he is able to replicate all the things. So you have to provide information required by another researchers so that he can replicate your study. Another important thing in material methods is that you have to give ethical clearance, whether it has been taken, whether your thesis is ethically cleared or not. And nowadays it is very important that you go for clinical trial registry. So once you write a thesis protocol, you apply for ethical clearance and the clinical trial registry. After ethical clearance, you can go ahead with the clinical trial registry and get a clinical trial registry number. So that is very important. These things are very important nowadays. Now, you have to describe how the study was designed. You have to be very simple. Description should be in a very brief. How you have recruited the subjects, how you have done the randomization, whether you have simple randomization or you have done the randomization technique. You have to tell how randomization has been done. You have to tell what was your study design, whether it was randomized control trial, case control study, cohort study, prospective study, retrospective disease, cross-section study. You have to tell about your study design. You have to tell information about the data collection tools and techniques. You have to tell about how have you done the follow-up, the duration of your follow-up, duration of your study, whether your duration follow-up was complete or not. You have to tell about the dropouts. And again, it is very important that you mention about the pro forma or the format of your data collection. Another important thing is how the study was carried out throughout the period of the duration of the study. Then inclusion and exclusion criteria is also very important. You have to describe about which patients were included and which patients were included and why they were excluded. You have to give reason why these patients were excluded. You have to also help to tell about how the recruitment was done and how the patients were taken or chosen into your study. Give accurate details of the materials that you have used. If you have used drugs, and then dosage has to be given in accurate form. You have to give exact form of the treatment that you have given to the subjects and the controls both, and accessible details of unusual apparatus. If you have used unusual apparatus or a technique, you have to tell about that thing also in material methods. Any modification or deviation from the standard technique or protocol, then you have to again mention in the material methods. Now, it's very important how the data were analyzed. Use p-value to disapprove the null hypothesis. Give an estimate of the power of study, likelihood of the false negative error in the sample size, how you have calculated the sample size, and you have to provide exact test whichever used for the statistical analysis. That gives about material method. The material method, description of material method is very important for the purpose of that if some other persons, if some other author want to do the same dissertation in a similar way, or he wants to further strengthen your study, further wants to check your study, then he should be able to replicate your study. So the main purpose is that he should be able to replicate your study, and all the methodology should be very correct for that purpose. There should be no ambiguity in it. Now the next part is the result of observations. So simply the result is what was found. It is the core of your discussion. Exactly whatever you have done till method was for results only. The result is the core of your dissertation. You have to tell how comparable your groups are in the terms of demography, in the terms of age, in the terms of body mass index, and so on and so forth. You have to tell how your groups are comparable. You have to include all the tables, statistics, pie charts, photographs, figures that you have decided in methods. All possible details obtained are displayed. Others, so that other can draw their own inferences explanation. So you have to put as it is. The result should be given as it is. All possible details are displayed in your results. There should be nothing to be whatever you have obtained from your observations. You have to tell in the results, so that you will make conclusions, but it should be presented in form that others can also draw their inferences and explanations. Other important thing is that you have to follow the SI units, or the systemic international units, or the metric units has to be followed when we are using the headings, when we are using the units in the results. All results must have a subheading so that it becomes easy for the reader to read about what exactly the results you're talking about. And key results should be written in clear sentences, and it should be written at the beginning of paragraph. It is very important. The result, any paragraph should be begin with the results at the beginning. So you just write the results and at the beginning, and then you can elaborate your result. And results are to be served unbiased and as it is. Whatever you have obtained, you have to straight away put in that way only. And in result section, you will never interpret the result. You will just give that I have found this, I have found this, I have found this, but you will never try to interpret but what others have found and what is the possible scope in further possibility. So just have to put the result as it is. Language, you have to use past tense because you have already done everything before, and now you are writing your thesis. Try to be concise and clear. Short length of results make reader more comfortable. Don't try to frame long sentences. Short sentences will be very easy to understand by everybody. And if you found an unexpected result, you have to also put into your result section. And don't try to give results to a greater degree of accuracy than that of the measurements. Again, avoid using percentage unless the groups have more than 100 subjects. So if your subjects is having more than 100 number, then only use percentage. Otherwise, don't use percentage. When considering results, give number of subjects, range of results, central tendency, and spread in the form of confidence interval for the mean you have to give. All tables and illustrations should have an appropriate legend. Never forget to put an appropriate legend for table and illustrations. And don't carry it away with the computer graphics. Suppose if you want to put large amount of graphics, then it will be unnecessary and it won't be add anything. So it is very clear that if the number of subjects is more than 100, then only use percentage. And all table and illustration must have a proper legend, and don't get carried away with the computer graphics. Now there are few key points in writing table and graphs. Decide between table or figure as per your objective. What you want to actually display in a better way. Always common numbers beyond 1000 and above. Don't always the comma the number so that there is no ambiguity. All numbers are to be written in the same decimal points. On both figure and table, avoid footnote and subscript. You should always don't put subscript or footnotes on figures and table. And figure titles go below, and table titles go above the table. So table titles are at the top and the figure titles are below. That is very important. You have to follow. Now the important point is the discussion. Discussion is basically exchange of knowledge, while argument is an exchange of influence. So discussion is you are going to describe whatever results you have obtained from your research work. You will describe in brief about them. So it basically tells what does the results actually mean. It is a brief essay in itself, and discussion must be opened with most relevant result. So whenever you're going to write discussion, the most relevant part of your study must come in on the first come first basis. So discussion must be opened with the most relevant result. Present principles, relationship, and generalization observed in the results. Agreement or disagreement with the previous work. So whatever results you have found, whether they agree or disagree with the previous work done in the same topic. Interpretation of results in terms of background laid out in introduction. What is the relationship of the present results to the original question? So this tells us basically you are interpreting your results in the term of whatever the background you have laid down the review of literature and background you have done. You are interpreting results on that basis. And what is your results in comparison to the original question? What is the relationship? You have to describe that part also in the discussion part. So in discussion, you have to tell about your results, your agreement or disagreement with the previous work, which has already been done on the same topic, and interpretation of results in the term of background laid out in the introduction. What is the relationship in between your results and what the introduction and the review of literature that you have done? It is a detailed analysis. Hypothesis testing is we have done. If your result agree or differ with hypothesis, then provide explanation of relevant hypothesis. If your hypothesis agree or disagree, then you have to provide explanation of relevant hypothesis in this part. Sources of error. You have to also tell what was the error in your experimental tools. What were your design problem? What was your experimental error while you are collecting data? That have influenced your ability to draw conclusions. So in this discussion part, you can tell whether what was the experimental error, what was the error in determining the data, what were your data tool mistake, you can describe in discussion. And you can also have to tell about the alternative model, about the explanation of your data. You also have to tell future of your project, of your thesis, where the research might go next and what questions still remain unanswered. So you have to tell about the drawbacks of your tool, of your data collection tools, of your technique. You can tell about what could be the alternative model for our project, for your project, and what is the future of your project, and what questions still remain to be answered. That has to be covered in discussion. References, only relevant references have to be kept in discussion. All unnecessary and irrelevant elements which are not related should be omitted. And differentiation between observation and interpretation should be maintained. Now, the last part is the conclusion. Conclusion is basically the panoramic view. Brief statement about the goals and contents. Includes strongest and most important statement from the observation. So this basically conclusion tells about the strongest and most relevant and important statement from the observation has to be done. You have to summarize about new observation and interpretation. You have to tell about the strength of your research and limitation of your research. And you also have to tell about the recommendations for further research to fill gaps in the present understanding. So that is very important. In conclusion, you tell whether your study, apart from telling about the relevancy of your topic, the important observation from the topic, the other thing that is important is you have to tell about the strength and limitation of your research. Where your strength, what was actually the strength, what exactly that the data that have you obtained has concluded in a very positive way or in a negative way, in both the ways, and what is the limitation of your particular research, and how you can correct it in further researches. So recommendation for further research to fill the gap in the present understanding. Now the last part is the references. You have to cite all ideas, concept, text, and data that are not author's own work and do not constitute present work. So whatever you have cited, concept taken from other studies, text and data taken from other studies, that is not actually your work, and they are not part of the present work. You have to tell them in references. All statement to be made in thesis should be backed with data from a reference. So whatever statement that you made must be backed up from a reference. References in text should be numbered in sequence in which they appear. So you have to give numbering to your references, and in the same way you can use them in the references list. And for that purpose, just starting from your thesis, you can use a reference manager. Reference manager is available. The reference tools are available in the form of Zotero and EndNote. You can use any of them from very inception of your thesis, writing of your thesis, so that it's become easy to arrange the references. And there are lists. There are still listing styles of references, which is the Vancouver style and the Harvard style. So most commonly the Vancouver style is used, in which you can list, and how this Vancouver and Harvard, it's very easily, you can see the internet and you can see how exactly the references has to be done in Vancouver and Harvard. The Vancouver style is most commonly used these days. A references list is a detailed list of references that are cited in your work. And bibliography is a detailed list of references cited in your work, that is the references plus the background reading or other material that you may have read but not actually cited. So there is a difference between bibliography and reference list. And in bibliography, you also have to add the background readings or other materials that you may have read but not actually cited in the text. Now the last part is appendices. all data pertaining to the study will be attached in the form of appendices. If there is material that should be in thesis, but which would break up flow of bore of the reader, it is included in appendix. So we usually include all the data in the appendices. And if the data is too big or it is too large or huge, that it will bore the reader and it is not going to generate interest in the thesis reading. So that has to be included in appendix. And this usually include the master charts, the list of equipments, details of complicated procedures, table which is having more than 1-2 pages are used in the appendices, or any pro forma that you have made, you can attach in the appendices. Finally, to conclude is, there are 3 aspects: the structure, substance, and the style in a thesis. We have to think, plan, write, and re-revise our thesis. A good thesis protocol is very important to complete the thesis and efficiently write a thesis. Keep in close touch with your mentors. A 3-monthly assessment of work will help in reduction of errors, and check your university guidelines on thesis production before final printing. So with this short lecture, I would like to finish off. Thank you very much.
Thank you, sir, for nice presentation on the important topic for PG students and for learning our. So any question from postgraduate students and faculties?
It is actually a very dry topic, and it's mainly a part of workshop. But then I try to cover every topic. And the most important thing is the thesis protocol. If you have got a good thesis protocol, and then only you can go ahead with your thesis, and then you will have an efficient thesis writing for that purpose. So thesis protocol, a good thesis protocol is a must for a good thesis.
But yes, a question is, I'm talking to a question. Sir, they always ask question by the students for the writing the thesis. What is the difference between the abstract writing and the proposal writing and one page concept writing? And the other is what should be the priority of the paper review first or last? This should be clear by you, sir.
Thesis protocol and one page, right? One page concept is basically in that one page concept you propose a protocol, and that protocol presentation you have to one A4 size paper you have to complete within 1,000 sentences. You have to complete. Suppose you are putting your paper for not for a proper thesis, or for a project submission, then you have to write. There is a particular protocol for that, and every association has a different. But for one page concept paper, you have to tell in brief about what the concept, just like concept of thesis protocol. You have to tell about. You have to introduce. You have to tell what previously has been done, what you want to do, and what exactly you have to disclose everything. You want fund for that, then you have to tell about the funding of that, and then you also have to tell what will be your methodology, how exactly you will be doing this project, and then you have to disclose about how methodology will be. Then you have to tell about the complete methodology in just a very short description, and then you have to tell about what do you expect the outcome. So in this space, you have to tell a one-page statement for that. This has basically been deposited in when you are applying for a project for that purpose in one-page statement.
Yes, sir.
It should be brief enough to explain everything, whatever.
The other question was, sir, what should be a sequence of the paper reviewing, sir?
Sequence of paper reviewing, in the sense you want to peer which paper, original article submission or for a thesis submission?
For the thesis.
For the thesis,
yes, sir.
Thesis is basic. Yes. Thesis is thesis is basically written under the guidance of a mentor. So guide is always there, and then thesis is being reviewed by a board first you write the thesis protocol, which has been reviewed by the board. Then you get you go for ethical clearance. The ethical clearances part. Then you go for CTRI registry these days. You get the CTRI number. Then you write the thesis in all the following headings with your mentor. And then your mentor checks the mentor reviews your thesis, and then your thesis goes to the dean for the review. And then after that review, it goes to your MD examiner, and then he checks before the exams. He checks the thesis and he tells it whether the thesis is up to date or not. And for the DNB exams, the thesis goes to the national board, and then there is a particular board for that. It reviews your thesis. It sees whether your thesis has complete all the criteria or not, and then only the thesis is being approved that it is a part of your MD or DNB exam. You can successfully you can give the examination when your thesis is approved. So in this way, that review has been done.
One more question, sir.
Yes.
One more question, sir.
Dr. Amit, Prakash Dubey here.
Sir.
I just wanted to know whether we can have a pilot study as a thesis topic or not.
You can have a pilot study.
Right. Thank you so much.
Sir, one question from my side, sir. How many references should be put in introduction part, and how many references should be in a discussion part, sir? Is there any percentage?
Percentage, actually, I'm not aware of percentage, but your references should be preferably within 10 years, the first thing. And references should not be too exhaustive related to the product only. Usually 30 to 35 references are enough. Putting too much of references and putting references on established data is not a standard practice. If the references are kept within 10 years, so if you will find a reference, you will not find more than 30 to 35 references within the last 10 years. So 30 to 35 winners, how much introduction discussion that is, actually, I don't know actually.
Thank you, sir.
Thank you.
Is there any question from audience?
Yes, sir. Good afternoon, sir. So what is the difference between bibliography and references?
References,
bibliography.
I tell you, bibliography, I just told you. Detailed list of references that you have cited in your work, that is references. And there are many things, that background readings that you have done or other materials that you might have read but have not actually cited, that is bibliography. So references, you put number on the reference and then you put in the reference list. And when you talk about bibliography, in bibliography you have to tell about references along with that background readings that you have done. Suppose you have read a book, suppose you have seen a website, so that you can put in bibliography, but that will not come into a reference list.
Okay, sir. Thank you, sir.
Any other question? Any other question from the student side? So as there is no question, so we'd like to conclude this section. Thank you very much, Amit Rastogi sir, for being a part of this conference. Thank you, sir.
Now, I request Dr. Jitesh Kumar to hand over the memento to our speakers. Dr. Tiwari sir. Hello. Dr. Tiwari sir. Sorry. Dr. Rastogi sir.
Please unmute yourself. Amit Rastogi sir, please unmute. Yes.
Sir, your memento will be sent to you.
Thank you.
Sir, your memento will be sent to you. I don't know why by post or by email.
No, sir, that is.
Thank you, sir.
Thank you,
sir. Thank you. Now I request Jitesh Kumar to hand over the memento to our chairpersons. Prabhat sir. The next topic is how to answer in theory and practical examinations. This is basically meant for our PG students and DNB students. The chairpersons are Professor Ajit Gupta from Sasaram, Professor Gurmukh Prasad from NMCH, and Professor Jitendra Singh from Bhagalpur. The speaker is Professor Prabhat Tiwari from SGPGI, the renowned teacher, and he will guide us how to answer the theory and practical examinations. Prabhat sir.
Hi, good afternoon.
Sir, please continue.
Okay.
Sir,
Well,
okay, sir. Thank you, sir.
I hope my slides are visible to you.
Yes, sir. Yes, sir.
Okay. So this topic is very interesting, you see, because since the advent of NEET, somehow the doctors have actually forgot to write and answer some questions, you see, and they are just in the habit of putting dots and dashes. But I have tried to make it only a very inspirational lecture, you see, so that you enjoy it. So just sit down and just enjoy my talk. And I think by the end of this, you will get few points which you can use during your examinations. Well, this is me, and there are no disclosures as far as this talk is concerned, and anything which is shown here. And so let's go back to the education and how you answer. I think all of you who have listened songs in the last 3 decades before, they must have actually learned and heard to Pink Floyd's Another Brick in the Wall, and they said that we don't need no education, right? We don't need any thought control in the classroom. But actually, they said that education is building out bricks, and we do not want that to happen. See, there should not be bricks. And we can have actually the proper education. So what education is that way? Are my slides visible? Hello, is it visible? The screen is visible? Hello? 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 Am I, are the slides visible? Are the slides visible? Hello? Hello? Prakash.
Your slides are visible, but the sound is a lot of echo is there. So it's not very clear. Please distance away from the mic, I think, please.
Okay, are the slides visible now?
Better.
Can you see it? Can I see the person who is managing your camera in the hall? Can you focus on the screen?
Yes, sir, we can hear you.
All right. Yeah, that is something. I can see what I'm showing. All right. So see, education starts with a good mentor. And here in this picture, I've shown who the mentor is. The boy who's here, that is the task of the mentor, actually, right? And this is the mentee. He is actually helping him out in doing the task, but he is not doing the task for him. So that is what a good mentor is. So whenever you are guiding and training and all, a good mentor is very essential. Because from here, these are the roots from where you actually build up how to answer to go for the examination. Because it is examination is only you are writing something, but you are actually looking patient. So you are going with the examination every day. That's how we have to take the examination, so that it is not only one day phenomena, but actually it is a 3 years learning, and every day is an examination. Then it becomes very easy for you. And always remember that knowledge, whenever like you answer the question and all, what actually you need is good knowledge. That is the power. That is what you want, you see. So gathering knowledge is very important. And one more thing, I like this person, this Hollywood character here, right? And this Johnny Depp, you know, he once said that, well, it is the love, right, by which you live and for which you live, and therefore you love thy subject. If you have become an anesthesiologist, you love that subject, right? And then only you will deliver, right? As long as you keep on training for your MD, for your super specialties and all that, you keep on loving the subject. Every day will be the examination. You keep on gathering the knowledge with reading the subject and also doing the collateral learning. That is what's important, you see. So knowledge is the trust. That is the key. And throughout your course, you have to build up a confidence. That is very important, you see. So that is how you actually, more knowledge results in more confidence building. And as I said, collateral reading is very important. Always remember, anesthesiology, it is not only that you just take one book and just read it from cover to cover and that is it. No, see, we are the cardiologists to begin with. As far as like ECG, you are dealing with ECG from the day one. You are handling anesthetics in the OR or in the ICU or anywhere else in the distant suites of like cardiology or any other area. You see a distant anesthesiology and all. So you have to read collateral reading. You read obs and gynae also. You read cardiology as well. You read cardiac surgery as well. You read other surgical knowledge and skills that you have to read along. That is what's important, you see, to actually bring in lots of knowledge in you. And now, once you have this knowledge and the experience of 3, 4, 6 years, then actually your examination is a kind of mill in which you place knowledge and experience, and you run it with the process of your memory and the way you answer, right? And that it will churn out either degree or diploma for you. So that is actually what's all this. This is the gist, you know, to understand. Then only you'll be doing it properly. And that is why knowledge and experience are very important, you see, to answer any question. And always remember that you have to gather knowledge. You have had enormous hard work, but it should not become counterproductive. So mock practices and all, if you are actually going for an examination, that is important, right? So you actually do ahead. Once you gather knowledge and all, and once you are approaching the examination, then actually you keep on doing lots of mock practices that will help you a lot. Now, when you are actually looking at the examination paper to answer in some limited time, you read, there is a format of doing it quickly. Read all questions, right? Look at the format of the questions. And also, immediately you build up the time management, how you are going to answer. It's not like you finish off all the time for writing only one question and rest you leave it like that. No, you will not garner marks on that, you see. And you build up argument for each and every question. And you do it in the first few minutes. That is how you actually go ahead. And always remember, when you answer a question, you structure it, right? So key of gathering marks is you structure your answer. Always remember that. It puts in lots of impact on the examiner. So structuring is very important. Means a forceful beginning, a good supported middle part, and an end which actually gives the direction. That is what's important. So, and always remember, whenever you read a paper question, you see you keep a pen between your fingers or a pencil between your fingers. Because what happens, your mind, right? It is getting some kind of information. It is started actually analyzing that information, and then it wants to do as well. So if you give some physical direction to this working mind of yours, right, your mind will become sharper and it will actually gather answers faster. So it is a good practice to hold a pen in your hand and you just scribble it, right? Answer at the back of the question paper, you can just scribble few questions for answers or points or something on which you are going to actually elaborate when you are writing your answers. And always remember, I like this part of this, your traffic light, the middle light, what you call as the yellow light. Always remember, you are reading, you have stopped, you are red light, you are reading it. Answering, writing answers is the green light, but between them is the yellow light. So you have to think for a minute on that answer, how you are going to structure it and how you are going to answer it. Now let's take just an example, like how mixed venous oxygen assessment can help in goal-directed therapy in ICU. Supposing we get this kind of question, right? So you actually underline some key words on which you are going to elaborate, like mixed venous oxygen, its assessment, and the goal-directed therapy, what all these are there. And always remember, you read with the context, that goal-directed therapy, where it is happening, in the ICU, in the OR, what kind of patient you are doing. Because if you are thinking out of context, then you will not fetch marks. Like this boy, you see what he is answering for the value of X. So how we are going to go ahead with it, right? Then mixed venous oxygen, we have to actually define what mixed venous oxygen is and how it is assessed and how this assessment is actually going to help us, right? So that becomes the introduction part of this question. And then how this is actually building up the goal-directed therapy, right? Why this is important, that you structure it, you read the few key words and try to elaborate upon it. Let me really emphasize upon you. You write for 3 hours. You know how much time an examiner takes in answering or in evaluating your 180 minutes of effort? Not more than 5 or 6 minutes. So always remember, it is only the structure. He finds the structure is there, your image is built up. He finds, well, the question major points are there in the introduction. Oh, you have fetched 50% marks. Always remember that. And then after introduction, you go back to your second paragraph, right? And here you have to elaborate upon, right, what is actually this mixed venous oxygen is doing with the goal-directed therapy, how it comes in. So you have to actually make a link between them, and that has to be properly deciphered and written in clear language over it. And once you finish it off, right, actually you sum up that what actually you gathered from mixed venous oxygen and how it changes during the course of your patient and how it is actually used to actually direct the goal of the therapy, means maintaining the hemodynamics. That is how you enter. Nothing more, nothing less. So how you conclude that question, right? Goal-directed therapy must target a return of how much mixed oxygen saturation, right? And this can be actually guided or supported by the fluids, right? And how you are actually looking at the fluid management, well, non-invasively, that becomes very easy if you are looking at the stroke volume variation. So that becomes also a part of your goal-directed therapy. So that is how you have to do it. Another question, like mechanism of hypoxia in COVID-19 disease, it is 4 marks. And oxygen therapy in these patients, 6 marks. So always, immediately, your question is also structured. It shows that, well, mechanism of hypoxia, it is actually 4 marks, means you have to actually tell the whole story very quickly, sharply. It is better if you build up a very good figure and you tell the process that what is all is happening with that disease, right? And for oxygen therapy, you actually start from the basic to the maximum, right? From the simple to the complex, right? From the simple oxygen mask to ECMO. That is how, and few words and all that, and that will help you out with this kind of answer. And few other things, right? Einstein said, out of clutter, find simplicity. So as simple you are, right? Your actually answer must stand out for the question, for the examiner to see immediately. It's needn't be very much cluttered, okay? And always remember that Einstein has also said that things must be simple, but not simpler. You see, the way Peter is actually solving this answer, you needn't do that, right? So it is not that it's just a simple statement that, well, mixed venous oxygen is helping in goal-directed therapy. No, you have to actually sum up critically and put in some extra knowledge in that, extra information, which you have actually gathered by your readings, collateral readings throughout your 3 years. That is how it makes the difference, right? And few other points whenever you are answering or writing papers is, I have seen the people develop self-doubt. They read the questions and answers and suddenly they think that, well, they don't know. But actually, if you hold the pen, right, and always remember, if your mind you have read the paper in the beginning, all the 10 questions, right? And if you are solving your papers from one question to the other, your mind is working on all the 10 questions simultaneously. And you may have a sudden thought somewhere about question number 10. Then suddenly you don't ignore that thought. Immediately put the point at the back of the sheet so that once you start writing on the question number 10, you use that point again to elaborate upon, right? Once you develop this practice, then probably self-doubts of yours will wane, will not take long. The other very important point is thought block. Many times I've seen either the student has a thought block when he's sitting in front of the examiner, or he's sitting in front of your question paper and writing the answer. Again, remember, if you hold the pen, you read it, the whole question paper in the beginning, right? And you start writing the points whenever they just flash in your mind about any question. That way, you can actually take care of these thought blocks, you see? So that is important. The other minor things is attempt questions in the order given in the question paper, because it always helps the examiner, because they get irritated when they have to really scan your paper for the question answers and all that again and again. You are reducing on your marks, because nowadays it is the marks that matter, you know. They are all added up, and then it is said that, well, you get as many marks, and they are written on your sheets also. So it is important you make their life easy also. And also, I have seen some students too ambitious in answering the questions, right? There is no need. If there is a straightforward answer that you define something, they say, define mixed venous oxygen. Then it is better you give the copybook perfect definition of mixed venous oxygen, right? And in the first few lines, and then leave some empty space, and then you start elaborating upon them, right? There's no need just to beat around the bush to capture the answer. You don't want to show your knowledge to the examiner. Always remember, just put some space all around your writing so that you frame your answer. It gives always a good impression about you. Second very important thing is that as you grow up in the medical ladder, you find that your handwriting suffers a lot. And when you are in a school, you are writing like this. When you become attending and you become a consultant, your writing is like this, you see. Nobody can read it. So it is important that when you are answering, and that is why time management is important. What happens? You write for 1 to 2 hours for 3 or 4 questions. You write in these kind of letters, and then you hurry up, and then everything becomes like that. So you don't get marks on that. And also impression becomes bad, you see, because you have to appear in person in front of the examiner to answer the questions. Other things are make small sentences, use bullets, and important point should always be first, because you remember that Pandit who went to a marriage feast, you know, he hated this pumpkin, and therefore he said that I'll eat pumpkin first, and then I'll eat the other things. And when he ate pumpkin curry, the person who was serving is found that, oh, this man likes pumpkin a lot. So he gave more pumpkin. So that fellow, he kept on eating pumpkin to the end, can't eat other things. So always remember, put important points in the beginning. Avoid writing controversial points. Those were very extremely controversial. You don't know, means there is so much of debate that this and that, this and that. It is better not to write those kind of points, you see. And make paragraphs, only 1 or 2 concepts per paragraphs. Paragraphs has to be, means a full page, should not take a full paragraph. And I have seen people just putting underline everywhere. Right, then I start finding those sentences, which are not underlined, right, so that I can actually creep in the mind of the student and see what he or she is thinking, right? So that is important. Don't use too many colors, and if you use colors, then you be consistent with the color plan, you see. And always remember, abbreviations, medical line is full of abbreviations. So always use universal abbreviations. It is very important. And second thing is, if the question comes with a clear-cut structure like define, describe, discuss, it has a perfect meaning. If it is defined, just give a definition. You can put up 1 paragraph and write a bit of that afterwards, okay? If you see, yes, time permits, because question is made like that, if I say, define this, and then if I say, well, how this is helpful, it means the definition may get around 10 or 20% of the weightage, and rest will be on that. So you have to take that, you have to write it separately. Always remember, in the medical answers, diagrams, flowcharts, tables, they just put beauty to that, right? And if the pictures say it all. So as many pictures as possible, and they have to be clear. That is important. It render beauty to your answering, it renders beauty and clarity to your thoughts, and it renders beauty and clarity, and also the seriousness of your personality, so in front of a patient. So that is what's important. Always use that. Always remember that figure. Again, this picture you see in one of the nurses in Sri Lanka, she always gave this kind of picture to the patients, right? That how the NPO status will mean. So compliance can be achieved, right? But you not be too elaborative by putting a big drop here or putting knife or something like that. Well, let's go to the other part quickly. Practical examinations. Here you have to be physically present in front of the patient. You are examining him or her, and then you have to be physically present in front of the examiner also. It may be a long case or the short case. So you have to know your patient well, right? You have to know your audience, who is the examiner. You have to know the situation. Means situation can change. Supposing your colleague who went for initially before you in front of the examiner has really done very bad, then actually bring the examiners in a bad mood. Always remember that. Now you have to be cautious and careful that you are not going to actually make him more angry. So you have to be really very precise in answering and practice, right? 6 months before you appear in the exam, you start practicing. 2 people, one becomes the examiner, other becomes the student, and just change the roles and keep on practicing again and again, and be as rigorous as possible, right? So that you can learn a lot. There is always a template of oral presentation. This is the template. I think you all know it. You use it. But I will tell you, be organized whenever you are doing anything, right? You follow the template and you follow the way it has to be answered. And this is one of my very important slide, and I like it a lot. In the examination, you tell a story, but not a cock and bull story, right? It has to be a true story. It means you have seen the patient. So you have to address patient, that gentleman or that woman or something like that. Right? Don't call him patient. And then weave the story, present illness, past illness, medication history, and everything like that. Because if you are telling a story, if you are a powerful storyteller, then actually people get interested in hearing to you. That is important. And with every moment, you are gaining actually some brownie points from the examiners. They become too lenient then, right? If you find that, well, your story is good. Always start with a strong opening statement, right? Don't just speak inside your mouth or the tongue-in-cheek kind of speaking. No, because you have seen the patient and all that. So you say that Mr. So-and-so has presented with this kind of result. Immediately it will actually draw the attention of examiners to you, and they will become more attentive. Otherwise, they will just keep on drinking tea and eating cashew nuts and talking to their colleagues, right? But you have to draw their attention. The patient and the illness present in a logical sequence, right? And both include pertinent positives and negatives. And once you have completed the history, then you summarize with positive points and go to the differential diagnosis, right? And before going to the management, never jump to immediate management. And then again, you start with your how you are going to further investigate that patient. You tell the investigation, then again you summarize. This time, when you summarize, you take the history as well as the positive points on your investigation, and then summarize and come to a differential diagnosis with giving maximum weight to one diagnosis, which you think, right? And then let the examiner decide how he wants to ask you the management and all that. Improve your presentation, be enthusiastic. Always remember, right? Your enthusiasm tells that you have seen the patient and you have really worked hard for the 3 years. Use an audible voice, right? And don't try to read your presentation because you have met the patient. You have actually asked questions from your mind. They are not given to you, written in the copybook so that you can actually fill them. No. So when you have asked the questions from your mind, you can very well present the answers to them without reading. Be honest. If supposing I say, have you seen these CVP say that, well, the jugular venous pressure is that much? Examiner asks, have you seen it? Right? If you have seen it, if you have done it properly, you tell them. Or you can very well say, sir, I have not done it. I have forgotten. Oh, it's okay. It's fine, right? You will, he may give 1 mark less, but if you're dishonest, and say, oh, I have seen it, and then you are caught that probably you have not done it, then you lose maybe a lot marks, you see. And at the end, you may ask for feedback. So include only the most essential facts, but be ready to answer any question, right? Keep your presentation lively. Keep in mind the limitation of your listeners. Beware of jumping back and forth between descriptions of separate problems, right? And your reasoning, that is why. So your education, right, throughout your 3 years, it actually helps you. And always remember, examiner is not the same. That examination is not the same for all of you, right? Because the candidates are different and the examiners are different and the questions may be different. But by your knowledge and lots of effort, you can very well scale it. And always remember, examinations can be extremely formidable. Why? Because, anybody can ask. Asking questions is very easy, but answering them needs lots of education, knowledge, effort, right? That is what's there. Thank you for your kind attention. Thank you. Thank you. Thank you. Hello. Well, I'm not able to listen. I'm not able to listen. I'm not able to listen.
Thank you, sir, for an excellent presentation. I'm Dr. Bharat, Associate Professor from AIMS Jodhpur. So I have no questions, but I had taken my mic because I could not restrict myself from appreciating how well you have presented. So just as your first slide, you had been a mentor and you had excellently presented and you had opened up what an examiner is looking for when there is checking the copies of the students. So thank you very much. And this is my feedback also. You can thank you very much, sir.
Any
extremely elaborate
Professor Tiwari. Bas. Hello, am I audible?
Yeah, please. Yes, yes.
Sometimes some of the students have complained to me as an internal or something that whenever the externals do come for the Viva examination, they talk to the students and midway before their reply comes to an end, they leave the place or they talk to someone else. So this becomes a traumatic to them. How to bear up this trauma? Just can you give me some suggestions?
Yes, I actually don't like this practice because we are sitting for the examining the candidates, so the whole attention must go to the examinees. Let me tell you, means I think in early 20s and the late 90s, the DNB board has this practice because we were doing lots of super specialty examinations for DNB board, and they have come up with ASCII ways. I was also an examiner for FRCA when I was in England. We used to keep the examiners separately in stations. So you make the stations, you let the examiners sit for maybe 1 hour or 1.5 hours for that module, and you just talk to the student. I think that gives more, means it builds up confidence in the student, number one. Number two is, a student is afraid, he thinks that supposing two examiners are sitting side by side, and one has asked the question, the other examiner will be actually evaluating the student's demeanor, the way he answers. And supposing he slightly smiles, and it may be a smile for something else, not related to the student, but actually that reduces the confidence level of the student. So I think the best way nowadays is that it is better if there are two examiners, so you keep on taking certain parts of the examination and talk to the student separately in a separate room. And I have seen that it enormous builds the confidence of the student, and they really come out of good answers. Over to you.
Thank you, sir.
Any more questions? Thank you, sir.
Now, may I request Professor Arun Kumar sir to honor our chairpersons. Dr. Tiwari sir.
Yeah.
Sir, thank you, sir, very much for your nice presentation and elaborative informations to our students and our teachers. And your memento, I will send you, sir, personally. Thank you, sir. Thank you very much.
It's okay. It's fine.
Thank you very much.
500 चेयर लगवा दीजिए, है ना? इसको बीच में रखिए, बीच में प्रेसिडेंट, सेक्रेटरी, ट्रेजरर, गवर्निंग काउंसिल, 7 को चेयर लगवा दीजिए। वो टेबल लगवा देंगे तो बहुत अच्छा रहेगा, बेस्ट बेस्ट उसको लगवाइए एकदम। Dear all, important announcement. With this session, with this lecture, we come to the end of this session, academic session. After the lunch, which we will start the AGM of the zonal East Zone at 2:30 sharp. So I request all the members to reach the hall, this hall only. At 2:30, we will start the AGM of the zone, which will be followed by the state AGM, and then we will start the valedictory. आप लोग का बहुत अच्छा रहा। हरी जी कहाँ गए? नीचे बोलिए, मेरे से बात करेंगे। रांची में टाटा में वो कॉन्फ्रेंस हमको करवाना है ना। ठीक है।
वही हरि जी देंगे सर। हरि भगवान का दर्शन कीजिए सर।
नहीं तो आजकल क्या है सर, मेल है, व्हाट्सएप है। अरे क्या है इसमें तो बहुत सब करो सब दे बहुत सी चीज है सब काम नहीं करने नहीं क्या करेगा कम तो क्या
कर दो, साइन कर दो। हाँ साइन करते चलिए बस, ठीक है। मेन इसमें जरूरी है, उसमें भी 10 लोग हो जाए तो काफी, 10-15 लोग। वो सीनियर देखो, जब मनोज को फोन कीजिए तो जरा सा बोली तो आ नहीं रहे, इतना देर कर रहे हो, मेन आदमी वही है हम लोग के। 10 लोग चाहिए, 7 हो गया ना, 3-4 को और इधर वो कर दीजिए ना आगे, कोई दिक्कत नहीं। वो बिल्डिंग कमेटी है सर, देख जरूर देखिए सर। मनोज भाई, वी आर वेटिंग फॉर यू, आवर रिस्पेक्टेड Manoj sir. With your permission, we will start the East Zone GVM. Please come to the dais. हाँ, I request all the senior members. Please आप लोग आगे बैठें. अजीत सर, जगन्नाथ सर, सेबास्टियन सर, प्लीज आप लोग आगे बैठें. नहीं सर, वहां बैठिए, अच्छा लगेगा. आप लोग का गाइडेंस चाहिए सबको. आइए सर, I request all the senior member. अजीत सर, जगन्नाथ सर, हाँ बैठिए सर. जरूरत होगा तो एक यहाँ हम लोग और लगवा देंगे सोफा, कोई दिक्कत नहीं है सर. हाँ बैठिए सर, बैठिए. हाँ 2 लोग वहां बैठ जाएंगे सर. अजीत सर बैठिए. आई रिक्वेस्ट डॉक्टर मनोज, वी आर रनिंग शॉर्ट ऑफ टाइम, प्लीज स्टार्ट द प्रोसीडिंग. पहले एजीएम का जोनल का लिख लीजिएगा ना, जोनल जोनल का पहले एजीएम होगा. हाँ आराम से बैठिए, बाद में ऊपर आके लिखिए. अभी खाली वही बैठेगा और कोई नहीं बैठेगा, ठीक है. चल स्टार्ट. Respected members, so officially we are going to start the East Zone annual general body meeting. As this is happening in this pandemic, so there are very few attendance from the Odisha, West Bengal and Andaman Nicobar. These 3 are the part of us with, the Bihar and Jharkhand is the other one. So as Dr. Manoj is the GC member of the East Zone, he will chair this AGM, and we all the members of this society from the Bihar and Jharkhand. So if you have any issue regarding the zonal conference, I will not talk about the state problems, no the city problems. Only the zonal problem, if you have any concern, please raise your hand. And when I will take the name, then otherwise we don't want any fighting or shouting, sir. Just a polite request with everyone. We are all educated persons. So I want, if you want to ask anything or say anything, please raise your hand. Definitely we will call you. Right, sir? So hand over to Dr. Manoj. Officially, we are starting the meeting at 2:45 p.m. Neela madam, 2:45 p.m. और अपना सिग्नेचर जरूर करेंगे. एक रजिस्टर घूम रहा है, रजिस्टर में नाम, आईएसए नंबर लिखें, जरूर लिखें, क्योंकि आपको मैंने बताया कंट्रोवर्सी हो चुकी थी. डॉक्टर मनोज, प्लीज स्टार्ट द प्रोसीडिंग. वहां बनेगा, उसको भी घुमाना होगा. अरे उसी को फोटोकॉपी करके भेज दीजिए. ठीक है, ओ मनोज, विजेंद्र सर ग्रुप में डाल दीजिए. All the members are requested to reach the hall for the AGM. सुनना, यहाँ पैसे लगा तो नहीं सकते. 1 2 3 समझे ना, उसे मत नीचे से सीक्वेंस बना से.
Respected senior IC member, हमारे बीच हमारे पास्ट वाइस प्रेसिडेंट IC नेशनल अजीत सर हैं, बिहार झारखंड स्टेट प्रेसिडेंट डॉक्टर बादशाह सर हैं, डॉक्टर अरुण सर हैं, हमारे पास्ट प्रेसिडेंट IC बिहार झारखंड अजीत गुप्ता सर, ही इज ऑल्सो सेक्रेटरी ऑफ पास्ट सेक्रेटरी ऑफ IC बिहार झारखंड. हमारे बीच बहुत से स्टेट ऑफिस बियरर हैं बहुत से सिटी ब्रांच के ऑफिस बियरर हैं, एक्सिक्यूटिव कमिटी ऑफ दिस कॉन्फ्रेंस। आई वेलकम ऑल ऑफ यू on behalf of East Zone General Governing Council member of ICA National. So I welcome all of you. So अभी जो कॉन्फ्रेंस हम लोग कर रहे हैं, सबसे पहले उसके लिए पूरा ऑर्गेनाइजिंग कमेटी को दिल से एज ए ईस्ट जोन के गवर्निंग काउंसिल की तरफ से बधाई। और ये मैसेज मैं आज सुबह सुबह ICA नेशनल को भी दे दिया। जो एक्टिविटी हुई है परसों से, वर्कशॉप से लेके कॉन्फ्रेंस का, तो मैंने उनको फोन से कन्वे कर दिया है। और आई रिक्वेस्ट टू डॉक्टर शरद, आवर स्टेट सेक्रेटरी, जो भी आज विनर हैं डिफरेंट कंपटीशन के, उनको दो तीन दिन के अंदर उनका नाम भेज दें नेशनल में, ताकि वो कंपटीशन में भाग ले सके नेशनल लेवल पे। और जैसा कि आप लोग को मालूम है कि ऑनलाइन इलेक्शन का नॉमिनेशन हुआ था नेशनल लेवल के लिए, तो हमारे ईस्ट जोन का जो पोस्ट है, एक पोस्ट वो निकला था, एक पोस्ट गवर्निंग काउंसिल ICA नेशनल। तो ईस्ट जोन के लिए ओनली वन नाम आया नॉमिनेशन में, और वो एक तरह से रिजल्ट हो गया। तो वो है डॉक्टर रेखा दास। तो मैं एज ए गवर्निंग काउंसिल उनको हार्टिएस्ट कांग्रेचुलेशन देना चाहता हूँ। डॉक्टर रेखा दास विल बी द आवर ICA नेशनल गवर्निंग काउंसिल फ्रॉम ईस्ट जोन फ्रॉम 29th नवंबर ऑनवर्ड्स ओनली फॉर 3 ईयर। इसके बाद हम लोग जो कोऑर्डिनेशन बनाए हुए हैं ICA ईस्ट जोन में कि ये जोनल कॉन्फ्रेंस किस तरह से रोटेशन वाइज हो रहा है, उसी तरह हम लोग का अपना जो गवर्निंग काउंसिल का सीट है वो हर पहले उड़ीसा हुआ, फिर वेस्ट बंगाल हुआ, फिर बिहार झारखंड आया, फिर उड़ीसा गया, फिर अगले बार 2024 में ये वेस्ट बंगाल जाएगा, फिर 27th में फिर बिहार झारखंड आएगा। तो जो भी एलिजिबल कैंडिडेट हैं यूनानिमसली हम लोग कोशिश करते हैं कि हो जाए, लेकिन फिर दिस इज इलेक्शन प्रोसेस, तो मतलब कोई भी खड़ा हो सकते हैं इसमें। ये तो हो गई हमारी टर्नओवर का। उसी तरह 2019 में उड़ीसा में कॉन्फ्रेंस हुआ था। नाउ कम टू द एजेंडा ऑफ नेशनल कॉन्फ्रेंस। एक्सक्यूज मी, दिस इज अ वाइटल पॉइंट फ्रॉम ईस्ट जोन। तो 2019 में एम्स भुवनेश्वर में कॉन्फ्रेंस हुआ था, तो उसमें उसके जनरल बॉडी को प्रिजाइड हम ही किए थे। तो उसमें 2-3 पॉइंट डिसाइड हुआ था। पहला पॉइंट होता है PG असेंबली का। तो उस मीटिंग का हम प्रोसीडिंग पढ़ के सुना रहे हैं, जिसमें कि डिसाइड हुआ था कि जो 2019 में कि वो PG असेंबली का जो टर्नओवर है वो जाता है वेस्ट बंगाल को। पटना को तो मिल चुका था, तो वेस्ट बंगाल को गया। 2020 में वो लोग किए। इस बार 2021 में PG असेंबली विल बी अगेन एज ए रोटेशन वाइज अगेन विल बी हेल्ड इन उड़ीसा। तो हम चाहेंगे कि इसके लिए एक बार ताली बजा दीजिए। और PG असेंबली में सारे हमारे PG और कुछ फैकल्टी हमारे जो इनवाइटेड रहेंगे जोन से, सब लोग हम लोग वहाँ हेल्प करेंगे, जाएंगे। और टाइम डिसाइड हो जाएगा नेशनल में के मीटिंग में डिसाइड हो जाएगा कब करना है। फिर नाउ कम टू द स्टेट नेशनल कॉन्फ्रेंस। तो नेशनल कॉन्फ्रेंस के लिए हम लोग डिसाइड किए। अभिषेक प्लीज। नेशनल कॉन्फ्रेंस के लिए जो हम लोग डिसाइड किए रोटेशन वाइज 2-3 नियम है नेशनल कॉन्फ्रेंस में। पहला है कि जो नेशनल कॉन्फ्रेंस जो स्टेट कर लिया है उसको 10 साल नहीं करना होगा। तो हमारे जोन में 3 स्टेट हैं, वेस्ट बंगाल, उड़ीसा एंड अनदर इज वेस्ट बिहार झारखंड। तो 2017 से वो 2027 तक कॉन्फ्रेंस नहीं ले सकते हैं। तो एज ए वो तो पहले ही छट गए थे, और आया अब बिहार झारखंड और उड़ीसा का बारी, तो उसमें कुछ मेंबर उड़ीसा में बोले कि हम लोग भी इंटरेस्टेड हैं, लेकिन हमने एज ए पूरा वहाँ पे डिस्कशन हुआ, सारे मेंबर थे हमारे, बिहार झारखंड के भी बहुत से मेंबर थे, उड़ीसा के भी थे, क्योंकि कॉन्फ्रेंस वहीं था तो ज़्यादा मेंबर वहीं थे। तो वहाँ पे फाइनल डिसीजन ये हुआ कि नहीं, ये बिहार झारखंड स्टेट जो है इसको होस्ट करेगा। और हम लोग बताया कि पटना ब्रांच हम लोग के बोकारो स्टेट कॉन्फ्रेंस में डिसाइड हो चुका था, उसके बाद उड़ीसा में हुआ था ये मीटिंग। तो पटना ब्रांच, पटना सोसाइटी ऑफ एनेस्थेसियोलॉजिस्ट को नेशनल कॉन्फ्रेंस ऑर्गेनाइज करने का बारी आता है। तो सब लोग उसमें इंडोर्स किए और साइन किए। और अब उसी को मतलब इस मीटिंग में हम ये कहना चाहेंगे कि उस मीटिंग को में ये हम लोग चर्चा में लाए हैं कि पटना ब्रांच को 2024-23 में होना था, लेकिन एक साल सब चीज डिले हो गया, नल ईयर हो गया। तो पटना सोसाइटी ऑफ एनेस्थेसियोलॉजिस्ट को ये ऑर्गेनाइज करने का मौका मिलेगा और बिहार झारखंड सोसाइटी ऑफ एनेस्थेसियोलॉजिस्ट उसको होस्ट करेगा। तो ये ओपन फॉर डिस्कशन है, इसमें अगर किसी को कुछ कहना है सर। प्लेस पटना में सर कन्वेंशन सेंटर है, विज्ञान भवन है, इसके बाद हमारे पास
डॉक्टर मनोज, हम कुछ कहना चाहेंगे। सबसे पहले तो आपको बहुत बहुत धन्यवाद, आपके अथक प्रयास से हमारा नेशनल कॉन्फ्रेंस ऑलमोस्ट हम लोगों ने बात की है, काफी देर, 3-4 दिनों से चर्चा कर रहे हैं, और काफी दिनों से इनफैक्ट हम मनोज, बीके सर, अजय भाई, हम लोग 4 लोग काफी दिनों से इस पे चर्चा कर रहे थे। और हम लोगों के प्रयास से हम लोगों ने उड़ीसा और वेस्ट बंगाल से बात करके ऑलमोस्ट हम लोगों ने अपना क्लेम किया है कि वी विल होस्ट द 2014 आईसाकॉन नेशनल कॉन्फ्रेंस एट पटना। प्रोबेबली दिस इज फाइनल, बट सी देयर ऑलवेज इफ एंड बट चलता है, क्योंकि हम लोग चाहेंगे कंसेंसस सबका होना चाहिए, केवल हम 4 जन बोलने से नहीं होता है। हमेशा बोलते हैं इससे टीम एफर्ट, हर कोई आदमी को हाथ उठा के जोर से बोलना होगा, वी आर विद पटना एंड वी विल होस्ट दिस सोसाइटी, देन वी विल फाइंड कि ओके हुआ। तो आई प्रपोज कि अगर हम प्रपोज कर रहे हैं कि पटना करना चाहता है, सेकंड डॉक्टर नीलम प्रपोज आप लिख सकती हैं, डॉक्टर नीरज का नाम लिख सकते हैं, डॉक्टर तो इसको पास करें डॉक्टर मनोज।
हाँ ओके।
वेन्यू, हाँ वेन्यू अभी हम लोग पटना को रखते हैं, होल पटना, बिकॉज इट्स टीम एफर्ट, वी विल फाइंड द बेस्ट प्लेस। नेशनल कॉन्फ्रेंस कराना हमारे 10,000 लोगों को कैटर करना, ठीक है, 8 से 10,000 हमारे मेंबर्स होंगे, उनकी फैमिली भी होती है। सो कमिटी हम लोग बनाएंगे, अच्छे अपने लोगों मेंबर्स की, एक्टिव मेंबर्स की कमिटी बनाएंगे, दे विल फाइंड द बेस्ट सुटेबल प्लेस, क्योंकि एक जगह नहीं हो सकता है। हमारा कन्वेंशन सेंटर इतना बड़ा नहीं है कि उसमें 10 हॉल हो। बिग रिसर्च, हम लोग वी विल वर्क ऑन दिस, 6 महीना साल भर लगेगा इस पे काम करने में, एंड इट्स ह्यूज अमाउंट, बहुत बड़ा पैसा का भी जुगाड़ करना है। सो कोई बात नहीं, स्टार्ट यहीं से होता है, जीरो से स्टार्ट होकर हम लोग कहाँ से पहुंच जाएंगे। तो हमारा आप लोग से सहयोग चाहता है बीजेएस से एज वेल एज पीएसए। सो सपोर्ट है ना सर आप लोगों का? सो इसको क्लोज किया जाए, मनोज भाई आगे बढ़े।
नहीं, उसमें
बोलेंगे हाँ,
उसमें 2-3 बात को अगर कंफर्म हो गया है तो 2-3 बात का आप एज ए स्टेट सेक्रेटरी आपको नॉलेज होना चाहिए। एज ए स्टेट सेक्रेटरी 2-3 बात का उसमें हम लोग ना जुलाई के आसपास ये हम लोग बीट करेंगे। उसके लिए पूरा हम लोग को नेशनल में गवर्निंग काउंसिल के में ही डिसाइड हो जाता है आजकल, जनरल बॉडी नेशनल में नहीं जाता है, रूल हुआ है। अगर वहाँ पे अगर ये वोटिंग होता है जनरल गवर्निंग काउंसिल के अंदर, तो जो अगर कुछ भी वोटिंग में जीत गए तो जीत गए, अगर बराबर हो गया तब जनरल बॉडी में जाता है। तो ऐसा तो होगा नहीं, हम लोग उड़ीसा से बात कर लिए हैं, हम ही लोग सिंगल बीट कर रहे हैं। अब हम लोग का काम है कि बढ़िया से उसको प्रेजेंट करें, वहाँ पे सारा चीज क्या हमारा हॉस्पिटलिटी है, क्या कौन सा उसमें है कि कच्चा नहीं लगाना है, पक्का हॉल होना चाहिए, ये ध्यान देना है। और कितना होटल्स है, क्या आने का है प्लेन का, और बस रूट और ट्रेन का जो सारा रूट सब दिखाना पड़ता है। और पटना सोसाइटी का जो है सो 3 साल का ऑडिटेड अकाउंट, डॉक्टर सुकेश, पटना सोसाइटी ऑफ एनेस्थेसियोलॉजी का 3 साल का अकाउंट को उसमें पेश करना होगा। डॉक्टर शरद,
हाँ ये सॉरी,
3 साल का ऑडिटेड अकाउंट पटना सोसाइटी का
हाँ।
एक होना चाहिए, सारा
तो
फॉर्म बढ़िया से हम
request-
लोग करके देंगे।
जी हाँ जी, रिक्वेस्ट प्रेसिडेंट ऑडिटेड है 3 साल का।
ओके
हाँ, ठीक।
ओके, थैंक यू वेरी मच पटना सोसाइटी ऑफ एनेस्थेसियोलॉजी। अब इसमें 3 पोस्ट के लिए जब बीटिंग करेंगे, चूंकि ये अब कॉन्फ्रेंस सितंबर अक्टूबर में होगा, हम लोग को बीट पहले करना है, तो जुलाई में हम लोग को फॉर्म भर के देना है, सारा फॉर्मेलिटी करना है, तो जुलाई में नॉमिनेशन के लिए भरना है हम लोग को बीटिंग फॉर्म। तो उसमें अभी ही डिसाइड होना पड़ता है 3 पोस्ट। पहला पोस्ट डॉक्टर शरद, पहला पोस्ट जो हम लोग को
होता है, हम लोग जब बिड करेंगे तो उसमें वी हैव टू गिव द 3 नेम्स टू द सेंटर एंड दीज नेम्स आर ऑर्गेनाइजिंग चेयरमैन।
तीनों का साइन होता है, तीनों का साइन होता है।
एग्जैक्टली, कंसेंट के बिना नहीं होता है। एंड उसको हाउस भी ओके करता है, क्योंकि हाउस अभी यही है, दिस इज द हाउस कोरम दैट इज कॉल्ड। सो हमारा प्रेसिडेंट ऑर्गेनाइजिंग चेयरमैन, द फर्स्ट वन इज ऑर्गेनाइजिंग चेयरमैन। सो डू यू हैव एनी नेम डॉक्टर? ऑर्गेनाइजिंग चेयरमैन की बात कर रहे हैं हम। कसके क्या बोले सर? डॉक्टर मनोज। डॉक्टर नीरज ने प्रपोज किया है सेकंड। डॉक्टर सुदामा ने समर्थन किया और हम भी समर्थन करते हैं। और कोई लोग हैं तो बताइए। सो 2014 नेशनल कॉन्फ्रेंस द ऑर्गेनाइजिंग चेयरमैन हमारे तरफ से, जो सोसाइटी की तरफ से नाम जाएगा डॉक्टर मनोज कुमार, क्योंकि इनका अनुभव नेशनल लेवल पे हम लोग जितने भी लोग बैठे हैं, पूरा मत मानिएगा, सबसे ज्यादा है आज के दिन में। ठीक है, आज से 10 साल पहले बिहार झारखंड अच्छा करता था, लेकिन इनके अथक प्रयास से बिहार झारखंड के लोगों को, आज की जो वहां की गवर्निंग काउंसिल है, हम लोग को पर्सनली नाम से जानती है सर। इनका प्रयास बहुत है, इसके लिए एक जोरदार ताली तो बनता है मनोज सर के लिए। डॉक्टर मनोज, आप इसके लिए सहमत हैं? इस पोस्ट के लिए सहमत हैं? थैंक यू डॉक्टर मनोज, थैंक यू। तो आगे बढ़ते हैं। दूसरा पोस्ट होता है जो इंपॉर्टेंट, द मोस्ट इंपॉर्टेंट इनफैक्ट, दैट इज ऑर्गेनाइजिंग सेक्रेटरी। डॉक्टर विजेंद्र ने डॉक्टर अजय का, अजय जी आप यहाँ आइए प्लीज। डॉक्टर अजय कुमार हम लोग के बहुत अच्छे मित्र हैं, सबके, जिसको कहते हैं ना भगवान कृष्ण हर समय हर जगह अवेलेबल रहते हैं। तो हम लोग इनका नाम प्रपोज कर रहे हैं। डॉक्टर विजेंद्र ने प्रपोज किया। सेकंड डॉक्टर नीलम, डॉक्टर डीके सिंह सर, डॉक्टर अजीत गुप्ता। डॉक्टर अजीत सर नाम लिख लीजिए। डॉक्टर अजय, आप सहमत है इस जिम्मेदारी को उठाने के लिए?
देखिए, जिम्मेदारी बहुत बड़ी है, लेकिन पूरे मंच का यहाँ पर जितने लोग हैं, मंच के तरफ से भी और जो इधर से भी जितने लोग हैं, सोसाइटी के लोग हैं, यदि सब लोग, क्योंकि ये एक आदमी 2 आदमी का चीज नहीं है, हमेशा सबों का साथ जरूरी होता है। कोई भी कॉन्फ्रेंस कोई अकेला एक आदमी का चीज नहीं होता है ये, और वो भी नेशनल। इसलिए सारे लोगों का सपोर्ट का जरूरत है। हम आगे बढ़ गए, बाकी सब पीछे चले गए तो फिर दिक्कत है। तो हम आप लोगों के साथ हैं, जैसा आप लोग कहेंगे वैसा हम करने के लिए तैयार हैं।
तो हम लोग चाहते हैं आप सेक्रेटरी का पोस्ट संभालें।
चलिए ठीक है, थैंक यू।
एक नाम और होता है
एक
आजकल
तीसरा
ऑर्गेनाइजिंग, ओनली 3 नाम में 2 नाम तो आप हो गया। तो ये साइंटिफिक चेयरमैन, ओनली चेयरमैन, सेक्रेटरी का हम लोग बाद में जब मीटिंग करते हैं, जब मिल जाता है तब डिसाइड करते हैं। ऑर्गेनाइजिंग चेयरमैन के लिए बीके प्रसाद,
डॉक्टर बीके प्रसाद।
चलिए बहुत जोरदार तालियां से।
बीके सर, बीके सर,
मैडम नीलम मैडम आप भी लिख लीजिए।
हाँ सर,
लिख लीजिए।
नहीं सर, एक पब्लिक के सामने, हाउस के सामने उनका कंसेंट होना बहुत बहुत बड़ी जिम्मेदारी है सर। तो सर आपको हम लोग प्रपोज किया लोगों ने साइंटिफिक चेयरमैन के लिए नेशनल कॉन्फ्रेंस, तो आप सहमत हैं सर?
सभी लोगों का आशीर्वाद है तो सहमत है।
सो ये 3 इंपॉर्टेंट, तीनों का नाम, आईसी नंबर, एवरीथिंग डिटेल वी विल सेंड टू द नेशनल इन नेक्स्ट 1 or 2 months। वी विल प्रिपेयर द ड्राफ्ट, वी विल सेंड। डॉक्टर मनोज, नेक्स्ट एजेंडा आपका प्लीज।
मेरा नेक्स्ट एजेंडा है कि हमारे जोन से डॉक्टर निविता पानी मैडम खड़ी हो रही है, जो कि इस बार प्रेसिडेंट इलेक्ट के लिए खड़ी हो रही हैं, डॉक्टर निविता पानी। तो हम चाहेंगे उनके बिहाफ में, मतलब हमसे बात हुई है, सारे मेंबर से उनकी बात हो रही है, तो हम चाहेंगे ईस्ट जोन का सारा वोट हमारे निविता पानी मैडम को जाए, जो कि 1 से 5 नवंबर को है, और सुबह 8 बजे से कंटिन्यू चलेगा इलेक्शन। और वो 5 नवंबर को 5 बजे शाम में वो बंद हो जाएगा। तो ये कंटिन्यू प्रोसेस है, किसी को कंफ्यूजन नहीं होना चाहिए। पूरा 8 बजे सुबह 1 नवंबर से 5 नवंबर के 5 बजे शाम तक चलेगा। और हम चाहेंगे कि जो भी एक्टिव मेंबर हैं और जिनका मोबाइल नंबर और ईमेल रजिस्टर्ड है, तो वो लोग कृपया वोटिंग दें। और हम यंग जनरेशन से अपील करना चाहते हैं, जो हमारे सीनियर हैं जो वोटिंग करने में सक्षम नहीं होते हैं, तो जो भी नज़दीक में हैं उनको मोटिवेट कर ये लैपटॉप से या मोबाइल से अपने डिपार्टमेंट में या अपने घर पे उनके जाके वोट कराएं, ताकि हम लोग का लगे कि रिप्रेजेंटेशन बिहार झारखंड से एकजुटता हो और मैडम को बहुत सा वोट जाए, और जिससे कि मैडम अच्छे खासे मार्जिन से जीते। धन्यवाद। मैं आज का यही एजेंडा था। और आप लोग से अनुरोध है कि अब जो पीजी असेंबली है अगले साल पटना में आएगा 2022 में। तो हम चाहेंगे कि पटना ब्रांच या जमशेदपुर ब्रांच जो भी ब्रांच इंटरेस्टेड है लेना चाहेंगे। और एक चीज और हम बोलेंगे बिहार झारखंड के इस पे भी, कि हम लोग नेशनल से बात किए हैं, वर्कशॉप जो है हम लोग 5 ब्रांच को 1 लाख रुपया दिलाने के लिए तैयार हो गए हैं। हम लोग नेशनल सेक्रेटरी नवीन मल्होत्रा से बात हुई है, जो भी एक्टिव ब्रांच है, जो जिसका पैन नंबर, जिसका अकाउंट है, जिसमें नेशनल पैसा भेज सके, तो 1 लाख रुपया आपको वर्कशॉप के लिए आपको देगी। तो आप उसके लिए बधाई के पात्र हैं। आप केवल 5 ब्रांच का हमको नाम आज बिहार झारखंड सोसाइटी में डिस्कशन होगा, और उसमें 5 लाख रुपया हमको बिहार झारखंड को डिफरेंट ब्रांच को मिलने वाला है। धन्यवाद। आप लोग आए मीटिंग में, बहुत बहुत धन्यवाद। थैंक यू।
डॉक्टर मनोज, ये तो था जोनल कॉन्फ्रेंस का। नाउ वी विल स्टार्ट विदाउट वेस्टिंग एनी टाइम द स्टेट जनरल बॉडी मीटिंग। सो आई रिक्वेस्ट our president BJSA Dr. Braj Kishore Prasad sir to take the chair on the dais. I will take later. इस एक ही बार करके दे देंगे ना यार, इसमें कैसे? अच्छा सुनिए ना, इसमें इससे 2 पेज में करवा लीजिए अलग से, है ना? इसमें आप करवाइए आदमी को, स्टेट का अलग से फाड़ लीजिए। समझ गए बात? इसी में करवाइए। नहीं तो स्टेट का अलग से लिखना होगा ना पॉइंट। हाँ ठीक है, ठीक, डन डन। अच्छा सुनिए, एक और छोटा सा सजेशन आया है कि स्टेट और जोनल का जो सिग्नेचर होता है अलग अलग होता है। एक और पेपर सर्कुलेट होगा, प्लीज साइन कर दीजिएगा उसमें। हाँ, नाउ आई रिक्वेस्ट आवर ट्रेजरर डॉक्टर नीलम मैडम टू प्लीज टेक द चेयर ऑन द डायस। पटना सोसाइटी प्रेसिडेंट डॉक्टर विजेंद्र सर प्लीज टेक द चेयर ऑन द डायस। सर आप बीच में आएंगे, सर आप बीच में आएंगे। नहीं आप आइए बीच में, 7वां आपका है, ठीक है सर। आप यहाँ आएंगे सर, इस वाले पे। हाँ हाँ हाँ, यहाँ करें कि यहाँ करें, बुढ़ा लोग दिक्कत नहीं हो रहा है, यही करा देंगे ना। यहाँ कराना बेटर है, समझे ना, गिर उड़ जाएंगे, आफत हो जाएगा। आप इसमें बैठेंगे सर। आई रिक्वेस्ट डॉक्टर नीलम मैडम टू प्लीज टेक द चेयर। डॉक्टर सुकेश, आपको बाद में बुलाएंगे। डॉक्टर सुकेश प्लीज टेक द चेयर ऑन द डायस। नहीं सर, वहां पे आपके बगल में जीसी मेंबर सर मनोज, वहाँ हाँ हाँ सर, सबका बना हुआ है सर। एक वाइस प्रेसिडेंट डॉक्टर महेश आए, डॉक्टर महेश भी नहीं आए, उनका भी खबर होना चाहिए। ये अभी हटा दो, बाद में थोड़ा देर में बुलाते, अभी एजीएम 5 मिनट लगे, वहाँ किनारे रखो, है ना। ये लाइट क्यों बंद कर दिया? लाइट ऑन कर दीजिए प्लीज भैया, ये लाइट इसको ऑन कीजिए। डॉक्टर महेश कुमार फ्रॉम भागलपुर, आवर वाइस प्रेसिडेंट। डॉक्टर महेश, डॉक्टर महेश है नहीं हमारे साथ, 1 2 3 4। और डॉक्टर मनोज कुमार, आवर जीसी मेंबर, आवर गाइडिंग फोर्स, इज ऑलवेज विथ अस। अब डॉक्टर मैडम आप थोड़ा इधर हो जाइएगा बस, हाँ ठीक है। हाँ यहाँ डॉक्टर मनोज बैठ जाएंगे, हम बैठ जाएंगे, वहाँ अगर आगे वाइस प्रेसिडेंट तो बैठेंगे, नहीं आए तो ठीक है। मनोज भाई आप यहाँ बैठे बीच में, आप बीच में बैठे, सर के बगल में बैठिए। इस लाइट को ऑन कीजिए ना, इस लाइट को ऑन कीजिए। और लास्ट में हम आते हैं। नहीं ठीक है, अभी जगह नहीं, हमको बाद में पता चला, नहीं छोड़, आजा। सो हम लोग बीजेएससी की जीवीएम को स्टार्ट करते हैं। सर आपको पहले मीटिंग होगा, मैसेज होगा। सो हाँ सर, तो लिखा है सर। विद ड्यू परमिशन, we are starting the 33rd annual general body meeting of Indian Society of Anesthesiologists Bihar and Jharkhand state chapter. Sir, with your permission, can we start the meeting, sir?
Please start, sir.
Thank you very much. As you all know, the corona has given us so much grief and sorrow that we can't express. We lost so many precious life in the last 1.5 years all over the country. Around 600 doctors lost their life in fighting with this pandemic and to serve the human mankind. Unfortunately, 2 of our precious friends also we lost fighting with the corona, and our beloved and Ashok Kumar Gupta sir. Ashok Kumar Gupta sir was suffering from renal problem, and sir also was the very active member of the society. And to pay homage to all the departed soul, I would like all the members to please stand for 1 minute and pray for the peace of the soul of the departed soul. Time is start. Please take your seat. Now I request our president, Dr. B.K. Prasad sir, to address the gathering.
सभा कक्ष में उपस्थित सभी हमारे सीनियर ब्रिंस, हमारे गुरुजन, सहकर्मी, छात्र, मीडिया पर्संस, आईटी पर्संस, मैं प्रेसिडेंट के हैसियत से बहुत कुछ नहीं बोल पाऊंगा। कर्मचारी के हैसियत से बोलना रहता तो बहुत बात बोल पाता। मेरे मन की इच्छा थी 2019 में जब मैं बोकारो कॉन्फ्रेंस गया था, जिस समय मुझे ये भार दिया गया था कि मैं हर एक सेक्टर में सासाराम से लेकर किशनगंज तक, दोनों ही हमारे ब्रांच नहीं है अभी, उस दोनों सेक्टर तक, मधुबनी से लेकर के शहर चाईबासा तक, सभी सेक्टर में सभी जगह एनेस्थीसिया का काम करते हैं जो लोग, एनेस्थेटिस्ट जो काम करते हैं लेकिन एनेस्थेटिस्ट नहीं है, उनको भी कुछ दिशा निर्देश के लिए एक यूनिट बनाना, सबको गाइड करना, सबको अपडेट करना, टीचर से लेकर कलीग में बांटकर उन लोगों तक पहुंचाकर। लेकिन कोरोना काल के चलते या किसी भी कारण से मेरा यह सपना बहुत हद तक पूरा नहीं हो सका। जो कुछ भी पूरा हुआ, जो कुछ भी सेटिस्फेक्शन का परसेंटेज है वो डॉक्टर शरद और डॉक्टर निशांत सहाय के प्रयास से हुआ। डॉक्टर वदानी और डॉक्टर निशांत सहाय साइंटिफिक सेक्रेटरी बने। बाद में हम लोगों की गलती से डॉक्टर नाग को बनना था, जो बाद में लास्ट 2 मंथ में उनका नाम ऐड हुआ। हालांकि उनका सहयोग हमेशा मिलता रहा हम लोगों को, और हम लोगों ने फर्स्ट सीएमई कोविड काल ही में शुरू किया, और अभी तक अनेकों सीएमई सेक्टर वाइज प्रेजेंटेशन वहां के लोगों से, वहां के लोगों के द्वारा, और दो स्पीकर सेंट्रल से लेकर हमेशा अभी तक करते आ रहे हैं। और 31 तारीख को भी है एक, अगले संडे को भी एक सीएमई उसी तरह से प्रस्तावित है, और हमें उम्मीद है कि ये आगे चलता रहेगा। और हम डॉक्टर डीके सिंह जो प्रभार लेंगे अभी, उनसे रिक्वेस्ट करेंगे कि इसको किसी भी परिस्थिति में बंद न होने दें। हमारे वाइस प्रेसिडेंट डॉक्टर महेश प्रसाद सर को भी मैंने रिक्वेस्ट किया था, नहीं आए, तो उनसे भी मेरा आग्रह रहेगा कि इसको सेक्टर वाइज बांटें। नॉलेज को जितना बांटा जाए, अपना ही नॉलेज उतना बढ़ता है, तो इसको बांटे। छोटे छोटे जगह पर, जैसे सीतामढ़ी, मधुबनी, यहाँ भी एनेस्थेटिस्ट हैं, वहां पर कुछ छोटा छोटा उतनी बात बताएं जो लाइफ सेविंग हो, बीएसएल हो, जो एकदम लाइफ सेविंग है, सीपीआर की ट्रेनिंग है, इस तरह का काम के लिए हम लोग बताएं। काम तो वो कर ही रहे हैं। तो इस तरह से ये मेरा मन की बात थी जो मैं पूरा नहीं कर सका। कॉन्फ्रेंस की बात थी, हम लोगों ने बहुत तरह से करते नहीं करते, करते नहीं करते, ऑफलाइन ऑनलाइन करते करते एक जोश आया लोगों में, और हमारे ऑर्गेनाइजिंग सेक्रेटरी सुकेश कुमार अपनी टीम के साथ, अपने लोगों के साथ एक बड़ा सा लिस्ट बनाए ताकि हर एक आदमी को इसमें इन्वॉल्व किया जा सके, और एक छोटा टीम बनाए जिनको जबरदस्ती डांट कर, हाथ जोड़कर, समझा कर उनसे काम लिया जाए। और उस तरह से इन्होंने परसों, कल और आज वाली स्थिति आपके सामने रखी है। क्या इसका आकलन है, ये आप हमसे अच्छा बता पाएंगे। हम उम्मीद करते हैं हमारा सहयोग, हमारा आपसी संबंध, हमारा भाईचारा एनेस्थेटिस्ट के समुदाय के रूप में हमेशा बना रहे। जैसे हमको हमारे टीचर प्रोफेसर नसीर अहमद के साथ भी मैंने काम किया, प्रोफेसर एनके मिश्रा हमारे गाइड थे, और आज भी हम आप लोगों के साथ काम कर रहे हैं। तो एक ये जो ऊपर से आशीर्वाद का लेकर के हमारे यहाँ से हाथ से किसी और को देने का ये सिलसिला बना रहे, हम लोगों को आपका आशीर्वाद मिलता रहे, और आगे वाले पीढ़ी को ये नॉलेज व्यवहार के साथ, मानसिकता के साथ, आपसी सहयोग के संबंध को बनाए रखने का मैसेज के साथ अगली पीढ़ी को भी जाए। धन्यवाद।
Thank you very much, sir, for your kind words. So now I will present the confirmation of the proceeding of the last AGBM held at Bokaro. So there were few points. Late Dr. Ashok Kumar Gupta sir, presented building committee status. No PAN card was made till date, and in fact, till now we have not progressed because of this COVID. There were lots of issues. So Dr. Ajay, Dr. Manoj, and all the committee members, they tried level best. They worked hard, but in spite of some unforeseen problems, the PAN card was not made till date. All the rules and regulation of the ISA building committee, the important one was that building committee name to be changed to building trust. It was passed in the house in the last AGBM at Bokaro. All the rules and regulation of the ISA building committee, that will call the building trust, earlier will continue, and the bank account का नाम सेम रहेगा, द बिल्डिंग कमिटी। ये बात हुई थी, थोड़ा सा कंफ्यूजन हुआ था इसमें। नाम बिल्डिंग ट्रस्ट होगा तो बैंक का भी तो चेंज करना पड़ेगा। सो हाउस इज ओपन फॉर दिस नाउ, बिकॉज दैट टाइम इट वाज नॉट क्लियर क्या करना होगा, क्या रूल्स रेगुलेशन बहुत कॉम्प्लिकेटेड हो जाते हैं। बिल्डिंग ट्रस्ट हम नाम रखें अपनी सोसाइटी का, और अकाउंट का नाम चेंज नहीं करें। सो आई नीड द ओपिनियन ऑफ द हाउस, क्या करना चाहिए। डॉक्टर नीलम प्लीज नोट कीजिएगा इसको। ठीक है, डॉक्टर डीके सिंह सर के अनुसार उन्होंने कहा कि दोनों कमिटी ट्रस्ट का नाम बिल्डिंग ट्रस्ट होगा और बैंक में भी सेम नाम होना चाहिए, राइट? आगे बढ़ते हैं। ओके सर, आगे बढ़ते हैं। नेक्स्ट था कि नेशनल कॉन्फ्रेंस भी डिस्कस हुआ था उस समय भी बोकारो में। सो डॉक्टर मनोज ने पूरा उसके बारे में डिस्कस ऑलरेडी कर दिया है, तो डू वी नीड टू डिस्कस अगेन और वी शुड कंटिन्यू? ओके, डॉक्टर नेशनल कॉन्फ्रेंस 2024 पटना इज ओके फ्रॉम ऑल ऑफ यू? ओके, सो डॉक्टर मनोज ने ऑलरेडी उसको पास प्रेजेंट किया था जोनल जीवीएम में, तो अगेन द सेम थिंग, नो नीड टू डिस्कस, द सेम विल गो इन दिस मीटिंग ऑल्सो। हाँ, so organizing chairman will be Dr. Manoj Kumar. The house has passed that, and the proposal will keep the proposal and seconder same. The organizing secretary will be Dr. Ajay Kumar. Proposer and seconder will remain same. If you want, we can change it. No issue. We can change it. And the scientific chairman will be our BK Prasad sir, right? तो उसको दोबारा डिस्कस करने की आवश्यकता है क्या? तो आगे बढ़ते हैं, एक बार जोरदार तालियों से उनका फिर से हौसला अफजाई करें। ठीक है, आगे बढ़ते हैं। उस समय डिसाइड हुआ था कि जो हमारे प्राइवेट प्रैक्टिशनर फोरम अवार्ड में मेडल दिया जाएगा, तो इस बार हम लोग रिसेप्शन कमेटी के चेयरमैन डॉक्टर अजय, मेडल रेडी है सर? डिस्कस हुआ था लास्ट टाइम। रेडी है ना सर? ओके, सो इन सबों के लिए ताली बजाया जाए कि जो पास करते हैं हम लोग, उस पर काम भी करती है कमिटी। सो डॉक्टर अजय, डॉक्टर प्रशांत, हाँ मेडल हम लोग देंगे, तो आप देख सकते हैं, चाहे तो हम दिखा दें। डॉक्टर अजय, प्रशांत,
नहीं सर, ये एक अशोक गुप्ता सर है, इसके बाद सर का ये है।
सेकंड का भी तो है ना कुछ, ये okay, so this is the medal in the name of Dr. BK Prasad sir. The promise has fulfilled. Thanks to the organizing committee, especially Dr. Ajay, Dr. Prashant, Dr. Sukesh. Thank you very much sir. Thank you. उसको रखे, बाद में हम लोग देंगे। आगे बढ़ते हैं। The next one in the agenda is the selection of new society members of the BGSA. As you all know, recently we had the online voting for the post of president elect, जहाँ पे हमारे दो कैंडिडेट थे और डॉक्टर मोतीलाल दास सर ने, डॉक्टर मोतीलाल दास सर आप कहाँ हैं सर? तो कृपया आगे आए, क्योंकि आप हमारे प्रेसिडेंट इलेक्ट होने वाले हैं नेक्स्ट 2022 16 अक्टूबर से, जब भी कॉन्फ्रेंस होगा। कृपया आगे आए सर। डॉक्टर मोतीलाल दास सर आइए यहाँ, और हम रिक्वेस्ट करेंगे हाउस से कि आप सर को बैठने दिया जाए, एसपी सिंह सर को। थैंक यू सर। हम लोग आगे बढ़ते हैं। आई विल रिक्वेस्ट डॉक्टर मोतीलाल सर कि दो शब्द जरूर कहें, क्योंकि ये ऑफिशियली वी आर फर्स्ट टाइम गोइंग टू मीट हिम, ऑल्दो हम लोग रोज मिल रहे हैं, बट उनका सर आपके बारे में हम लोग आपसे कुछ जानना चाहेंगे, सोसाइटी और के लिए आपका क्या विचार है?
First of all, I want to give thanks to all the members of Bihar and Jharkhand Society who are elected me as president-elect for the year 2022 to 23. So we are doing, I have the experience of more than 20 years of this society. I have organized the zonal state and serve as the secretary. And now I will serve as president. So I will try to do my best in future. And I hope the organizing committee of this national conference will do very much better. Thank you.
थैंक यू डॉक्टर मोती सर। सोसाइटी को आपसे बहुत उम्मीद है, हमें पता है कि आप बहुत ही मेहनत करके हमारी सोसाइटी को और भी ऊंचाई पे लेने चाहेंगे। और एक अच्छा इंफॉर्मेशन देना, जस्ट रिक्वेस्ट एवरीवन टू प्लीज कीप, हमारे बीच में हमारे गार्जियन डॉक्टर एसपी सिंह सर पधार चुके हैं, एक बार उनके लिए जोरदार तालियां होनी चाहिए। डॉक्टर एसपी सिंह सर, वेरी हैप्पी टू सी यू हियर सर, वेलकम सर। आगे बढ़ते हैं। secretary report. So generally secretary report इनॉग्रल स्पीच में भी पढ़ा जाता है, लेकिन इस बार चूंकि गवर्नर का बहुत स्ट्रिक्ट प्रोटोकॉल होता है तो एवरी मिनट इज काउंटेड. सो विद योर परमिशन कैन आई डॉक्टर मनोज, डॉक्टर पीके सर. Good afternoon everyone, ladies and gentlemen. A warm welcome to the 30th ISACON East Zone and 33rd ISACON Bihar and Jharkhand. First and foremost, first and foremost, I would like to extend my gratitude to all the dignitaries present over the dais. Dr. Manoj Kumar, GC member, ISA National. Dr. Braj Kishore Prasad, President, ISA Bihar and Jharkhand. Dr. Vijender, Chairman, Organizing Committee of this conference. Dr. Sukesh Kumar, Organizing Secretary. Dr. Neelam, the Treasurer of the BGSA. Thank you, Madam. Thank you, sir, for gracing the occasion. I also take this opportunity to thank our ISA National President, Dr. Mulidhar Joshi, National Secretary, Dr. Naveen Malhotra, and our very own Dr. Manoj Kumar, GC member, ISA National, for their guidance and encouragement towards organizing this event. On a personal level, I will be ever grateful to their continuous support and guidance during my tenure as Secretary. I also wish to thank all the past presidents of the ISA Bihar and Jharkhand for their contribution towards the development of the organization, with a special mention to Dr. Dev Sanjay Nag, our immediate past president. His dynamic leadership and innovative idea helped the organization to tide over the various challenges during this crisis, the COVID crisis. I wish to convey a special gratitude on behalf of our society members to our present president, Dr. Braj Kishore Prasad sir, for his continuous encouragement, engagement and guidance to all academic and non-academic activities. Sir, we sincerely thank you for being there for us in this crisis. We all know we have gone through lots of transformation, and sir was with us from the very beginning. I am delighted to share with you all that in recognition of his immense contribution to our society, BJSA has started an award since 2020 in his name for our private practitioner forum colleagues. This award will motivate and encourage our private practitioner colleagues to present scientific papers during our state conference. One information today, we had this session, and you will be happy that we had, Vishal, how many presentations? 6, no? 4, 3. There were 3 presentations, although we want 30 presentations. But here I want to give emphasis that we need the cooperation of all the president and secretary of the city branch. We need that they should then give information to every member, those who are practicing in their town. You please present your paper. Please present any case report at least. So we just a personal request to every president and secretary, even all the members की अपने members को please बोलिए कि आप कभी आके present करें, इसी बार interaction होता है. तो sir हमने वो शुरू कर दिया. Thank you very much. My sincerest thanks to our predecessor secretaries, Dr. Manoj Kumar, Dr. Ajay Kumar, present treasurer, Dr. Neelam Sinha, and all executive and scientific committee members for their outstanding work for our society, and also for their assistance in helping me with the daily affairs of the society. The past year has been very challenging for all of us, and it brought in a wave of unfortunate incidents. We all lost something precious in that wave, including but not limited to our beloved late Dr. Ashok Kumar Gupta, past GC member ISA National, past president ISA Bihar and Jharkhand, and chairman building committee. Society will always remain grateful for his immense contribution towards the betterment of our society and for sharing the best paper award for young anesthesiologist that encourages competitive academic activities among young anesthesiologists of our state. He was also instrumental in building and nurturing the various subcommittees in our organization since the inception. The adversities and challenges in the previous year also brought out the very best in us, and we did stand up and delivered when it mattered the most. The corona pandemic forced the postponement of our annual conference last year, but as doctor, we always face the challenges head on and seek the best alternative towards our desired goal, and we did the same yet again during this setback. We used to revolutionize our scientific and other activities through digital media. We were the first state in the whole country. We were the first state in the whole country to organize the virtual conference ISA BJ BevCon on 30th September 2020.
with approximately 300 members registered and many eminent speakers of the national, international participated. I want a big round of applause to all the members of BGSA for being the first state in the country to organize this conference. Thereafter, from the month of December last year, we also started monthly city branch CME and workshop where young and fresh passed out postgraduates are presenting their paper. We also developed our state website www.bjsa.com during this .in during that period. I am very proud of how we have all shouldered our responsibility as a frontline corona warrior, as well as taking administrative role during this challenging time. However, I wish to mention few of our achievements which have been on the larger scales, like distribution of the PP kits, face shield, mask and gloves to many of our colleagues and to common people. A large number of our colleagues were felicitated by various society and organizations, including government bodies, for their exemplary work in fighting against this COVID and serving this mankind. I am glad to say that at present, few of our BGSA members are representing our state at national level. Dr. Nishan Saha is in the COVID National Task Force and is also helping in the weekly ISA online PG classes. Dr. Abhiday as the quiz master, Dr. Manoj Kumar and Dr. Srividya are in the ISA Cultural Committee, and our society is really proud of them. I want a big round of applause for these our society members. This is the first time. I need your attention. Sir, this is the first time that few of our members are representing the national body. So it is a really pride matter for all of us. Earlier, there was no scope for the Bihar and Jharkhand member, other than the vice president or the president. But now the governing council is recognizing us. So I request all of you to please keep working hard. Definitely you will reach that level someday. I will also like to mention that at present there are approximately 900 registered ISA members from Bihar and Jharkhand. However, many of them are inactive. 900 में 499 केवल एक्टिव हैं. ये एक बहुत बड़ा कंसर्न है. इसमें 1 मिनट आप लोग सुनना चाहेंगे, बहुत जरूरी है. ये इलेक्शन होने वाला है फिर से 1 नवंबर से 5 नवंबर. 900 में सिर्फ 499, 500 रख लीजिए, एक्टिव मेंबर हैं. ये हमारे लिए गर्व की बात नहीं है. 500 लोगों में 400 लोग हमारे इनएक्टिव मेंबर. आप इस चीज को ध्यान दीजिए सर. हम रिक्वेस्ट करते हैं हमारे जितने भी सीनियर मेंबर हैं जो इनएक्टिव नहीं है, हमारा मदद लीजिए. आप सोसाइटी से बात कीजिए, सर हम इनएक्टिव हैं, या डॉक्टर शरद हम इनएक्टिव हैं. तो हम चाहते हैं आप लोग हम लोग से इंटरेक्ट कीजिए कि हम वोट नहीं दे पा रहे हैं, हमको आईजे का मेंबरशिप नहीं, मतलब सॉरी अपडेट नहीं हो पाया है, हार्ड कॉपी नहीं मिल रही है, सॉफ्ट कॉपी नहीं मिल रही है. तो थोड़ा इंटरेस्ट शो करना होगा तो वोट भी कर पाएंगे. अदरवाइज क्या होगा कि जब तक आपके पास नंबर नहीं है आपकी वैल्यू नहीं है. याद रखिए हर जगह 900 लोग अगर वोट करते हैं तो हर कोई आके आपसे बोलेगा मुझे सपोर्ट करो. कल को कोई प्रेसिडेंट खड़ा होता है तो दे विल नीड आवर सपोर्ट. तो आई रिक्वेस्ट all the inactive member to please get activated. It's very simple. Go to the ISA website. You can do it in a minute. In the last 1 year, 125 new members were added in our state. Most of them are our ALM, that is associated life member, PG students. They will convert to the life member when they pass. I urge all the anesthesiologists and the postgraduate students who are not a member of ISA to please register. Suppose you are studying, please register as an associated life member and you will become the life member when you will pass the MD or DNB. As you all are aware that our national ISA election or online voting is from 1st to 5th September. Please update, please participate. And this time, as we have already decided, we will support our East Zone candidate, Dr. Nivedita Pani. Again, we request, please vote, because this is a family. We always work as a family. जो family support एक दूसरे को करेगा वो आगे बढ़ेगा. So we have to support Nivedita Pani. I request all of you to please join the ISA Family Benevolent Fund for the benefit of your near ones. I also request you to kindly attend the 68th ISACon National at Ahmedabad from 25 to 29th. I heard Dr. Manoj is going with, Dr. Ajay is going with a large number of members. Dr. Manoj, very good. Please keep this up. We are lucky that during the last ISACon Bihar and Jharkhand 2019 at Bokaro, many stalwarts from ISA National and State were present. The gathering was a resounding success and we all still cherish its memories. It gives me immense pleasure that when I look at the gathering and find out that many of our leading personalities and stalwarts of our family are being present with us in this hall. उनके लिए एक बार जोरदार ताली होनी चाहिए. It is an honor to have you all, and we all seek your guidance and blessing in order to take this society at the greater height. I will conclude by thanking all my respected teachers. Ajit sir, he was my guide. Ajit sir, namaskar sir. And all this, Jagannath sir, आप भी हमारे टीचर रहे हैं, हम आपके छात्र रहे हैं सर, नमस्कार सर। और जितने भी हमारे टीचर हैं उनको हाथ जोड़ के मेरा सबको धन्यवाद। हमारे सीनियर्स, फ्रेंड्स, जूनियर्स एंड कलीग, अगेन we need their your continuous support, guidance and blessing, and of course love. Long live ISA. Jai Hind. Thank you. Now I will request our treasurer Dr. Neelam Sinha madam to please present the audit report of the BJSA, and she will also tell us about the current status of the building committee. I will now start saying the building trust.
गुड आफ्टरनून एवरीवन एंड सभी सीनियर्स को मेरा नमस्कार। थैंक्स टू ऑल द ऑर्गेनाइजिंग कमिटी, इतना सक्सेसफुल कॉन्फ्रेंस हुआ। एज अ ट्रेजरर आई एम गोइंग टू प्रेजेंट द ऑडिटेड अकाउंट ऑफ BJSA। As we know, in the pandemic time, we were not able to do much and we were doing most of the thing virtually. हमने जमशेदपुर में 20th September 2019 को एक अकाउंट खोला था, BJS अकाउंट, एंड उस अकाउंट को हमने 1000 रुपए से स्टार्ट किया था। उसके बाद उसमें बहुत सारे ट्रांजैक्शंस हुए थे केवल जमशेदपुर ब्रांच में। पटना ब्रांच एंड बिल्डिंग ब्रांच में बिकॉज ऑफ पैंडेमिक कोई भी ट्रांजैक्शन या एक्टिविटी नहीं हुई थी। हमें जो फंड्स मिले वो मिला ISA नेशनल हेडक्वार्टर से फॉर PPE which was distributed equally to all city branches for getting their PPE as told by Dr. Sharad Kumar. Dr. BK Prasad for the private practitioner forum award we received 1.5 lakh rupees from him, and various members contributed. Dr. Prashant contributed 10,000 rupees to the society. Different medical companies for the first virtual webcon which was held in the year 2020 during pandemic, various medical companies contributed. We had an online award paper for our PG students, and for that 36,000 was distributed as award money to them. Next. So this was mainly, and when we started our virtual CME, there was it was decided in the general body meeting that every city branch will contribute to the society. So Bokaro city branch, Darbhanga, Bhagalpur, they contributed to the society in the range of 5 to 10,000 rupees. Jamshedpur has promised 5,000 rupees. We have not received any amount from the other branches. Various payments was done to our website management company. So as of today, the balance with Jamshedpur account is 1,98,768 rupees. Next. Then we have Patna account. Patna account, because of the pandemic, it is at present it is dormant, and they will try to activate this account. To date, the amount with Patna city branch is 3,86,475 rupees. As we discussed the ISA building fund, we have FD of 8,15,756 rupees. We have in cash 1,24,800 rupees, and ISA building account fund is 2,22,900 rupees. Jointly the Patna and building trust account, they have 15,49,429 rupees, and combining both Jamshedpur Patna account as well as the building trust account, we have a total balance as of now is 17,48,198 rupees. Thank you.
Now the house is open to discuss the audit report. If you have any query, please raise your hand or come forward. We will take your question and we will try to give the reply. इसको माइक देखो, भैया भैया जी माइक देखिए तो.
Hello.
हाँ.
Yeah, I have information that me and Dr. Braj Kishore.
Madam Neelam, please write down.
Yeah, we had started one account for Eastern Zone way back, say 15 years back. It is the
You and
Dr. Braj Kishore for East Zone.
Okay,
At that
sir.
time, I was the secretary of the Eastern Zone,
Yes, sir.
and Dr. Braj Kishore was treasurer of that zone. And we had collected some money, and that account is still with the at Indira Gandhi Institute of Medical Sciences. And approximately, I think around 30,000 rupees must be there. And in Ceylon conference at Nigrims, it was decided that this money will be transferred to 3 state branches in dividing it. But at that time, no branch had its PAN number. So
Exactly.
this money is still lying at Indira Gandhi Institute of Medical Sciences, Allahabad account, now Indian Bank. So what should I do with that money?
Thank you, sir. I got your point, sir. So my suggestion is first that, sir, do you have the copy and all the documents, sir?
Yeah, we have.
So I request the member of the Patna Society branch, especially the secretary and the current treasurer, to please look into this matter. I request Dr. Sukesh, please come over here.
Yeah, Sukesh is here. It is not a Patna city branch. It
Got
is
your
a
point, sir.
zonal
I
branch.
got your point, sir.
If the zone has got
me-
PAN
why
number now.
why I'm taking why I'm taking the name, because the Sukesh stays here at Patna and the Prashant stays at Patna. It will be easy for them to work on this and to get the information of the Bihar, Bengal and the Odisha branch secretary. Connect with them. If they have any issue, please, I will also be there to help them. We will take the all the account details of these 3 branch secretary, state branch account details, and we can transfer that.
Yeah. Here is a one point, because at that time, no branch, even the zonal branch was not having its PAN number. So the money was decided to distribute. Now, the Eastern zonal branch has got its own PAN number now. So it will be my suggestion, because it is in the name of Eastern Zone. So why not to transfer this money to Zone?
Sir, as far as I know, sir, there is no account in the name of East Zone. I have from the last 3 years, I am into this matter. I don't know anything about this. So there is no zonal account. So my suggestion, distribute this 30,000 or अभी तो interest लेके 40 हो गया होगा, जो भी हो, divided by 3, transfer into the all Bengal, Odisha and state branch. Okay, sir? If you confirm, we will do that. I will take the help of Dr. Sukesh and Dr. Prashant for this.
Okay.
House को okay करना है? Any suggestion? Dr. Ajay?
No, only we have 3 state. So,
There was 3. I know, sir.
जब ऐसे बिल्डिंग फंड का अकाउंट गवर्नमेंट है, तो आपका भी अकाउंट गवर्नमेंट हो गया होगा।
नहीं सर, उसको तो एक्टिवेट करना होगा सर, उसको we have to reactivate sir. Yes sir, it can be activated sir. It can. Both the problem कब होता है, जब किसी की unfortunate incidents हो जाता है, then it creates problem to get activated. When the person is alive, there is no problem sir, it can be activated. So Dr. Ajit sir, आपका point well taken. I request Dr. Sukesh, please look into the matter. कोई दिक्कत होगा, I as a secretary will talk to the secretary of the Odisha and the West Bengal. Okay sir, आगे बढ़ें. House ये ऑडिट को पास किया जाए, कोई प्रपोज कोई करेगा? Anyone proposing the?
आगे बढ़िए.
डॉक्टर अजय आप प्रपोज कर रहे हैं, सेकंड कौन कर रहा है? डॉक्टर अजीत सेकंड कर रहे हैं. प्रपोजिंग बाय डॉक्टर अजय कुमार ऑडिट. डॉक्टर अजय ने प्रपोज किया, डॉक्टर अजीत कुमार सर ने इसको पास किया. आगे बढ़ते हैं. Any other matter? Now the house is open. Any other matter with the permission of chair? सर, आपकी आज्ञा हो तो हम लोग क्वेश्चन ले सकते हैं.
मेरा क्वेश्चन है सोसाइटी से कि हम लोग का 10 ब्रांच है, पटना में बिहार में 6 ब्रांच है और 4 ब्रांच झारखंड में है. तो हम लोग और जो प्रपोज्ड ब्रांच था बेगूसराय, सासाराम, इसमें हम लोग कितना दूर, क्योंकि बिना सोसाइटी मेंबरशिप स्ट्रेंथनिंग का सोसाइटी मजबूत नहीं होता है। और सेकंड क्वेश्चन मेरा ये है कि हम लोग का जब इलेक्शन होता है, ऑनलाइन इलेक्शन प्रोसेस अब हो गया शुरू, तो उसमें मोर देन 40% मेंबर अभी भी इनएक्टिव हैं। तो उसके लिए हम लोग क्या कर रहे हैं? उसके लिए जो ISA नेशनल है पूरा छूट दी है, आप इन्फॉर्म कीजिए, मेल कीजिए ISA-NHQ पे कि आपका मेल, ईमेल और जस्ट फोन नंबर, तो आपका एक्टिवेट हो जाएगा। तो बहुत से मेंबर जो कंप्लेन करते हैं, खासकर हमको या नेशनल स्टेट सेक्रेटरी को, ऑफिस बियरर को, कि मेरा वोटिंग प्रोसेस में प्रॉब्लम हो रहा है, तो वो अपना एक बार अकाउंट एक्टिवेट कर देंगे तो उनका हमेशा के लिए कोई जरूरत नहीं है उसके बाद एक्टिवेट करने का। और बहुत से मेंबर को कंप्लेन है हार्ड कॉपी क्यों नहीं आता है, तो उसके लिए भी जुलाई से लेके सितंबर तक सब्सक्रिप्शन लेने के लिए हार्ड कॉपी का आपको IC वेबसाइट पे जाके उसको सब्सक्राइब करना होता है, तो फ्री में आपको मिलेगा। उसे तो ऑनलाइन आप कभी भी एसेस कर सकते हैं। तो 2-3 पॉइंट है, हम चाहेंगे इस पे कुछ डिस्कशन।
हाँ डॉक्टर मनोज, आपकी पॉइंट से हम सहमत हैं। हमारे 900 मेंबर हैं बिहार झारखंड के, ऑन पेपर 900 मेंबर, 500 ओनली एक्टिव, 400 इनएक्टिव है। इनएक्टिव मेंबर को बहुत सिंपल कर दिया गया है, ISA के वेबसाइट पे जाना है, अपना डॉक्यूमेंट जो भी है मांग रहा है, अपडेट कीजिए। जहां दिक्कत हो प्लीज कॉल मी, आप मुझे कभी भी फोन कर सकते हैं, मैसेज कर सकते हैं, मेल कर सकते हैं, व्हाट्सएप कर सकते हैं कि यहाँ पे ये प्रॉब्लम है। सोसाइटी विल डेफिनेटली उसके लिए काम करेगा। और कोई दिक्कत तो हमसे नहीं होगा तो नवीन मल्होत्रा सर हैं, ही विल गाइड अस, ही इज आवर नेशनल सेक्रेटरी। सो अपडेट करिए अपने मेंबरशिप को। आई रिक्वेस्ट ऑल आवर सीनियर, स्पेशली सीनियर मेंबर्स, दे ऑल आर सीनियर्स, प्लीज जस्ट गिव अस सम इंफॉर्मेशन, वी विल डू दैट, वी विल सेंड ऑल द। बट क्या है कि पासवर्ड प्रोटेक्टेड हो गया है सर, हर चीज आजकल आपको OTP आएगा आपके मोबाइल पे, इसीलिए हम लोग बहुत बार नहीं कर पाते हैं, बट डेफिनेटली होगा। दूसरी बात थी कि सर हमारा 10 ब्रांच है, लास्ट टाइम हम लोगों ने कोशिश किया था और भी ब्रांच करने को, बट क्या है कि मेंबर्स को थोड़ा सा इंटरेस्ट शो करना होगा। बड़ी मुश्किल से, बहुत तकलीफों के बाद, आपको पता होगा गया मुजफ्फरपुर ब्रांच, बुरा ना मानेंगे, हम लोगों ने एक्टिवेट किया। आपको याद होगा मनोज भाई, हम लोगों को पता ही नहीं चलता था कि गया और मुजफ्फरपुर में कौन प्रेसिडेंट सेक्रेटरी है। 2 साल लगा मुझे पता करके उसको एक्टिव, एंड नाउ वी आर वेरी हैप्पी कि हमारे 10 ब्रांच एक्टिव हैं। रही बात हमारे 2 ब्रांच हम लोग खोलने की बात किए थे, सासाराम और हजारीबाग। सो आई एम वर्किंग ऑन दिस, थोड़ा समय दीजिए, हो सकते बेगूसराय भी था, सॉरी। तो 3 ब्रांच है हमारा, हम लोग कोशिश करेंगे उसको वहां बात करने का। एक हमारे डॉक्टर देव संजय नाग पास प्रेसिडेंट हैं, ऑनलाइन हैं, जूम पे हैं, एक क्वेश्चन पूछ रहे हैं। डॉक्टर देव संजय नाग, प्लीज आस्क योर क्वेश्चन।
Yeah, thank you, Dr. Sharad. First of all, I'd like to congratulate the Patna City branch for organizing this wonderful conference. Sare scientific content and the way it was managed, I would like to thank all the organizers and under the guidance of BK Prasad sir and Sukesh, it was a wonderful show. So the congratulations to entire team. Now one request to the state branch. Can I request that all the CME programs which we are having, can we have an online link with the topics mentioned on the ISAPJ website? And correspondingly, if possible, have the presentations also there as a repository so that not only today, but in future, all the students can benefit out of it.
थैंक यू डॉक्टर नाग, वेरी वैलिड पॉइंट। आपकी तरफ से हम फिर से पटना सिटी ब्रांच को कांग्रेचुलेट कर रहे हैं, एक बार जोरदार तालियों से सक्सेसफुल कॉन्फ्रेंस कराने के लिए धन्यवाद दे रहे हैं। और रही बात रिपोजिटरी की, तो आपका कहना सही है, हमारा जो भी BGSA का CME होता है, यू विल बी वेरी हैप्पी कि हम लोगों ने वेबसाइट पे, ठीक है, वेबसाइट पे हमारे 10 सिटी ब्रांच का 10 का अलग अलग नाम है, वहां पे अपडेट करने का प्लान है, ऑल्दो भी नहीं हुआ, आई एक्सेप्ट दैट, दैट इज माय फॉल्ट, बट वी कैन डू दैट। दैट्स अ वेरी गुड सजेशन डॉक्टर नाग, वी विल डू दैट। ठीक है,
थैंक यू।
और कोई सजेशन हो तो बताएं डॉक्टर नाग, तो आगे बढ़ते हैं। थैंक यू वेरी मच। और एनी अदर क्वेश्चन? हाउस इज ओपन फॉर द क्वेश्चन, जो भी, इनफैक्ट सजेशन ऑल्सो, कोई चीज बोलना चाहते प्लीज कम फॉरवर्ड, अपना परिचय दें और बताएं। सर कुछ राजीव अजीत सर बोलना चाह रहे
इसमें फैकल्टी अभी पूरा हो गया है, इसमें फैकल्टी पूरा हो गया है, उन लोग को भी निगोशिएट करके सिटी ब्रांच बनवाने का कोशिश किया जाए।
जरूर सर, हजारीबाग है, दुमका है और एक डाल्टेनगंज है। बिहार में भी काफी 27 मेडिकल कॉलेज हो गया जहां तक मुझे पता चला आज। सो हो जाएगा। सो सर गुड सजेशन, वी विल ट्राई टू।
सहरसा में भी 3 मेडिकल कॉलेज हो गया, एक मधेपुरा 2 सहरसा, वहां भी ब्रांच खोलने का प्रयास किया जा सकता है।
सही बात
इधर
है।
एक मधुबनी खुल गया है, इधर पूर्णिया में खुल रहा है।
राइट सर।
तो पूर्णिया कटिहार मिलाकर तो अभी ब्रांच है। तो जैसा कि मनोज बोले कि 10 ब्रांच है, यहाँ सिटी ब्रांच है, कटिहार
के साथ ऑलरेडी
कटिहार के साथ उसका ब्रांच है। तो हमारा कहना ये था ना कि सजेशंस है कि कॉन्फ्रेंस में इतने लोग आते हैं, लेकिन हर ब्रांच के ना सेक्रेटरी रहते हैं ना प्रेसिडेंट रहते हैं। इन लोगों में से किन्हीं एक को होना चाहिए। जो मेंबर्स को प्रॉब्लम होता है, जैसे इनएक्टिव से एक्टिव कराना है, तो वो सेक्रेटरी का थोड़ा सा काम होता है, तो ये आसान हो जाएगा। वो स्टेट लेवल का थोड़ा बर्डन घट जाएगा।
सही, गुड, वेरी गुड
नेशनल लेवल का घट जाएगा। ये सब स्टेट ब्रांच के सेक्रेटरी का जो भी काम है, सेक्रेटरी रहेंगे नहीं तो पता कैसे चलेगा। ये रिजोल्यूशन पास होना चाहिए
जी सर,
कि ऑफिस बेयरर में से किन्हीं एक को जीबी में प्रेजेंट होना चाहिए।
एकदम सही बात बोला सर।
और ऐसे
ताकि
भी
ब्रांचेज का काम स्मूथली चले।
मेरा भी ये सजेशन ये है कि कभी भी कॉन्फ्रेंस, कहीं भी कॉन्फ्रेंस होता है तो एटलीस्ट एक ऑफिस होना चाहिए आईएसए सब सिटी ब्रांच का, जो कि कोई भी प्रॉब्लम हो एटलीस्ट वहां पर सॉल्व होना चाहिए। कि यहाँ किसी को कोई आईएसए का मेंबर बनने में उसको कठिनाई हो रही है, एक्टिवेट करने में कठिनाई हो रही
जी
है,
हाँ, सही
तो
बात।
ये कॉन्फ्रेंस में एक ऑफिस होना चाहिए। हर कहीं भी हो, स्टेट का जो कॉन्फ्रेंस होता है एक ऑफिस बनाना चाहिए जिससे कि सारा प्रॉब्लम को सॉल्व किया जा सके।
ऑफिस बेयरर का प्रेजेंस भी जरूरी है।
बिल्कुल, बिना
सर
उसके
इसमें एक
presence का तो
सजेशन
ऑफिस
अगर
हो ही नहीं
हम,
सकता।
अगर आप लोगों की आज्ञा हो तो मैं एक सजेशन दूं डॉक्टर अजय। जो भी कॉन्फ्रेंस होता है तो क्यों ना हम जो प्रेसिडेंट सिटी ब्रांच के हैं, सेक्रेटरी हैं, उनको इनवाइट करें पर्सनली एंड गिव देम ए चेयरपर्सन। एटलीस्ट एक चेयरमैन, ठीक है, रजिस्ट्रेशन कराने दीजिए, उनको एक चेयरपर्सन दे दीजिए, किसी भी एक सेशन में बना दीजिएगा। देयर आर 20 हमारे मेंबर्स हैं, दे ऑल आर सीनियर, जो हमारे सोसाइटी में सेक्रेटरी और ट्रेजरर बन चुके हैं, उनको चेयरपर्सन बना दीजिए, मॉडरेटर बना दीजिए। एक क्या होता है ना, बहुत लोग चाहते हैं यार मेरे को तो कुछ मिला ही नहीं, मैं क्यों जाऊं। सो डिपेंड्स, थोड़ा सा हम लोग भी अपना इंटरेस्ट शो करें, वो भी करें, तो वी कैन डू दैट।
डिपेंड्स करता है कि वो कितना इंटरेस्ट।
एग्जैक्टली। अगर हम बोलें कि आप,
दूसरा ये होता है ना कि चेयर से अपना सेशन किए, टाइम देखे, बस मेरा टाइम होगा मैं चलता हूँ, ये भी होता है।
ये तो खैर हम नहीं कह सकते पर्सनल लेवल पे, बट मेरा सजेशन है हाँ कि हम लोग और कोई सजेशन हो तो बताएं सर, पॉइंट सही है। कोई और पॉइंट सर?
मेरा एक सजेशन एक मेरे तरफ से था
जी हाँ, बोलिए।
शरद बॉस को, कि हम लोगों को जैसे आईएसए में एक बैच है नेशनल का, ये हम लोग को एक बिहार झारखंड का एक बैच बनना चाहिए, जो एटलीस्ट ऑफिस बियरर जो है उस बैच को लगा करके वो
ये जो डॉक्टर अजय ने बोला, ये बात हमें काफी लोगों ने बताया इस बार कि हमारे जो भी स्टेट एग्जीक्यूटिव हैं और सिटी ब्रांच के एग्जीक्यूटिव हैं, ऑर्गेनाइजिंग एटलीस्ट उनको एक मोनोग्राम या बैच होना चाहिए। जो स्टेट ब्रांच का डॉक्टर बीके सर से मैंने परमिशन ले चुका है इसके बारे में। नेक्स्ट कॉन्फ्रेंस में यू विल फाइंड ऑल द स्टेट एग्जीक्यूटिव टू हैव दैट बैच, एंड रांची अगर कर रहा है तो वो भी रखेगा। ये बात डॉक्टर बीके सर, बीके प्रसाद सर, आपसे जैसी मेरी बात हुई थी, अभी सिर्फ हमारे पास मेडल जो है हमारे प्रेसिडेंट पहनते हैं, सेक्रेटरी, ट्रेजरर एंड ऑल द एग्जीक्यूटिव विल हैव दैट समथिंग, कुछ ना कुछ होगा उनका, दैट क्योंकि दे आर रिप्रेजेंटिंग अस।
सिंपल बैच,
एग्जैक्टली, वी विल डू
का एक बैच
बन जाएगा। हाउस ओके है, पास कर रहा है इसको,
ओके
पास।
और मेरा एक वैलिड पॉइंट है बॉस, हम लोग हर साल इलेक्शन के लिए कुछ प्रोटोकॉल नहीं कर पाते हैं, कौन खड़ा होगा इलेक्शन में,
एजेंडा में है
नहीं, एनी अदर के बाद तो एजेंडा
में
होता
है।
नहीं।
मनोज भाई ये एजेंडा में है, हमारे पॉइंट को आ रहे हैं।
ओके,
तो एक मैं यहाँ पर हाउस में ये क्वेश्चन करना चाहता हूँ पूरे हाउस से, कि हम लोग एक कॉन्फ्रेंस ऑर्गेनाइज करते हैं, उस कॉन्फ्रेंस में बहुत इंपॉर्टेंट प्रोग्राम होता है इनॉग्रेशन का, और इस इनॉग्रेशन प्रोग्राम में हमको लगता है कि सारे लोग जा चुके होते हैं। जिस समय इनॉग्रेशन का टाइम होता है उस समय सारे लोग जा चुके होते हैं, और जब कोई हमारे चीफ गेस्ट आते हैं उनके सामने 25 से 30 आदमी जब रहते हैं काफी खराब लगता है,
सही
अच्छा
बात,
नहीं
सही
लगता है।
बात।
और ये मैं पर्सनली इस चीज को फील किया हूँ, क्योंकि राज्यपाल ऑफिस से मेरे पास फोन आया कि आप तो कहे थे कि 300 से ऊपर डेलीगेट है, यहाँ तो 25-30 आदमी भी नहीं दिख रहा था। ये हमारे पास फीडबैक आया, तो ये बहुत खराब लगता है। इसलिए सारे लोगों से रिक्वेस्ट है कि जिस तरह से साइंटिफिक प्रोग्राम होता है, जिस तरह से आप लंच में पूरा भीड़ लगी रहती है, डिनर में भीड़ लगी रहती है, तो इनॉग्रेशन में क्यों नहीं आप 1 घंटा समय क्यों नहीं दे सकते हैं? अगर आपकी तरफ से कोई सजेशन है कि इनॉग्रेशन का टाइम बदलना चाहिए, इनॉग्रेशन का डेट बदलना चाहिए, तो आप इस हाउस में आप क्वेश्चन कर सकते हैं कि ये इनॉग्रेशन का टाइम बदला जाए। क्योंकि मेरे तरफ से एक है कि टाइम की वजह से एक प्रॉब्लम आ सकता है, टाइम की वजह से हमारा मीडिया कवरेज भी नहीं हो पाता है। मीडिया कवरेज क्योंकि 6-7 बजे 8 बजे जब हमारा प्रोग्राम खत्म होता है उस समय तक सारे प्रेस वाले अपने काम में लगे रहते हैं।
डॉक्टर अजय, आपका
हाँ।
पॉइंट वेरी वेल टेकन, क्योंकि हम लोगों ने अनुभव किया कि डॉक्टर गवर्नर साहब थे, मुश्किल से 40-50 लोग थे। ये सही बात नहीं है, क्योंकि हम जब जाते हैं गवर्नर साहब या किसी भी डिग्निटरीज का नंबर अपॉइंटमेंट लेने, दे आस्क कितने लोग रहेंगे वहां, तो बड़ा वो खराब लगता है कि हम बोल के आते हैं 300 लोग रहेंगे, यहाँ 50 लोग हैं, तो दिस इज नॉट गुड। मेरा एक सजेशन है, जो आपकी बात से हम सहमत हैं, लंच के समय जो हम भी मानते हैं, लंच अगर 1 बजे होता है तो 12 बजे इनॉग्रेशन रखिए। ओरेशन भी तो हम लोग उसी समय रखते हैं ना, जान के कि ओरेशन के समय मैक्सिमम लोग क्यों रहते हैं, क्योंकि हम लोग देखिए हम सबको ही चाहते उस समय हमें भूख लग जाती है, तो व्हाई नॉट 1 आवर जस्ट बिफोर द ओरेशन, कि अगर कोई चीफ गेस्ट है वो भी मेरे साथ लंच करे, तो ओरेशन सॉरी जस्ट बिफोर द लंच वी कैन कीप द इनॉग्रेशन।
बिल्कुल, मेरा ये सजेशन है,
आप अगर बताएं तो इसको
हाउस
हम
की
लोग
तरफ
नेक्स्ट
से।
टाइम हम लोग रांची में ये करेंगे, इज ओके? क्योंकि सबसे अच्छा समय सुबह 11 से 1 के बीच में रहता है, जो जब सब कोई आ जाते हैं कॉन्फ्रेंस के दिन। तो इसको अगर आप लोग ओके करेंगे तो रांची में हम लोग ये इंप्लीमेंट करना चाहेंगे। ओके, कोई डॉक्टर अजीत ने प्रपोज की, मैंने प्रपोज किया, सॉरी अजीत सर ने सेंट ऑर्गेनाइजिंग कमिटी ऑल्सो द पर्सन हु इज कमिंग डेफिनेटली, बट वी कैन ऑलवेज रिक्वेस्ट दैट। ठीक है सर, आगे बढ़ते हैं सर। डॉक्टर श्वेता भारती हेम्ब्रम, आपका बैग यहाँ छूट गया, प्लीज कलेक्ट योर बैग फ्रॉम द ऑफिस। डॉक्टर श्वेता भारती हेम्ब्रम, उसमें लैपटॉप भी है, प्लीज कलेक्ट फ्रॉम डॉक्टर प्रशांत। आगे बढ़ते हैं। एक बड़ा इस जो इलेक्शन हुआ अभी इस बार बिहार झारखंड का स्टेट इलेक्शन एंड सिटी ब्रांच इलेक्शन, एक आया था क्राइटेरिया फॉर द सिलेक्शन ऑफ द कैंडिडेट स्पेशली द सीनियर प्रेसिडेंट, सेक्रेटरी एंड द ट्रेजरर। उसमें थोड़ा एम्बिग्यूटी हो गई। क्या हो गया कि कुछ लोगों ने मुझे कंप्लेन किया कि हम जूनियर मेंबर है, माने जस्ट मेंबर ऑफ द आईएसए एंड ही कैन ही फाइट फॉर द पोस्ट ऑफ आईएसए प्रेसिडेंट ऑफ द सिटी ब्रांच और द स्टेट ब्रांच और द सेक्रेटरी, बिकॉज दीज आर सीनियर पोस्ट। सो आई ऑल्सो थॉट कि नहीं, ये इस पे थोड़ा डिस्कशन इज नीडेड फ्रॉम द हाउस। ये कंप्लेन ऑफिशियल कंप्लेन है मेरे पास, सो हाउस इज ओपन फॉर द डिस्कशन ऑन दिस पॉइंट। प्रेसिडेंट और सेक्रेटरी क्या कोई डायरेक्ट मेंबर बन सकता है? क्या ही शुड और शी शुड हैव सम एक्सपीरियंस एज वर्किंग एज ए गवर्निंग काउंसिल फर्स्ट फॉर एटलीस्ट 2 टर्म्स, मेरा मानना है। उसके बाद ही और शी शुड गो फॉर द सेक्रेटरी एंड द president, at least these 2 posts. So house is open for discussion because this is an official complaint. So I would like to take the opinion of the house.
डॉक्टर सर, मैं नेशनल का रूल इसमें बताना चाहूंगा, इसके बाद हाउस डिसीजन ले सकता है। फॉर प्रेसिडेंट इलेक्ट, क्योंकि अब प्रेसिडेंट का इलेक्शन डायरेक्ट नहीं हो रहा, प्रेसिडेंट इलेक्ट 10 year experience एज ए आईसीए मेंबर, तो ये है प्रेसिडेंट और वाइस प्रेसिडेंट के लिए। सेक्रेटरी के लिए 5 साल और 5 साल से ऊपर, और जीसी मेंबर के लिए भी 5 साल होना चाहिए। तो ये और जो जीसी मेंबर ही सबसे पहला एंट्री होता है एग्जीक्यूटिव कमिटी में। जीसी मेंबर होने के बाद वो ट्रेजरर, वाइस प्रेसिडेंट और एडिटर ऑफ जर्नल और प्रेसिडेंट इलेक्ट बन सकते हैं। तो ये मैंने आईएसए नेशनल का क्राइटेरिया है। थोड़ा सा उसमें लिबरल बना गया कि सिटी ब्रांच के लिए, कि सिटी ब्रांच में आप थोड़ा, क्योंकि मेंबर कुछ कम होते हैं, तो थोड़ा सा ईयर कम किया जाए। कर सकते हैं, लेकिन ये पूरा नेशनल का रूल है। हमको लगता है कि हाउस में अगर है तो नेशनल या उससे जो भी है पास होके अगले बार इलेक्शन में हम लोग को फायदा होगा।
सो दैट्स अ गुड सजेशन। जो नेशनल में इम्प्लीमेंट हो रहा है एटलीस्ट स्टेट ब्रांच में सेम चीज इम्प्लीमेंट होना चाहिए। सिटी ब्रांच में वी कैन गिव देम सम लिबर्टी, बट नेशनल और स्टेट का रूल रेगुलेशन सेम होना चाहिए। सो आप लोग बताएं, कोई डॉक्टर नितिन आप कुछ कहना चाहते हैं? Okay, so we got your point. For the state election, all the criteria we will follow the national, right? Yes. आगे बढ़े सर, चलिए।
Governing council member or the vice president.
For that city, sir, we are not talking about. We are talking about the state, sir.
Not city. I'm talking of the state, not national. For national, those rules are there.
नहीं sir.
Otherwise, no young people will come forward for any sort of help or anything.
Dr. Sharad, can I come in?
Which are number of members, active members.
Dr. Sharad, is it possible a member working in city for last 10 years, again he will be a member for a state and then he will fight for secretary and president? Is it possible? He will lost at least 10 to 15 years, then he will be a president and secretary to a state.
See,
secretary के लिए 5 साल, only 5 साल.
5 years.
Sir, as we do not have a rule regulation for the state branch formulated so far, so we should follow the
Exactly. That is written in our bylaws. I have the copy with me. Bylaws में कहता है सिटी ब्रांच, सॉरी स्टेट ब्रांच में जो रूल नहीं है उसमें नेशनल का रूल फॉलो होगा। कहीं कोई कंफ्यूजन नहीं है इसमें। सो हाउस उसको ओके करना चाहिए मेरे विचार से। तो अगर कुछ उससे
सर उसमें यही लिखा हुआ कि सिटी ब्रांच और स्टेट ब्रांच।
Sharad, can I come in?
कर सकते। सिटी ब्रांच, नॉट द स्टेट, सिटी ब्रांच।
Dr. Sharad.
हाँ, yes, Dr. Nag.
See, I'll have a opposing view over here. I know it may not be the consensus opinion, but something we should keep in mind. If somebody has the talent and somebody has the capability and the support, see, this is a democratic process. So everybody who is, you may put in a point that he should be a ISA member for the last 10 years. That gives him adequate experience to take up these positions. But I think there have been many such cases, past presidents, some of us on the stage today also, we have not been following it. And I don't think there has been a dearth of talent in providing leadership to the ISA Bihar Jharkhand team. So making the system very tight actually will stifle good leadership coming up. And today we all know age is not a criteria, capability is the criteria. So we may go with the house, but this is one point of view I'd like to put across.
Okay, Dr. Nag, I got your point. Your point is very well taken. But my only is the objection for the post of president and secretary, because these are very, very responsible posts. We cannot take a person who is coming directly and becoming the president or secretary. He or she should understand the working. I know it is important, talent should be there, but the understanding the sentiments, the laws, the working, how the society works, it is also very, very important, sir. So my suggestion is, I maybe differ, कि एक बार एग्जीक्यूटिव या 2 बार एग्जीक्यूटिव होना चाहिए एटलीस्ट फॉर द प्रेसिडेंट एंड द सेक्रेटरी।
मेरा सजेशन है सिटी ब्रांच के लिए मेरा सजेशन है कि 3 साल के लिए गवर्निंग काउंसिल के लिए 5 साल से घटा के 3 साल कर दिया जाए, ओनली फॉर सिटी ब्रांच, नॉट फॉर स्टेट ब्रांच एंड नेशनल। सिटी ब्रांच में चूंकि कम मेंबर रहते हैं, हमारे यहाँ छोटा छोटा भी ब्रांच है, पटना में मोर देन 300 मेंबर है। तो जो गवर्निंग काउंसिल भी बनना है अगर आपको, तो 1 साल का मेंबरशिप नहीं चलेगा। आपको 1 साल तो समझने में लगता है ऐसे को, 3 साल में आप एक मैच्योर पर्सन बन जाते हैं ऐसे को समझने के लिए। मिनिमम 3 साल, 5 साल से लिबर्टी करके 3 साल किया जाए, और गवर्निंग काउंसिल बनने के बाद ही आप जो है सो सेक्रेटरी एंड प्रेसिडेंट, वाइस प्रेसिडेंट के लिए आप आगे बढ़ सकते हैं। तो
सर मेरा एक सवाल कहाँ के वाइस प्रेसिडेंट, और सिटी ब्रांच के लिए और स्टेट के लिए? सर मेरा एक सवाल है,
नहीं नहीं सर, देखिए दो चीज को मिक्स ना करें। सिटी ब्रांच अलग है, सिटी ब्रांच के लिए डॉक्टर मनोज कह रहे हैं ओनली 3 years, ठीक है।
डॉक्टर शरद, if I
इसमें
can
क्या
come in.
बोला गया, इसमें एक वर्ड आपने ध्यान नहीं दिया। सिटी ब्रांच को लिबर्टी दिया गया है, लिबर्टी वो दिया जाएगा। पहला बार तो कोई भी बनेगा ना भाई प्रेसिडेंट, उसको तो लिबर्टी दिया जा रहा है, कोई नया ब्रांच है। बट जो प्रेजेंट सिटी ब्रांच है उसकी बात हो रही है, लिबर्टी दिया जा रहा है सिटी ब्रांच को सब कुछ। स्टेट ब्रांच के लिए थोड़ा रूल टाइप होना चाहिए, क्योंकि स्टेट ब्रांच आगे सीनियर पर्सन माना जाता है।
सर मेरा एक सवाल है।
हाँ प्लीज डॉक्टर प्रशांत दास।
मेरा एक सवाल है कि जो लोग विदाउट 5 year एक्सपीरियंस जीसी या कुछ बन चुके हैं उनका क्या होगा?
पास्ट इज पास्ट, पास्ट इज पास्ट।
पास्ट तो क्या वो ट्रेजरर सेक्रेटरी और उसके पोस्ट पे खड़े हो सकते हैं या नहीं हो सकते हैं?
नहीं नहीं, देखिए पास्ट को जिस
वो जीसी बन चुके हैं तो क्या वो ट्रेजरर सेक्रेटरी और खड़े हो सकते हैं?
बन सकते हैं।
थैंक यू सर।
दे हैव द एक्सपीरियंस।
इसमें एक और पॉइंट है, मेरा सजेशन है डॉक्टर शरद कि जो अगर मान लिए स्टेट में जीसी मेंबर है, अगर वो अपने ओन सिटी ब्रांच में सेक्रेटरी या ये बन सकते हैं कि नहीं?
क्यों नहीं बन सकते? दे शुड हैव द अंडरस्टैंडिंग ऑफ द वर्किंग।
बिहार से अपने सिटी ब्रांच में आके सेक्रेटरी बन सकते
हैं। व्हाई नॉट?
ओके।
अगर काम किया हुआ, हम लोग क्या चाहते हैं कि एक थोड़ा सा अनुभव होना चाहिए, थोड़ा सा अनुभव बहुत इंपॉर्टेंट, थोड़ा सा, ज्यादा नहीं, थोड़ा।
जो सिटी ब्रांच के प्रेसिडेंट रहे हैं और सेक्रेटरी रहे हैं वो क्यों नहीं बन सकते स्टेट? उनको क्या एक्सपीरियंस कम होती है?
सिटी ब्रांच के प्रेसिडेंट तो एग्जीक्यूटिव माने ही जा रहे हैं सर। वो क्या कहा जा रहा है, आप समझ नहीं पाए बात को। स्टेट ब्रांच में जाने के लिए सिटी ब्रांच का भी अनुभव काम आएगा।
जी जी,
आप समझिए बात को। उनको आईएसए का वर्किंग मालूम होना चाहिए। ये कोई नहीं कह रहा कि स्टेट से आप सिटी से स्टेट नहीं जा सकते हैं।
नहीं, हम
अंडरस्टैंडिंग होनी चाहिए।
हम तो यही समझ रहे हैं।
नहीं डॉक्टर शरद, आई वांट टू कम इन ओवर हियर।
वहाँ का मेंबर होना पड़ेगा, जी मेंबर बनना पड़ेगा।
नहीं सर एक मिनट, मैं रंजीत इसमें क्लियर कट है। सबसे पहले आप सिटी ब्रांच को आप मान लीजिए, सिटी ब्रांच है, जिस सिटी ब्रांच जो भी फॉलो किया वो एक उसका अपना रूल रेगुलेशन अपना चलेगा। स्टेट के लिए, स्टेट में आप जा रहे हैं, मेंबरशिप का क्राइटेरिया जो भी फिक्स किया गया 5 years ऑफ मेंबरशिप ऑफ आईएसए, उसके लिए आप जीसी मेंबर के लिए एलिजिबल हैं। आप जीसी मेंबर में आप फाइट कीजिए। जिसे
नहीं तो मैं पूछना चाहता हूँ कि एक सिटी ब्रांच का
नहीं, नो
फिर से जीसी मेंबर बनेगा?
नो, सिटी ब्रांच में अगर आप एग्जीक्यूटिव हैं, आप यू आर नॉट फाइट कि आप जीसी मेंबर, उसके लिए आप जीसी मेंबर के लिए पहली बार आपको फाइट करना पड़ेगा स्टेट में।
ये कहाँ का रूल हुआ कि एक सेक्रेटरी?
वही नेशनल का रूल है, ये नेशनल का रूल है। आप नेशनल रूल को
नेशनल में भी यही रूल है,
नेशनल का रूल है।
सर ये कहाँ लिखा है कि एमएलए बनना जरूरी होता है?
एग्जीक्यूटिव मेंबर को फिर जीसी मेंबर बनाइए।
सिटी ब्रांच में बन के जाके स्टेट में घुसा है, उसके बाद हम नेशनल, क्यों नहीं हम नेशनल इलेक्शन सीधा लड़ सकते हैं? क्यों ये
इलेक्शन नहीं लड़ सकते?
नेशनल
इलेक्शन नहीं सर, नहीं लड़ सकते हैं सर। नेशनल बायलॉज के अनुसार आप सिटी में हर पोस्ट पे बढ़ने के लिए पहले जीसी मेंबर होना है।
एग्जैक्टली।
स्टेट में हर पोस्ट पे बढ़ने के लिए उसका जीसी मेंबर बनना होगा, और उसके बाद अगले स्टेप पे आप आ सकते हैं। नेशनल में भी जीसी बनने के बाद ही होगा। तो
सिटी में कौन बनेगा फिर?
हाँ तो आप
तो सिटी छोड़ के लोग स्टेट में लड़ेगा ना?
नहीं, ये स्टेट क्यों लड़ेगा?
टाइम जा रहा करें इसमें, बताइए तो आप हमको। Why I'm wasting the time? Why should I fight for city branches? Who will fight?
एक कंफ्यूजन और हम आपको क्लियर कर देते हैं। नेशनल में भी 5 साल का एक्सपीरियंस मतलब ओनली मेंबरशिप होना चाहिए। ये जरूरी नहीं है कि आप कहीं के प्रेसिडेंट, सेक्रेटरी या एग्जीक्यूटिव हैं। वो डायरेक्ट आप 5 साल का मेंबरशिप है तो यू कैन एलिजिबल फॉर जीसी मेंबर ऑफ नेशनल।
5 years membership and 3 years active membership. 5 year membership and 3 years active membership.
एग्जैक्टली एक्टिव होना जरूरी। अटेंडेंट एग्जैक्टली, साइन इज जरूरी। नहीं, एक्टिव मींस साइन करना है।
ये तो क्राइटेरिया है ही। आप 5 कॉन्फ्रेंस में, 3 कॉन्फ्रेंस में के एजीएम में ना कि कॉन्फ्रेंस में, एजीएम में प्रेजेंट होना है आपको।
ओके, तो इस पे थोड़ा एम्बिग्यूटी है, ठीक है। आई विल टेक द ओपिनियन ऑफ द नेशनल सेक्रेटरी डॉक्टर नवीन मल्होत्रा. I will take the rules and regulation. I will circulate to all the members to the society, and we will again discuss. See, house should discuss.
I think we don't have to take any advice from anybody. We have the criteria laid down before in the state, and that will be followed. Any city branch executive may be
To be very frank, sir, मेरे पास bylaws की कॉपी है, उसमें इसके बारे में मेंशन नहीं है ज्यादा. हाँ, so as we are running short of time, I am getting lots of information. We have to vacate this hall at 5. So we are moving. We will discuss with this with Naveen Malhotra. House is okay? Shall I discuss?
No.
एक मिनट. Just a minute, sir. Just a minute, sir. स्टेट वाला जो आप ले डाउन कर रहे हैं लॉ, वो हम लोग फॉलो करेंगे नेशनल वाला. और सिटी ब्रांच के लिए हम लोग अपना डिसाइड कर
वही तो बोला जा रहा है सर.
और सिटी ब्रांच के लिए जैसे मान लीजिए कि एक नया सिटी ब्रांच हम सासाराम में खोलने जा रहे हैं, वहां पे 20 मान लीजिए 15 है, 20 एनेस्थेसियोलॉजिस्ट है, तो हम लोग उन्हीं में से चुनेंगे. तो सिटी ब्रांच के लिए हम लोगों को 1 ईयर जीसी मेंबर होना इज सफिशिएंट. 3 इयर्स नहीं, 1 ईयर. और उसमें आप ये एक ऐड कर सकते हैं कि मिनिमम 1 या 2 पिछले 5 साल में आप अटेंड किए हैं जीबी मीटिंग.
सर नया ब्रांच में कोई प्रॉब्लम नहीं है, जो पहला बार बनेगा कोई तो प्रेसिडेंट बनेगा ना सर.
हाँ,
लेकिन उसके भी 2 साल के 3 साल के बाद उसको अदर सिटी ब्रांच का तो रूल फॉलो करना होगा ना सर.
फर्स्ट टाइम हम लोग इंस्टॉल कर दिए, सेकेंड टाइम जो एलिजिबल होगा मिनिमम 1 ईयर रहता है.
ठीक है, वो बात सही है.
1 ईयर.
तो सिटी ब्रांच में लिबर्टी काफी दिया गया है.
ब्रांच में आप चेंज कर सकते हैं.
सिटी ब्रांच को हम लोग चेंज कर सकते हैं, लेकिन स्टेट वाला ब्रांच जो है और जोनल ब्रांच जो है वो हम लोग को फॉलो करना है.
रूल फॉलो करना है सर, यही तो हम बोल रहे हैं.
फॉलो करना.
एग्जैक्टली.
डॉक्टर दिनेश सर, इसमें हम लोग पटना ब्रांच का भी मीटिंग हुआ था वर्ल्ड एनेस्थीसिया डे पे, तो हम लोग डिसाइड किए थे कि पटना में 3 साल का जो मेंबरशिप है वो जीसी मेंबर के लिए एलिजिबल हो जाएगा. 3 साल. और नया ब्रांच के लिए कोई बात नहीं.
नया ब्रांच के लिए कुछ नहीं, नया रूल दे कैन.
ये हम लोग बायलॉज में हम लोग इंक्लूड कर सकते हैं. स्टेट
चलिए खत्म कीजिए, है ना. हेलो,
ठीक है, इसमें थोड़ा सा एम्बिग्यूटी है. वी विल डिस्कस अगेन ऑन दिस. आगे बढ़ते हैं सर. नेक्स्ट स्टेट कॉन्फ्रेंस दिस टाइम बिहार को था. जैसे हम लोगों ने डिस्कस किया हुआ है, हर बार जो भी चीज होगा एक बार बिहार में होगा, एक बार झारखंड में होगा. सो दिस टाइम वी आर ऑर्गेनाइजिंग एट दिस प्लेस पटना. नेक्स्ट ईयर इज झारखंड. तो झारखंड में रांची का टर्न है. एंड आई हैड ए डिस्कशन विद द सिटी ब्रांच सेक्रेटरी डॉक्टर नसीम अख्तर, एंड ही वाज काइंड इनफ टू से that they are willing to host the conference at Ranchi. डॉक्टर अजीत सर, आप वहां के रिप्रेजेंटेटिव हैं, गवर्निंग काउंसिल के सबसे सीनियर मेंबर हैं, कुछ कहना चाहेंगे सर? सर यहाँ आके बोले सर, कॉन्फ्रेंस अनाउंस करना.
Hello. It will be hosted next year in Ranchi. It will be hosted next year in Ranchi, and everybody is cordially invited, and you will all enjoy there, I promise.
Thank you, sir. Thank you, sir.
Thank you. और रांची, जमशेदपुर एंड झारखंड इज नॉट ए ड्राई स्टेट. इसको डॉक्टर नीलम प्लीज लिखिएगा नहीं. सही बात, दैट्स नॉट ए ड्राई स्टेट. आगे बढ़ते हैं. इसके बाद भी हमारा, चूंकि आपको पता है प्रेसिडेंट और प्रेसिडेंट इलेक्ट का पोस्ट 1 साल के लिए होता है, तो फिर नेक्स्ट ईयर हम लोग नॉमिनेशन करेंगे. अगर जो आना चाहते हैं आ सकते हैं. हर सिटी ब्रांच के प्रेसिडेंट और सेक्रेटरी का 1 ही साल, सॉरी प्रेसिडेंट इलेक्ट का 1 ईयर होता है. आगे बढ़ते हैं. हमारे इंस्टॉलेशन ऑफ द न्यू प्रेसिडेंट, आपको जैसे पता होगा लास्ट ईयर, डॉक्टर आपको याद होगा लास्ट ईयर हम लोगों ने प्रेसिडेंट इलेक्ट का चुनाव किया था ऑनलाइन. उसके पहले इट वाज कंसेंसस डिसीजन कि एक बार प्रेसिडेंट बिहार से होगा, झारखंड से होगा. सो बीके सर हमारे प्रेसिडेंट हैं, और हम लोग इंस्टॉलेशन सेरेमनी नए प्रेसिडेंट का करने जा रहे हैं. तो हमारे नए प्रेसिडेंट हैं धनबाद सिटी ब्रांच के एक्टिव प्रेसिडेंट डॉक्टर डीके सिंह. डॉक्टर डीके सिंह सर, he will be our next president. I request you to come over the dais, change the medal, and take your respective position. I request. नहीं नहीं इंस्टॉलेशन बीच में होता है ना. हाँ सर रुकिए एक मिनट, आप पहुंच जाइए पहले सर. सो हमारे नए प्रेसिडेंट फॉर द नेक्स्ट 1 year इज डॉक्टर डीके सिंह, धनबाद के. एंड देयर विल बी अ चेंज ऑफ मेडल्स. आई रिक्वेस्ट डॉक्टर बीके प्रसाद सर. मिलेगा मिलेगा. दिस इज द गोल्ड मेडल सर. प्रेसिडेंट गोल्ड मेडल होता है और एक सर बीके सर आइए बैठिए. दोनों सर बैठिए एक बार, हम फिर इनवाइट करेंगे आपको थोड़ी देर में. So now I invite our new elected president, Dr. DK Singh sir, to come over the dais and give his view for the next 1 year and his. Dr. Vice President Dr. Mahesh Kumar from the Bhagalpur is not present over there here. So I request our new president Dr. DK Singh sir to come here and give his speech. Dr. DK Singh sir.
Respected हमारे जीसी मेंबर डॉक्टर मनोज, हमारे जस्ट पास्ट प्रेसिडेंट प्रसाद साहब, डॉक्टर शरद, डॉक्टर विजेंद्र प्रसाद, डॉक्टर नीलम, डॉक्टर सुकेश, and of the dais, all my seniors, सबको प्रणाम सर. एंड आप लोगों के आशीर्वाद से हम लोग आगे भी आईएसए का नाम रोशन करते रहेंगे बिहार झारखंड का. और जो भी लेट डाउन है हम लोगों का प्रोग्राम, आई विल ट्राई टू गिव माय बेस्ट ताकि बिहार झारखंड आईएसए कुछ नई ऊंचाइयों को छू सके. और जो प्रोग्राम डॉक्टर प्रसाद साहब और डॉक्टर शरद हमारे सेक्रेटरी, डायनेमिक सेक्रेटरी ने शुरू किया है, उस पे हम लोगों का, मेरा भी पूरा सहयोग रहेगा. आगे भी वो चलता रहेगा वो प्रोग्राम. अभी हम लोगों के पास एक बहुत बड़ा चैलेंज है 2024 का. होपफुली ये हम लोगों को मिल जाता है तो डे 1 से ही हम लोग इस पे काम करेंगे. जैसे ही ये कंफर्म हो जाता है, हमारे जीसी मेंबर डॉक्टर मनोज डिक्लेयर करते हैं कि वी आर गोइंग टू ऑर्गेनाइज द ईशाकॉन नेशनल इन 2024. वी विल स्टार्ट फ्रॉम दैट डे. और वो हम लोग बहुत शानदार ढंग से करेंगे और बहुत अच्छे ढंग से करेंगे. दिस इज आवर प्रॉमिस. मेरे बाद जो डॉक्टर मोतीलाल आ रहे हैं, ही इज ऑल्सो वेरी डायनेमिक पर्सन. और 2024 तक हम लोग बहुत काम कर लेंगे नेशनल कॉन्फ्रेंस के लिए. एंड हम लोग बहुत ज्यादा टाइम ले चुके हैं, इसलिए थैंक यू टू ऑल एंड प्रणाम हमारे सीनियर्स को.
Thank you very much and congratulations to Dr. DK Singh for being the president of the Bihar and Jharkhand Society of Anesthesiologists for the next, from today to next conference. So now I request our treasurer Dr. Neelam Sinha madam to come over the dais for the vote of thanks, and after that immediately we will have the we will start the valedictory function immediately.
अब हम लोग एजीएम के मीटिंग के अंत में आ रहे हैं. और ये थोड़ा कठिन काम है वोट ऑफ थैंक्स देना। सबसे पहले ये कॉन्फ्रेंस इतना अच्छा था, इतना सक्सेसफुल था, कहीं कोई हिच नहीं था। It was a flawless conference, and thanks to the organizing committee, Dr. Vijendra Prasad sir, Dr. B.K. Prasad sir, under the guidance of our GC member, Dr. Manoj Kumar, reception committee chairman, Dr. Ajay, Dr. Abhishek, Dr. Prashant, Dr. Vishal, Dr. Neeraj, Dr. Nitin, Dr. Motilal, कितने भी नाम लिए जाए कम है। इन सबके हेल्प से ही ये कॉन्फ्रेंस इतना सक्सेसफुल हुआ है। We are very much thankful to all our senior patrons जो इतनी तकलीफ और इतनी कष्ट से यहाँ आए हैं और उन लोगों ने पूरा समय दिया, एंड उनके रहने से एक आशीर्वाद मिलता है एंड कॉन्फ्रेंस बहुत सक्सेसफुल होता है। जितने लोगों ने इसमें प्रेजेंट किया पेपर, और चाहे सीनियर मेंबर्स ने, फैकल्टीज ने या हमारे पीजी स्टूडेंट्स ने, द लेवल ऑफ प्रेजेंटेशन वाज टू हाई। ये देख के लगता है कि हमारा जो प्रेजेंटेशन लेवल अभी है ये नेशनल, इट इज एट पार विथ नेशनल, एंड हम कोशिश यही करते हैं कि हमारे जो पीजी स्टूडेंट है हमेशा नेशनल लेवल पे जाएं और वहां से अवार्ड लेकर आए। स्पेशल थैंक्स टू दी होटल मैनेजमेंट ऑफ मौर्या होटल, जिनके इतने अच्छे अरेंजमेंट एंड सपोर्ट के बिना ये कॉन्फ्रेंस पॉसिबल नहीं था। थैंक यू टू द प्रिंट मीडिया जिन्होंने इसको वाइड पब्लिसिटी दी एंड सारे लोगों को पता चला कि एनेस्थेटिस्ट भी एग्जिस्ट करते हैं। महामहिम आए थे हमारे इनॉग्रेशन के लिए और उन्होंने भी एनेस्थेटिस्ट लोगों की बहुत तारीफ की, हमारे कार्य की सराहना की। सो थैंक यू टू द एंटायर टीम, थैंक यू टू आवर सेक्रेटरी डॉक्टर शरद कुमार हु इज ऑलवेज आफ्टर मी। मैडम ये कर लीजिए मैडम वो कर लीजिए, बिल्कुल बैठने नहीं देते हैं। एंड जो बड़ी रिस्पॉन्सिबिलिटी हम लोग को मिली है 2024 नेशनल कॉन्फ्रेंस का, जरूर हम लोग उसको बहुत अच्छे से करेंगे, पूरे सपोर्ट के साथ करेंगे एंड वी विल मेक इट अ ग्रैंड सक्सेस। लॉन्ग लिव ISA।
So now the meeting, the AGM is adjourned with the permission of President. Thank you, sir. We can close. So officially the GBM is closed. Now we will start honoring our respected seniors and valedictory followed by immediately. I request all the members who are outside the hall, please come. And I give the mic to Dr. Sukesh Kumar to take over the proceeding further.
थैंक यू शरद बॉस। वक्त बहुत ज़्यादा जाहिर हो चुका है, इसलिए मैं ऑन द डाइस एंड ऑफ द डाइस सब लोगों को एक साथ प्रणाम करता हूँ। स्पेशली हमारे जितने सीनियर मेंबर्स हैं, यूजुअली मैं उन्हें स्टालवर्ड्स ऑफ एनेस्थीसिया कहता हूँ, तो उनको कोटि कोटि नमन है मेरा, क्योंकि वो बहुत कष्ट करके यहाँ आए हैं। सबको मेरा प्रणाम। तो मैं असिस्टेंस लूंगा अपने सहयोगी डॉक्टर विशाल वैभव का फेलिसिटेशन प्रोग्राम के लिए। विशाल लिस्ट करो चेयर लग से पहले बोलो। हाँ, सबसे पहले एसके वर्मा सर, एसके वर्मा सर। मेरा हमेशा से ड्रीम रहा था, जब से मैं एनेस्थीसिया में आया हूँ, कि पटना में एक कॉन्फ्रेंस हो एनेस्थीसिया का, वो भी होटल मौर्या में हो, और मैं अपने सारे सीनियर्स को फेलिसिटेट करूं। आज वो सपना सच होता दिख रहा है। तो फेलिसिटेशन प्रोग्राम में सबसे पहले मैं डॉक्टर एसके वर्मा सर को निमंत्रित करना चाहता हूं। सर को पहले, और उन्हें फेलिसिटेट करेंगे हमारे जीसी मेंबर डॉक्टर मनोज कुमार सर। डॉक्टर मनोज सर, उधर से आगे से सर, आगे से। सॉल प्रशांत, सॉल खोल के देना है, उड़ाना है। सॉल एक बार उठाना है, खोल के उठाना है। हाँ ठीक, हाँ ठीक, भर जाएगा बस। ये सब सड़क घुसने के लिए तैयार। साथ में दोनों आदमी मिलकर कर लेंगे ना।
डॉक्टर एसपी सिंह
सो हटेंगे तब ना। डॉक्टर एसपी सिंह सर, जिन्होंने हमारे डिपार्टमेंट को काफी ऊंचाई तक पहुंचाया है। सर हमारे वीसी भी रह चुके हैं AKU के। कौन मनोज
सर
डॉक्टर मनोज कुमार सर। तीसरा कौन है? तो हम जाएंगे।
अब मैं आमंत्रित करना चाहूंगा डॉक्टर अरुण कुमार सर। डॉक्टर अरुण कुमार सर, जिनको सम्मानित करने के लिए मैं आग्रह करूंगा डॉक्टर बीके प्रसाद सर। डॉक्टर बीके प्रसाद सर। इसके बाद मैं कॉल करूंगा डॉक्टर मेनुका वर्मा मैम।
सोसाइटी का नाम लीजिए।
डॉक्टर मेनुका वर्मा मैम। डॉक्टर शरद सर प्लीज मैम को सम्मानित करें।
मारते जाओ जो हो गया।
मारते जा रहा है। ऑर्डर से चल रहा है। इसके SS शर्मा सर। इसके बाद मैं आमंत्रित करना चाहूंगा डॉक्टर SS शर्मा सर। डॉक्टर SS शर्मा सर प्लीज आ जाइए। और इसके लिए मैं आमंत्रित करूंगा डॉक्टर अजय कुमार सर। सर को सम्मानित करें सर। कृपया तालियों से स्वागत कीजिए। इसके बाद मैं आमंत्रित करूंगा डॉक्टर जगन्नाथ प्रसाद सर। और मैं अनुरोध करूंगा डॉक्टर रंजीत कुमार सर से। सर प्लीज सम्मानित करें सर को। सर दोस्तों की है। सब आएंगे लाइन से। डॉक्टर अजीत कुमार सर, इसके बाद मैं आमंत्रित करूंगा डॉक्टर अजीत कुमार सर यहाँ चलो। और सर को सम्मानित करने के लिए मैं पटना सोसाइटी से कुछ यंग लोगों को बुलाना चाहूंगा। डॉक्टर नीरज कुमार। डॉक्टर नीरज कुमार ज्वाइंट सेक्रेटरी।
अब मैं आमंत्रित करता हूं डॉक्टर A.K. वात्सायन सर को। सर आप भी आएंगे सर? सर जी सर। सर जब जब टाइम कॉन्स्टेंट्स होता है लोग मुझे चढ़ा देते हैं स्टेज पर, और मैं इसके लिए अनुरोध करूंगा डॉक्टर सुखेश कुमार सर, प्लीज सर को सम्मानित करें। अब मैं आमंत्रित करूंगा डॉक्टर बैजनाथ प्रसाद सर। डॉक्टर बैजनाथ प्रसाद सर, और इसके लिए मैं आमंत्रित करूंगा डॉक्टर अभिषेक बासुकी, जीसी बिहार झारखंड सोसाइटी।
Now I will like to request B.K. Sinha sir. B.K. Sinha sir, please. और इसके लिए मैं विशाल वैभव को बुलाना चाहूंगा। विशाल सर को शॉल लाए और एक मोमेंटो से सर को और सर से आशीर्वाद लें। बहुत बहुत धन्यवाद सर। B.K. सिन्हा सर। हाँ, अब मैं G.K. सिन्हा सर को बुलाना चाहूंगा। G.K. सिन्हा सर। G.K. सिन्हा सर।
मैं चाहूंगा कि डॉक्टर जी.के. सिन्हा सर का जोरदार तालियों से स्वागत हो। उन्होंने हमारे डिपार्टमेंट को बहुत ऊंचाई तक पहुंचाया है और वो ISA के नेशनल प्रेसिडेंट भी रह चुके हैं।
इसके लिए मैं प्रशांत को बुलाना चाहूंगा। प्रशांत आप प्लीज G.K. सिन्हा सर को फेलिसिटेट करें शॉल और मेमेंटो से।
इसके बाद मैं आमंत्रित करना चाहूंगा डॉक्टर विजय कुमार मंगलम सर। सर प्लीज आइए, और सर को सम्मानित करने के लिए मैं आमंत्रित करूंगा डॉक्टर नितिन
कुमार ओझा।
डॉक्टर नितिन कुमार ओझा। अभ्युदय था, ठीक है, इसमें उल्टा हो गया ना, कोई बात नहीं।
बस हमारा सिटी ब्रांच का फेलिसिटेशन है। सिटी ब्रांच का भी सब बुरेगा तब ना, सब तो यहाँ खड़ा करते हैं अपने इसको, सबको उनका नाम कौन है सब
इसके बाद मैं आमंत्रित करूंगा डॉक्टर बलराम प्रसाद सर। डॉक्टर बलराम सर प्लीज आइए, और मैं अनुरोध करूंगा डॉक्टर अभ्युदय से सर को आके सम्मानित करें। ज्यादा हुआ।
अब तक कोरोना मर गया सर।
और कोई बचा है? और कोई? अब मैं आमंत्रित करना चाहूंगा डॉक्टर A.M. शर्मा सर। डॉक्टर A.M. शर्मा सर।
इसके बाद
नहीं, अच्छा, देन अब इसके बाद मैं आमंत्रित करता हूं डॉक्टर नलिनी रंजन प्रसाद। डॉक्टर नलिनी रंजन प्रसाद नहीं है, तो मैं आमंत्रित करना चाहूंगा डॉक्टर एनके लाल सर। डॉक्टर एनके लाल सर। डॉक्टर एनके लाल भी नहीं है सर, अगर आप हैं तो सर आए प्लीज। इसके बाद मैं आमंत्रित करता हूं डॉक्टर महीप कुमार गुप्ता सर को। डॉक्टर महीप कुमार गुप्ता सर। और इसके लिए मैं आमंत्रित करूंगा डॉक्टर मोती सर। डॉक्टर मोतीलाल दास सर, सर को सम्मानित करें प्लीज। मैं अपने आदरणीय सीनियर सर से अनुरोध करूंगा कि एक बार प्लीज सब लोग मंच पे आए एक ग्रुप फोटो के लिए, या अर्थात यहाँ नीचे तक ही कम से कम, मंच पे चढ़ने में हो सकता है दिक्कत हो, लेकिन हम लोग सर के आशीर्वाद स्वरूप एक ग्रुप फोटो चाहते हैं।
There is an important announcement. एक मिनट आप लोग सब गौर करना चाहेंगे। एक इम्पोर्टेंट, अजीत सर एक सेकंड, विके सर एक सेकंड, एक इम्पोर्टेंट अनाउंसमेंट है। एक नया अवार्ड, लाइफ टाइम अचीवमेंट अवार्ड, वी आर गोइंग टू स्टार्ट फ्रॉम द नेक्स्ट ईयर। रांची से जो हमारे स्टॉलवर्ड रहे हैं, जिन्होंने अपनी जिंदगी का सबसे बहुमूल्य समय सोसाइटी के लिए दिया है, एक नई शुरुआत होनी चाहिए। ये नया इंडिया है, कुछ ना कुछ नया होते रहना चाहिए। अपने पुराने लोगों को ऑनर करना सीखो। जब तक हम पुराने लोगों को ऑनर सही समय पे सही जगह नहीं करेंगे, सोसाइटी कभी नहीं बढ़ेगी। तो ये बहुत अच्छा सजेशन आया है, इसको हम लोग नेक्स्ट टाइम से इंप्लीमेंट करेंगे। मैडम नीलम, इसको प्लीज एजीएम के पॉइंट में लिख लीजिए। सॉरी देर से आया। तो प्रपोज कर रहा कोई? कौन प्रपोज? अजीत सर प्रपोज कर रहे हैं लाइफ टाइम अचीवमेंट अवार्ड, प्रपोज बाय डॉक्टर अजीत कुमार, सेकंड बाय डॉक्टर डीके सिंह, डॉक्टर मोतीलाल एंड डॉक्टर बीके प्रसाद। प्लीज इसको नोट कर लीजिए, ये बहुत बड़ा अवार्ड होगा। We will do something big for this award, right? Okay, House is pass कर रहा है इसको। सर लाइफ टाइम अवार्ड के चक्कर में स्टेज ना टूट जाए।
Thank you very much. I request now to please take your seats, respective seats. Please take all dignitaries, take your respective seats. Postgraduate students, it's now your time. And now I would like to announce the winners for various sections in the awards. To start with, I'll be announcing, in fact, you can see the display. The first is the East Zone Inter-College winners. The first is Dr. Neeraj. Please come up. Collect your cash prize. Dr. Neeraj from IKMS, collect your cash prize as the first winner of the show for quiz. Dr. Sharad sir, please hand over the prize to Dr. Neeraj. Cash prize to Dr. Neeraj James. Cash prize of 5,000. IGMS, Dr. Neeraj. And sir, Neeraj IGMS. He is Neeraj from IGMS. IGMS Patna. Lot many Neerajas are there. Dr. Neeraj IGMS Patna. First prize quiz. Next, I would like to invite Dr. Jitendra Kumar. He is the second winner of the prize. And he is going to collect Inter-College Quiz winner prize. Second prize goes to Dr. Neeraj from IJMS. So IJMS has rocked in the quiz competition. Big round of applause for IJMS. Quiz 3,000 rupees cash. Yes. अभी अच्छी रकम मिल रही है लोगों को cash prize में. And then Dr. Surati from AIMS Patna, third prize winner for the quiz competition. Dr. Survi from AIMS Patna, 2,000 rupees cash, certificate थोड़ी देर बाद मिलेगा. So now I would like to invite Dr. B.K. Prasad sir to please come up for the Dr. B.K. Prasad award. And the winners are, this is for the Ashok Gupta. I want the Dr. B.K. Prasad award. Next slide. Yeah. B.K. Prasad award. Private practitioner. For the private practitioner award for. Okay, fine. So Dr. Abhinav Prakash from Medanta Hospital is the winner for Dr. Dr. Rajesh Jha from Samastipur is the second winner. Please come up. He is going to receive a medal. First medal for this has been given to Dr. Abhinav. That is good enough. It's very nice. Yes, yes. Okay, and Dr. Rajesh Jha from Samastipur is the second. Dr. Sanjeev Kumar from Paras Hospital is the third. He will be getting certificate, sir. Certificate, sir. He will get the certificate, but please medal is only for the first prize winner. Other will get the certificate. Third prize goes to Dr. Sanjeev. Dr. Sanjeev is here. Okay, fine. So we'll move on quickly on to Dr. Ashok Gupta Young and Statist Award. Yes, Dr. Ashok Gupta Young and Statist Award. And the first prize goes to Dr. Chandrakant Prasad, Vedanta Patna. Dr. Chandrakant Prasad. And I would like to invite Dr. Sukesh, sir, the organizing secretary, to give the award. Yes. Dr. Chandrakant Prasad is going to receive the medal for the winner for Dr. Ashok Gupta Award. Dr. Manisha from IGMS Patna, come up to receive the prize award. In fact, last time she has received the third prize award. She has selected herself up to the second prize. So, Dr. Manisha, you are receiving the certificate. And now I'd like to call Dr. Ritika, yes, Dr. Ritika from IIMS Patna, please come up to receive the third prize award. She is the third prize winner. She's not here. Okay, she has left. Unke behalf pe koi le lo from IIMS Patna. Otherwise, there are plenty of people from IIMS Patna. I can hand over to Dr. Neeraj standing beside. Okay, there is somebody to take. So Dr. Sukesh is presenting the third prize to Dr. Ritika. Thank you. And finally, we come up to the late Dr. T.N. Jha Memorial Travel Grant Award. And for this, I would like to late Dr. T.N. Jha and Dr. K.P. Chansoria Travel Grant Award. Oh, yes, yes. Late Dr. T.N. Jha and Dr. K.P. Chansoria Travel Grant Award. Okay. And for this, I would like to call upon Dr. Vijendra Prashant, sir. Sir, please come up to give the awards. The winner is, this is for the e-poster. I am announcing about the Dr. T.N. Jha Award. Last May? Okay, the T.N. Jha will be in the last. So e-poster, the winner is Arunima Patnaik from IIMS Patna. Second is Dr. Suriti from IIMS Patna. So IIMS Patna has led the e-poster competition. Two continuous winners. Second prize. Swarnika Singh. And the third prize goes to Dr. Swarnika Singh, IGMS. Dr. Swarnika Singh is she here? Okay, just somebody collect the certificate on her behalf. Finally, I would like to call upon Dr. D.K. Singh sir as well as our GC member national Dr. Manoj Kumar sir for giving the honorable late Dr. T.N. Jha and Dr. K.P. Chansoria Travel Grant Award. And I want the winners to be displayed, and the winners are Dr. Arunima Patnaik again from IIMS Patna. So she will be receiving a certificate.
She was mind-blowing.
Okay, e-certificate will be given to her. She will be getting a printed e-certificate. E-certificate, yes, sir. Sir. Okay.
And he will be representing Bihar.
She will be representing Bihar, in fact, the state in a national conference at Ahmedabad. The second person In fact, the second winner is Dr. Surabhi Srivastava, TMH Jamshedpur.
Tata Motors Jamshedpur.
Okay, it is Tata Motors Jamshedpur. I won't say TMH Jamshedpur.
Don't say TMH Jamshedpur. Very
I can understand, ma'am.
टाटा मोटर्स पिछले 4 बार में 3 बार निकला था सर, इस बार कैसे रुक गया आपको पता नहीं आ रहा है.
And Dr. Neelam ma'am, were you the guide of her?
Yes.
Okay, that's why I understood why Tata Motors has to be emphasized. Okay, fine. And then I would like to call upon Dr. Priyanka Mahapantra. She is the third prize winner of the TNJHA award. She is from ITM Patna.
One announcement, you will be representing Bihar and Jharkhand in the national conference for the poster. So start preparing from now onwards.
Yes.
So having done all with the postgraduate students, now I'd like to invite Dr. Manoj Kumar sir for the felicitation. Sir Manoj Kumar sir, आपको felicitate करना है. For this, the organizing secretary of the East Zone Conference, Dr. Sukesh Kumar sir, please come up to felicitate our GC National. Sukesh sir, Dr. Sukesh sir, you want to felicitate Dr. Manoj Kumar sir, our GC member National. From the PSA. I would request all the members of the Patna Society of Anesthesiologists to come up. When you are honoring somebody, please be there.
I request our Patna branch member executive at least come here.
Now I would like to invite our chief patron, Dr. P.K. Singh sir. Is he here? I don't think so. Okay. अब मैं सम्मानित करना चाहूंगा अपने कॉन्फ्रेंस के पैट्रॉन्स को. Sir, is he here? I don't think so. Okay. Dr. B.K. Kashyap, HOD Anesthesia PMCH Patna. हमारे इस कॉन्फ्रेंस के पैट्रोन और ऑर्गेनाइजिंग चेयरमैन डॉक्टर उमेश कुमार बलानी सर.
अब मैं सम्मानित करना चाहूंगा हमारे कॉन्फ्रेंस के चीफ पैट्रन डॉक्टर पी.के. सिंह सर। डॉक्टर अशोक कुमार सर, पैट्रन है उनका रिसीव करेंगे डॉक्टर गुरु प्रसाद सर। अब मैं सम्मानित करना चाहूंगा डॉक्टर ब्रजकिशोर प्रसाद सर को, जो प्रेसिडेंट, इमीडिएट पास्ट प्रेसिडेंट, जस्ट पास्ट प्रेसिडेंट BJSA and chairman of Sumeri committee, my mentor and my mentor. अब मैं सम्मानित करना चाहूंगा डॉक्टर शरद कुमार सर को, जो सेक्रेटरी बिहार झारखंड सोसाइटी ऑफ एनेस्थेसियोलॉजिस्ट है। डॉक्टर पी.के. प्रसाद सर, आप प्लीज सम्मानित कर दें सर। अब मैं सम्मानित करना चाहूंगा इस कॉन्फ्रेंस के को-ऑर्गेनाइजिंग सेक्रेटरी, को-ऑर्गेनाइजिंग चेयरमैन सॉरी, डॉक्टर विजेंद्र प्रसाद सर, जो हमारे प्रेसिडेंट भी हैं पटना शहर, और उनको सम्मानित करेंगे डॉक्टर अजय कुमार सर। Next in queue is Dr. Neelam Sinha ma'am, President BJSA, और उन्हें सम्मानित करेंगे डॉक्टर नितिन ओझा। Next in queue is Dr. प्रकाश कुमार दुबे, जो साइंटिफिक चेयरमैन थे इस कॉन्फ्रेंस के, जिन्होंने अपनी कड़ी मेहनत से इस कॉन्फ्रेंस के साइंटिफिक प्रोग्राम को संजोया है और अच्छे से आप इसको लर्न किए हैं। साइंटिफिक प्रोग्राम को शायद सर नहीं है, उनका रिसीव करेंगे HMS से डॉक्टर नीरज। थैंक यू प्रकाश सर। Now I'd like to invite Dr. Sukesh Kumar sir. In fact, I must tell that Dr. Sukesh Kumar sir, organizing secretary. We all should felicitate him because he last even hours of so many family issues. He has come up and he has organized the conference so well. Thank you, Dr. Sukesh Kumar. You are being felicitated by so many personalities, not just one. Now I'd like to call upon Dr. Neeraj Kumar. Dr. Neeraj from AIIMS Patna. And for this, I would like to call upon Dr. Sudama sir. Dr. Sudama sir. Please felicitate Dr. Neeraj. Now I'd like to
felicitation. And this has to be done by none other than our Dr. Prashant. Another one GC member presenting to the other GC member. Now the situation has to be reversed, and I would like to invite again Dr. Abhishek Vasuki to felicitate Dr. Prashant, the other GC member. Sir, थोड़ा सा राइट लेफ्ट का कंफ्यूजन जो है वो फोटो में सॉल्व हो रहा है। अब पता चल रहा है सर, रिवर्स है। Expert is micromanagement. Now it's the turn to invite our honorable president, Dr. H.K. Jha sir. Dr. H.K. Jha sir, please come up. Okay, somebody from NMC to proceed. And Dr. Nitin is going to receive on behalf of Dr. H.K. Jha sir. Please come up properly, and Dr. Sharad is presenting the memento on behalf of Dr. H.K. Jha sir. Now it's the turn for to be felicitated is Dr. Ajay Kumar sir. He will be felicitated by Dr. Vijendra Prasad sir. There should be no confusion who is being felicitated and who is the felicitator. Now I request Dr. M.L. Das sir, Motilal Das sir, Motilal Das sir. So now you should be familiar that his other name is also M.L. Das sir. I understand. And Dr. Manu sir, please felicitate him. Thank you so much sir. Now I call Dr. Vishal Vaibhav, Scientific Secretary. I call Manoj sir to please felicitate him.
Great job.
डेटा की तरफ बढ़ गया है।
I call Dr. Vijay Kumar from AIMS. I will ask Dr. Sharad sir to please.
Now I'd like to a big round of applause for Dr. Abhyuday, our scientific secretary. He is the man behind conduction of all the quiz, which was really very interesting session, and lot many work has been done by him for the abstracts, posters, and everything. And I would like to now felicitate Dr. Ranjit Kumar sir. Dr. Ranjit Kumar sir. And for this, in order to felicitate him, we have our GC member national Dr. Manoj Kumar sir. Please felicitate Dr. Ranjit sir. And now I'd like to invite Dr. Sudama Prasad sir. And in order to felicitate him, we have almost everybody from PSA. सर आप फोटो खींचना छोड़ के सर आगे आ जाइए। आपको लेना है सर, आपको फेलिसिटेट किया जा रहा है सर, प्लीज कम अप।
Dr. Sudama Prasad was the chairman of the Transport and Accommodation Committee. On behalf of that, he is receiving this award.
कोई गाली नहीं कर सके।
गाड़ी खास कर
बिना गाड़ी का कैसे हुआ है? ले भाई जल्दी से।
Okay.
जल्दी।
Now this is a turn for the workshop coordinators. All our 5 workshops were a mega hit. So first of all, I would like to Dr. Jitesh Kumar from PMCH Critical Care Nursing Workshop. इन्होंने बहुत ही अच्छे तरीके से मैनेज किया है डॉक्टर प्रशांत के साथ मिलके। और मैं बता दूं इसमें 150 कैंडिडेट हमको मिले थे, 50-60 को हमको लौटाना पड़ गया। दूसरे डॉक्टर आलोक कुमार भारती IGMS से, जिन्होंने सिमुलेटर एनेस्थेसियोलॉजी वर्कशॉप कराया था वहां पे। Dr. Neeraj will receive the award for Dr. Alok Kumar Bharti and also for Dr. Shwati, who is additional professor at IGMS. Next one is Dr. Ajit Kumar from AIMS. I think he is not here. He has some health issues. Somebody from AIMS should receive this award. Dr. Abhyuday and Dr. Neeraj will receive the award for Dr. Ajit Kumar and Dr. Kunal Kumar Singh. They have done excellent work. Chronic pain workshop and hemodynamic monitoring workshop. Then Dr. Nitin Oza from NMCH and Dr. Kishore Tunjulwala from NMCH. I think Dr. Nitin Oza will receive both the awards because Dr. Kishore Tunjulwala is not right here. Dr. Nagina Chaudhary sir, if you are here, then please come. We also have some award for you. Dr. Prasad will give the award to Dr. Nagina Chaudhary sir, who is HOD of Anesthesiology in Madhepura Medical College. Dr. Rakesh Kumar Singh sir, who is from Katihar Medical College. Dr. Vishal Mehra will present this award to Dr. Rakesh Singh sir. Thank you sir. Thank you for delivering your speech and coming to attend our conference. Dr. Gurmukh Prasad sir. Dr. Gurmukh Prasad sir. अगर आप मेरी आवाज सुन रहे हैं तो प्लीज आए। Now I would like to give award for our newly elected President of Bihar Jharkhand Society of Anesthesiology. And Dr. Ajay Kumar will present this award to Dr. D.K. Singh sir. Congratulations sir for holding the new post. And we are elated that you will do the justice with your post in coming next year. Thank you, sir. किसी भी कॉन्फ्रेंस की अच्छाई और बुराई दोनों होती है। अब हाउस में जितने भी लोग बचे हैं इसके पक्ष में या विपक्ष में बोल सकते हैं। अच्छा हुआ, बुरा हुआ, और फीडबैक ऑर्गेनाइजिंग कमेटी को भी मिलना चाहिए।
हेलो, ये कॉन्फ्रेंस 2019 में ही डिसाइड हो गया था। ऐसे 20 जोन के इसमें प्लस बोकारो कॉन्फ्रेंस में ऐसे दिया जाता है। और इसमें डॉक्टर सुकेश, डॉक्टर बदानी सब लोग प्रेजेंट थे, हम लोग थे। तो मुझे एज ए मेंबर ऑफ पटना सोसाइटी एनेस्थेसियोलॉजी मुझे काफी खुशी हुई। दरभंगा को जा रहा था लेकिन दरभंगा मना कर दिया, तो ऑटोमेटिक डिफॉल्ट में पटना सोसाइटी के पास आ गए। तो जोनल कॉन्फ्रेंस था, लगा कि काफी टाइम है, लेकिन अनफॉर्चुनेटली कोविड आ गया 2020 में, तो हम लोग उस साल ऑनलाइन से ही कॉन्फ्रेंस किए, जैसा कि आप लोग देखे ही होंगे। इसके बाद 2021 में थोड़ा लेट रिस्पांस हुआ हमारे ऑर्गेनाइजिंग चेयरमैन डॉक्टर बदानी सर से। कॉन्फ्रेंस ऑर्गेनाइज नहीं हो पा रहा था, तो डॉक्टर शरद को मैंने बताया कि कॉन्फ्रेंस का जो है सभी क्या स्टेटस है, तो सभी तरफ से कोई जवाब नहीं मिला। तो मेरे अथक प्रयास से बीके प्रसाद सर को भी बोले, शरद बोस को भी बोले, ऑर्गेनाइजिंग चेयरमैन डॉक्टर सुकेश, ऑर्गेनाइजिंग सेक्रेटरी को भी बताए, तो उन्होंने बोला कि कुछ आप लोग मीटिंग कीजिए। तो मैंने मीटिंग करवाया। मीटिंग में धीरे धीरे पहले स्टेट का हुआ, स्टेट से एक्टिवेट होके फिर पटना सोसाइटी ब्रांच का मीटिंग हुआ। हमको लगता है 1.5 से 2 महीना पहले हुआ है। और मैं सुकेश एंड हिज टीम, तो एग्जीक्यूटिव बॉडी ऑफ द आयसाकॉन बिहार झारखंड एंड आयसाकॉन ईस्ट जोन कॉन्फ्रेंस का जो भी एग्जीक्यूटिव बॉडी था थे, सभी लोग ने बहुत ही कम समय में, ये हिस्ट्री है ऐसा इस जोन और स्टेट कॉन्फ्रेंस का, कि इतने कम समय में इतने बेहतरीन ढंग से कॉन्फ्रेंस हुआ। मैं हार्टिएस्ट कांग्रेचुलेशन सुकेश और ऑर्गेनाइजिंग चेयरमैन डॉक्टर विजेंद्र सर को, और ये इनके चेयरमैनशिप प्लस एज ए प्रेसिडेंटशिप पटना सोसाइटी के लिए भी इनको थोड़ा सा चाहेंगे कि खड़ा होके एक बार सर के लिए ताली बजा दीजिए। और ये जो लीडरशिप है इसमें हमारा, चूंकि बिहार झारखंड का ये कॉन्फ्रेंस था, हम चाहेंगे बीके प्रसाद सर के लिए, जिन्होंने इनके गार्जियनशिप में हम लोग किए सर। एक बार मैं बोलना चाहूंगा शरद, डॉक्टर शरद जो है सो कंटिन्यूअस, और ये लग ही नहीं रहा था कि ऑर्गेनाइजिंग के बाहर है, ये तो ऑर्गेनाइजिंग में है ही, प्लस यहाँ आने के बाद भी जिस तरह से 24 घंटा काम किए, हम लोग कल जाके 3 बजे रात में सोए कि आज क्या होना है, नेशनल कॉन्फ्रेंस कैसे आएगा, तो सारा हम लोग लाइनअप किए। तो मैं डॉक्टर शरद, डॉक्टर अजय का बहुत बहुत धन्यवाद। इसमें डॉक्टर सुकेश के साथ अनफॉर्चुनेट ये हुआ, उसके लिए सॉरी है। हम लोग रेस्ट ऑफ पीस करने की माता जी का देहांत हो गया, लेकिन उन्होंने जो ऊपर से आशीर्वाद दिया, बेटा जाओ, तुम्हारा टीम जो है एक बहुत ही टैलेंटेड टीम है। और उनके कुछ दिन नहीं रहने के बाद भी इवन एज ए जीसी मेंबर मैं भी आके ऑर्गेनाइजिंग में काम किया, कुछ काम मुझे भी मिला था तो मैं किया। और उसके मेन सूत्रधार डॉक्टर अजय हैं, रिसेप्शन कमेटी के चेयरमैन। आज जो देख रहे थे गवर्नर आए, सब कुछ डॉक्टर अजय किए, और बहुत सा चीज में डॉक्टर अजय का बहुत, डॉक्टर प्रशांत, डॉक्टर जितेश, डॉक्टर अभिषेक वासवी, डॉक्टर रंजीत, डॉक्टर नितिन, हम सुदामा सर, मोतीलाल सर, इन्होंने इतना काम किया। और लास्ट नॉट द लीस्ट हमारी ट्रेजर, एक डायनेमिक लेडी, जिन्होंने दिखा दिया कि आने वाले दिनों में हम कैंडिडेट हैं प्रेसिडेंट बिहार झारखंड, सेक्रेटरी बिहार झारखंड और नेशनल के लिए। एक बार मैडम को मैं बुलाना चाहूंगा, मैडम का ताली बनता है। इन्होंने कंटिन्यू सोसाइटी के लिए काम किया। प्लस थैंक यू वेरी मच टू ऑल डेलीगेट्स, ऑल पीजी स्टूडेंट, और जो भी किसी का नाम छूट गया उसके लिए क्षमा प्रार्थी है। और लास्ट मैं सुकेश का बहुत आभार व्यक्त करता हूँ कि ले लिए प्रशांत और ट्रेजरर प्रशांत दोनों मिलके और उनकी टीम मिलके जिस तरह से काम किया। जितेश, प्रशांत, विशाल का नाम छूट गया, सॉरी। विशाल तो कंटिन्यू बोलते रहा और उसमें वो कलीवर था। और हम लोग इस बार जो टीम को चुन के जो सेक्शन में दिए, उन्होंने उतना टैलेंट के साथ काम किया। तो मैं आईएसए नेशनल से सभी का मंगल भविष्य का कामना करता हूँ। धन्यवाद।
धन्यवाद मनोज बॉस। मैं खास शुक्रिया अदा करना चाहता हूँ डॉक्टर मनोज कुमार सर का, जो नेशनल जीसी मेंबर है और इस कॉन्फ्रेंस के चीफ एडवाइजर एंड गेस्ट ऑफ ऑनर भी रहे हैं, जिन्होंने बहुमूल्य समय दिया इस कॉन्फ्रेंस को कोऑर्डिनेट करने में, और अब इसका समापन भी हो रहा है। थैंक यू मनोज बॉस फ्रॉम द कोर ऑफ माय हार्ट। मैं शुक्रिया अदा करना चाहूंगा लोग लाइव ऐसे, मैं शुक्रिया अदा करना चाहूंगा अपने स्टेट टीम का, डॉक्टर बीके प्रसाद सर, जो जस्ट अभी अपने प्रेसिडेंट का पोस्ट लीव करके पास्ट में गए हैं। मैं शुक्रिया अदा करना चाहूंगा डॉक्टर शरद कुमार सर का, जो डायनामिक सेक्रेटरी है हमारे विजय के। नए प्रेसिडेंट डॉक्टर डीके सिन्हा सर का, डॉक्टर नीलम सिन्हा मैडम का। उसके बाद में अपने साइंटिफिक चेयरमैन डॉक्टर प्रकाश कुमार दुबे का, जो सर नहीं है, उन्होंने बहुत अच्छे से, मेरा मानना है कि साइंटिफिक प्रोग्राम को फ्रेम किया और अच्छे स्पीकर्स को कॉल करके प्रोग्राम को सफल बनाया। मैं खासकर अपने दोनों साइंटिफिक सेक्रेटरी डॉक्टर विशाल वेबर और डॉक्टर अभ्युदय कुमार का तहे दिल से थैंक यू कहता हूँ कि आप लोग दोनों ने दिन रात मेहनत करके सब, ऑनलाइन है, कोई ऑनलाइन है, कोई फिजिकल प्रेजेंट कर रहे हैं, उनको लिंक भेजना है, उनसे सीवी लेना है, कितना पेनफुल रहा होगा। कोई अरेंज करेंगे तो ज्यादा अच्छा से समझ में आएगा, बिना अरेंज के उतना समझ में नहीं आएगा। तो इन दोनों हमारे साइंटिफिक सेक्रेटरी का खास शुक्रिया अदा करना चाहता हूँ। उसके बाद मैं डॉक्टर प्रशांत, जो कहने को तो फाइनेंस सेक्रेटरी पोस्ट मिला था उनको, जीसी मेंबर भी हैं विजय के, लेकिन वो हर जगह प्रेजेंट है, हर जगह पे 3 बजे रात में हमको मैसेज करते थे कि सर ये वाला देख लीजिए, ये वाला प्लान रेडी है, और इनके लिए तो खास करके भी हम नोट चाहते हैं। अनटायर्ड में देखने में थोड़ा हेल्दी रहते हैं, लेकिन बहुत फिट है। तो बैग देखे डिपार्टमेंट लगता है कि आज फिर मैं शुक्रिया अदा करना चाहता हूँ अपने जीसी मेंबर डॉक्टर जितेश का, खास करके जिन्होंने वर्कशॉप को बहुत अच्छे से कोऑर्डिनेट किया और हमारे रजिस्ट्रेशन डेस्क को 2 दिन फुल टाइम उन्होंने देकर, मैं देख नहीं पा रहा हूँ जितेश है कि, थैंक यू जितेश, थैंक यू जितेश। मैं शुक्रिया अदा करना चाहता हूँ डॉक्टर नीरज, जो हमारे ज्वाइंट सेक्रेटरी हैं, बहुत बड़ा योगदान है। सबसे पहले तो रेवेन्यू मैनेजमेंट में डॉक्टर बासुकी और डॉक्टर नीरज, जो दोनों हमारे ज्वाइंट ऑर्गेनाइज सेक्रेटरी हैं, इनका खास तौर पे मैं शुक्रिया अदा करना। नीरज उसके बाद मैं शुक्रिया अदा करना चाहता हूँ डॉक्टर रंजीत का, जो हमारे वाइस प्रेसिडेंट जस्ट पास्ट हुए हैं 16 अक्टूबर को। नए वाइस प्रेसिडेंट डॉक्टर रजनीश का, जो हमारे सोसाइटी के हैं। सबसे खास कर डॉक्टर अजय कुमार बॉस, सबसे खास डॉक्टर अजय कुमार बॉस। अल्टीमेटली कहिए, जब मेरी मदर का देहांत हो गया तो मैं उसमें बिजी हो गया। डॉक्टर अजय बॉस ने इसको सारा संजोया है। मैं तो वापस फिर 20 को शाम में लौट पाया हूँ, तो सारा करता धरता मेरे बाद अजय ही बॉस, उन्हीं का सारा प्रेम किया हुआ है, तो ये प्रोग्राम सफल हो पाया हमारा अजय बॉस। इसी तरह से अजय बॉस को हम लोगों को सपोर्ट करना है नेशनल के लिए। मैं खासकर शुक्रिया अदा करना चाहता हूँ हूँ इस कॉन्फ्रेंस में जितने स्पीकर्स थे हमारे, चाहे वो ऑनलाइन प्रेजेंट किए हों, चाहे वो फिजिकल आके प्रेजेंट किए हों, टू नेम अ फ्यू, डॉक्टर द्विवेदिया सर, डॉक्टर जीपी रथ सर, डॉक्टर प्रभात तिवारी सर, डॉक्टर सतीरानंद भारती, डॉक्टर रस्तोगी सर, डॉक्टर टी समारा, जो जज भी रहे इसमें से कुछ, उनका खास तौर से शुक्रिया अदा करना चाहता हूँ। इस कॉन्फ्रेंस में जितने भी सेशंस चले उसमें जो चेयरपर्सन थे उनका, जब भी कोई कॉन्फ्रेंस होता है तो सबसे मेन चीज होता है पैसा। तो पैसा है कहाँ से, तो मैं शुक्रिया अदा करना चाहता हूँ अपने स्पॉन्सर्स का। टू नेम अ फ्यू, इट्स स्टेटमेंट, रेस्टमेंट, मेडसन, Neon, Themis, BPL, Maxmed, Avalanche, Polymed, Vahe, and many others. Thank you, sponsors, for sponsoring us to conduct this conference nicely. And last but not the least, to all the media persons who have covered this conference very nicely with all the main newspapers of Bihar and Jharkhand or national. And thanks to our audio visual team who work day and night. Today we are running all the four walls. And TNX team has worked very hard to conduct all the scientific sessions. Thank you very much. Thank you for that. So now I am thanking everyone present right here. I must have missed some names, but from core of my heart, I thank all. Thank you, and wrapping up this program. Thank you.